Yeah, yeah. Welcome one and all to this year's TCT India South Asia 2020 conference. Obviously, because of the existing situation, we are doing it in a virtual platform. A lot of new things are being tried. Hope all of you will enjoy this, and you should all excuse us for some inadequacies which is there in between. It was always my desire to have Dr. Antonio Colombo and along with our Indian senior faculty as well as US faculty like Dr. Leon and Greg Stone, everybody together. And COVID gave us a lot of troubles, but it made us possible. All the dynamic personalities, world-class faculty, everybody are there with us together to start this. I think Indians, we do have a little habit of starting a little late. People will join. So if Antonio starts this, I thought it would be the best thing for people to join in on time. I think a lot of people have joined in, sir. I am happy to inform you that there are more than 3,000 registrations which have happened. I think at one point of time, we will have any time more than 1,000 logins for this. And I'm very happy with this brief intro. I request Dr. Antonio Colombo to declare this conference open.
Thank you very much, first for having me with you, and congratulations to all the faculty and to you, Dr. Kumar, for making this meeting happen. The situation is difficult, but to keep the meeting alive is a very important commitment. So thank you to all the Indian physicians and interventionists. I would like to start with my presentation that is something a little bit provocative. I wanted to spread the message of going a step forward and utilizing stents less routinely, especially in your country. You are faced a lot with diffuse disease, and the utilization of the full metal jacket or the extensive stenting may not always be the best answer. So sir, that
we will. Sorry to interrupt you, sir. We will just have one brief prayer song. It's a customary in our country to have the conference inaugurated with a brief Ganesh Vandana prayer song, and we will have it in the flute. Hope you will enjoy it. Then we will go on to your presentation, sir. And okay. Harshika, please play that 1 minute video introductory, then the flute song. AC is on.
Whenever I'm in India, I feel the hospitality, I feel the friendship.
Nam kuru me deva sarvakaryeshu sarvada.
requested him to play it live. In this COVID times, each of us should have some different experiences. I was also trying to practice this, and that's how I requested him to join for this inaugural function. Thank you, sir. I think before we go on to the Antonio's talk, I request the chairpersons of this session, Dr. Matthew, Dr. Sinha, to say a few words and have some interaction with him before, and then we'll go to his Dr. Colombo's talk. Over to you, Dr. Matthew, sir.
Yeah, good afternoon, everybody. And I think, as Antonio said, this is a difficult time, and it's good that we are able to meet together at least in a virtual setting and exchange our ideas and newer philosophies. What's happened between last 6 months, we want to update ourselves, and this is a great opportunity. And I think this would be the right time to get started. And Antonio is the right choice to get us provoked, and he is very provocative speaker. We know for last at least 20 years he has provoked each one of us into different arenas of interventional cardiology. And let us listen to him. Welcome, Antonio, and we are all waiting to listen to you. Nakul?
Yeah. First of all, good afternoon, Dr. Colombo. I would say that's probably good morning to you and good afternoon to everybody, Dr. Matthew, Srinivas. So as everybody knows, we are distanced from each other, but I think this is one of the best platforms to be virtually connected. And I think I don't find too much of a difference in the live conference and in being connected this way. This seems to be having less of extraneous disturbances. We are more focused, and I'm sure over the next 2 days, we are going to be revising a lot of pearls and sort of having different viewpoints also. So I think this is a very good opportunity, a very good initiative that Dr. Srinivas has taken. And I wish the conference all the best. And I'm sure it's going to set a very great standard benchmark. So thank you very much.
Now we will have Dr. Antonio Colombo's talk, sir. Newer approach to treat diffuse coronary artery disease. Over to you, Dr. Antonio.
Okay. Thank you very much. Let me go to my presentation. I need to enable, can you enable my, I see host disable attendees sharing the screen. I need you to enable my screen. Otherwise, I will not be able to. I made it a little bit provocative title, a metal-free approach, including treatment of diffuse coronary disease. I believe we had a setback with bioresorbable scaffolds, but we should not lose our interest to decrease the amount of metal we put in the vessels. Don't forget that the stents were created to treat acute coronary occlusion dissections, and then marginally they helped to prevent restenosis. So we still have to utilize the stent for the main reasons why they were created. So I have nothing to disclose. So everything is summarized in these slides. Another approach to limit stenting, not to avoid stenting, because we don't want to avoid stenting. So the lesion is crossed with two wires, regular wire, workhorse wire, and the pressure wire. The pressure wire can be positioned after pre-dilatation or at the very beginning. That's up to the operator. The lesion is optimally pre-dilated with a goal to reach a good angiographic result. So good pre-dilatation. IVUS optional but suggested. Following pre-dilatation, two events can occur. You can have an occlusive or a bad dissection, then you go on and stent. You can have an optimal result with or without a dissection. No matter what the optimal result is, with or without a dissection, you have now to measure the pressure gradient. And if the pressure gradient is less than 10, no FFR, just pressure gradient. If the pressure gradient is less than 10, you go ahead and apply drug-coated balloon. If the pressure gradient is more than 10, you implant a stent. You can do a long stent, a focal stent where the lesion is worse. You recheck the pressure gradient and basically you finish the procedure as usual. We estimate that with this approach, we will use stents in about 40% of the cases, but 50 to 60% will stay just with drug-coated balloon, especially with diffuse disease. And I call this a new approach, not to go against stenting, but to limit the full metal jacket and the extensive stenting. Get some examples. These are a 53-year-old male, classic angina. Let's go to the angiogram. So you see a left dominance. The striking aspect of this case is the diffuse disease of the LAD, suboccluded LAD. This is not even ideal for surgery, but I'm sure a good surgeon can handle. But with PCI, the risk is to implant 2 or 3 long stents, and this is not our preferred approach. So we elected to go ahead and do PCI. We measured the gradient in the diagonal, and as a surprise, despite the severe lesion, the gradient is only 11 millimeter of mercury. So it's not so bad. The diagonal is protected with a wire. Then we predilate the LAD aggressively, non-compliant balloon. There is an area right after the diagonal, the balloon is not expanded despite 25 atmosphere. So then we did IVUS, we saw concentric calcium. We decided to do lithotripsy. This is nothing unusual. So basically, we completed a very good predilatation with cutting balloon more distal, kissing balloon, and then is after aggressive predilatation. So I'm sure that many of you will stent the entire treated segment. We did not. We elected to place a short bioresorbable stent scaffold only proximally, 20 millimeter, 24 millimeter longer. And then we continued with better dilatation, and we measure there is a focal distal stenosis. So we did more dilatations, and then we measured the gradient. The gradient, very distal, was 77. So there is still limiting the flow. We did more dilatation with the semi-compliant balloon, and then we did the drug-coated balloon all around distal to the 24 millimeter stent. Then repeated the physiologic assessment, and the pressure gradient, no FFR, approximately went from 86 to 94, and the very distal, after better dilatation, went to from 77 to 87 after contrast. Baseline 84 went to 91. You see what looks a nasty dissection, but the flow is good, and more important, the gradient is very favorable. This diffuse disease is treated with drug-coated balloon and focal stenting, avoiding full metal jacket. This is another case, old stents placed many years ago, 2007, 2010, Noboi on the right coronary, stent on the LAD and on the circumflex. Patient comes back for a focal stenosis in the distal right, diffuse disease at the bifurcation. We treated good pre-dilatation, kissing balloon with drug-coated balloon or drug-eluting balloon. In this case, the result is there is a linear dissection, but the result is optimal. We didn't even measure the gradient because the result is so nice. Look at the distal branches, no stent at all. We go to the LAD, left main. Left main is okay, but there is a proximal stenosis in the LAD and in the circumflex. The stents are implanted distally. We did good pre-dilatation, high pressure, non-compliant balloon on the circumflex, non-compliant balloon on the LAD. Then we did a kissing balloon with drug-coated balloon. In this case, we did not have any dissection. The result is very, very acceptable and no stent at all. This is a more extreme case of diffuse disease in a lady, bifurcation lesion with a big diagonal, a lot of tortuosity, a lot of diffuse disease. There is also disease in the right coronary artery. We did a contrast QFR. It's not a surprise that the vessel is red. Means that the stenosis is critical. This is not a surprise. There is a QFR of 0.62, so it's extremely critical. This is not at all a surprise. We protected the diagonal and we dilated the proximal lesion with a cutting balloon 3.5 at 20 atmospheres at the bifurcation of the diagonal. Then we treated more distally with a semi-compliant balloon at 18 atmosphere. We repeated the IVUS proximal and distal to double check the size of the vessel, and the vessel is definitely 2.5. So we repeated further dilatation at high pressure with non-compliant balloon. We did the IVUS basically to make sure that the vessel is 2.5 and can accept high pressure dilatation. And then after dilatations, we did a drug-coated balloon, no stenting, not even at the bifurcation. Here there is a dissection, but the most important, we did the contrast QFR, and the contrast QFR now has only read very distal, but proximal and mid is not perfect, but is definitely acceptable with a QFR that really, if you look in this graph, goes down only distal, but everything where is yellow is 0.8. So we only drop near the apex that we elected to leave alone, but everything else is above 0.8, which is not perfect, but is definitely very acceptable. We have 6 months angiographic follow-up with persistent non-healed dissection in the mid of the LAD, but the bifurcation is excellent, the flow is nice, and even the distal LAD is fine. So this is a real proof that not only these dissections do not occlude acutely, but they do not occlude with time. And we have several of these cases, and we will put them together as a publication. And hopefully, we hope to do a prospective randomized study. This is the same LAD in the RAO projection. These are before and this is after. The right coronary artery got dissected by mistake at the very beginning with a guiding catheter. You see an extensive dissection of the right coronary artery. This extensive dissection is not flow limiting, but is really not acceptable. This dissection was evaluated with a pressure gradient. We didn't have a pressure wire available, so we had to use a very cheap approach to measure the pressure gradient. We took an angioplasty balloon, we broke the balloon, and you get a mean pressure. You cannot get a wave, but you have a mean pressure. And the mean pressure proximally was 60 and distally was 25. I don't think you need a mean pressure to tell you that this dissection is bad. But anyway, this is a confirmatory test. Then instead of stenting, we did extensive balloon dilatation, 3.5 proximally, 3 or more distally. We did not stent, and after this maneuver without stenting, we remeasure with our cheap approach the distal pressure, and now we have a distal pressure of 55, so only 5 millimeters of gradient with a very real poor man pressure wire. And due to this good result, we just did the drug-coated balloon, no stent, and we rechecked the pressure gradient and was 5, and we did not do any stent. This patient did very well, and we will do an angiographic follow-up at 1 year in this patient. So I don't have a large series, but soon I hope you will see a relatively large series in print. But I want to re-emphasize this novel approach to limit stenting. The lesion is crossed with 2 wires. The pressure wire can be positioned after pre-dilatation. The lesion is optimally pre-dilated with the goal to reach a good angiographic result, and IVUS is optional. And then following pre-dilatation, if the dissection is really bad, you stent. If the dissection is not bad and the result appears acceptable, you go ahead and measure the pressure gradient, and you stent only if the pressure gradient is above 10. I believe we have to go away from the idea the stent has to be used all the time. We now have drug-coated balloons, very effective drug-coated balloons, that if the result is acceptable, you don't really need a stent and you don't depend on the foreign body on dual antiplatelet therapy for 3-6 months. You can limit this approach when needed. Not to stay away, but limit the approach when needed. Thank you for your attention.
Thank you, Dr. Colombo, for again.
Thank you.
Over to you.
Around 10 years back, we had discussions about this diffuse disease. And that time you came out with a very provocative thought process saying that we can manage these lesions with spot stenting. What did you go away from that? And if so, why did you go away? That is one question. Second question is the drug-eluting balloon, whether it is paclitaxel or any other drug. What is the choice of, and what is the evidence?
Okay, I'm not against the spot stenting, and I still believe that we should rejuvenate spot stenting. What I like to introduce is the pressure gradient as a way to be safe. In the past, we were safe based on our experience on this is a good dissection, this is a bad dissection, on IVUS, the lumen is okay. These are very nice tools, but require judgment. With the pressure gradient is very little judgment. The number tells you. And when we measure the pressure gradient, we saw that even sometimes when you don't have a good result and you would like to stent, the pressure gradient is still acceptable, like 8, 9, 10, 11, 12. And with this low pressure gradient, we can limit further stenting. We can still do spot stenting, nothing wrong. But amazingly, even with some bad dissections, we have seen very good pressure gradients, and then we did not even use spot stenting. But this doesn't mean that we should not use spot stenting. So we have three options: diffuse stenting, spot stenting, no stenting. The way to move is experience, but pressure gradient is a new element that we introduced. The easy or pressure gradient does not require a lot of brain. Numbers, read the numbers. If it's high, it's bad. If it's low, it's good. So this is the answer to the first question. The second, definitely we use sirolimus, a drug-coated balloon. We now have a good Indian sirolimus drug-coated balloon, which is Magic Touch. We have also a Swiss-American from Med Alliance, and B. Brown will be coming with the sirolimus base. So the sirolimus-based drug-coated balloon are getting into the market, and they have a better late loss than the paclitaxel. Instead of 0.4, 0.35, they will give a late loss of 0.20, which is very favorable. So the drug-coated balloon is another help. So I think we are now in the new generation approach to treatment of coronary artery disease with stent, but not routine stenting.
So that means your philosophy today is going backward 40 years to what Andreas predicted. You remember those days we used to do a pressure gradient measurement in almost every case, and if the pressure gradient was all right and there is no occlusive dissection, we used to leave them alone, and we are going back to 40 years back philosophy.
Yes, but compared to 40 years ago, we have better tools. We have a way to measure pressure gradient very well.
Okay.
With an accurate pressure wire. And we have a good way to prepare the lesion, which it didn't have at that time. And we have also have the stent, because when things don't go well, you place a stent. I still love stents. Stents save lives. Thanks God we have.
Excellent.
I'm getting a lot of questions, chat questions. Can you take few of them, sir? Dr. Sudeep Kumar wants to know pressure gradient by balloon, whether it is tested against the pressure wire, what we use regularly.
Yes, the pressure wire is the way to go. But you know, sometimes in that laboratory, we didn't have a pressure wire. So I took a balloon, I made a hole in the balloon, and you don't get a good wave, but you get a mean wave, and it's okay. I mean, it's a very poor man procedure. I don't want to make a randomized study with that. But sometimes you have to drink water, even if it's not the excellent water. If you are very thirsty, you take what you have.
Another question by Dr. Wadul Chowdhury is, did you separate, did you use separate DEBs for different segments of the vessels, because vessel tapers? So use the same one or long lesions, his question.
Oh, yeah. We separate, and that's the reason why we use pressure gradient and a different size balloon. The reason why we like to use two wires is because I don't like to work over the pressure wire, because even if the company says the pressure wire is okay if you connect and disconnect, when you do multiple connections and disconnections to advanced balloons, the calibration goes funny. So you lose the calibration. So if you don't disconnect your pressure wire, you are less likely to lose the calibration, and the numbers is more consistent. But if you believe that the pressure wire is very reliable, you don't need to use two wires. You can work all the time over the pressure wire, but you just have to connect and disconnect every time you advance a balloon.
There are more questions coming up on drug-eluting balloons or drug-coated balloons. We will have it after the next session, sir. Dr. Praveen K. Goyal wants to know, do you think that we need to do a different prospective trial with this concept versus what we are practicing now?
Yes, absolutely. We need to do a trial with one endpoint of non-inferiority compared to what we do now to routine stenting at 1 year, and we will have a superiority at 5 years. I'm sure that on the short term, you will see no difference because stents do very well. But if you follow your patients 5, 6 years, this approach will be better. So non-inferiority at 1 year, superiority at 5 years.
That was the question asked by Dr. Shekhar Sriram also. How about the long-term patency? You answered it. Another question is regarding the drug-eluting balloon, different types. You said sirolimus is preferred. And what is your opinion of the usage of drug-eluting drug-coated balloons in ACS? Dr. Ramakumari wants to know.
I think in ACS is the same. I would use the same approach. Of course, there are some situations where the lesion is very focal, very short, and then you can use a short stent. I mean, I think if you see a very focal lesion where you can use a 12 millimeter stent, you can use a stent, nothing wrong.
Okay, sir. Before we close this, there are more questions coming in. We'll have it after the next. Dr. Sinha, you want to say any final comments before we close this?
Yeah, Dr. Colombo, a very interesting concept and a very nice presentation. Just 2 questions. Firstly, conventionally, sirolimus coating has not been able to hold and give a good diffusion and a stain characteristic. So you believe there are new technologies which are coming up which can make the sirolimus more friendly with the endothelium, and the elution from the balloon is more standardized versus paclitaxel. So that's the first question. The second was in fact a non-medical question, so I'll reserve it for slightly later. So you can go ahead on the sirolimus versus paclitaxel debate.
But I think the sirolimus, I'm not totally convinced that paclitaxel caused death as the meta-analysis of Katsanos says. I believe paclitaxel is most probably relatively safe. The reason why I endorse sirolimus is because these new balloons eluting sirolimus are more effective. Definitely. They have a more favorable late loss. Maybe because sirolimus is better drug, maybe the technology they use to hold the drug on the balloon and give to the vessel wall is more effective. For a number of reasons, I believe the way to go is to go into the sirolimus-based drug-coated balloons. And there are already 3 or 4 companies making very good products. And one of them is India.
What I was just saying that, I mean, this COVID thing has put a paradigm shift, not only on our professions, on our working, but also on our lifestyles. And Italy was ahead initially in all the cases of COVID. Then India has gone far ahead of that, and Italy had sort of unlocked and unopened its restrictions. So the India scene is also very different because now the unlock is happening and we are seeing a lot of variable problems and some things which are unimaginable, which are difficult to control. So what is your opinion about the way to go ahead and how to unlock and how to ease the lifestyle, and how is Italy getting back to the normal lifestyle so that we can take some from that?
But I think we have seen progress in going back to a almost normal lifestyle, but using precautions, not to be very strict, complete locking, but try to keep some distance, utilizing face cover like this, and avoiding big groups. I don't think we will eliminate the problem, but the problem will be contained and we will be able to have a normal life, especially in the hospitals. Because what we do now, we concentrate all our energy to treat COVID patients. We need to treat also other diseases. I love infectious disease doctors, but we also need cancer doctor, cardiologist, gynecologist, etc.
I think, thank you, sir. I think we have to also catch up on the time. We'll have more discussion. Antonio will stay with us for another hour. We'll go on to the next symposium. We call upon next set of chairpersons to also to join. Thank you, Dr. Sinha and Dr. Matthew. Please continue to be staying in. We can have interesting comments. With, Yeah, again, after that interesting concept, again, as Antonio Colombo always does very interesting things, a lot of questions are coming up on this new concept which he proposed. We'll have more discussion later, but we have to move on. Now, the next symposium is innovative solutions to treat diabetic patients. In India, we do see a lot of diffuse disease, what he proposed, and also we have diabetes increasing. So I think this session will be more relevant. I hope other panelists, Dr. Ravikant Patil, Shonan Ray, Rishi Sethi, and Sangat Velu also are there. And with this brief words of introduction, I first hand over it to Dr. Colombo to introduce the session objective and his opening remarks. Then we go on to his talk. Dr. Antonio Colombo.
Okay, thank you again for having me. I see very good friends, Mary Claude, Luca Testa, hello. And you know, diabetic disease, diabetic atherosclerotic disease is a severe issue, not only in Western country, but in Asia, in India. And we know how poor PCI has been successful in this group of patients. We cannot scratch the result of freedom trial, where the endpoint of death is on our head. Even if Syntax trial did not show diabetes as a marker, still am attached to the freedom trial result. So we need to do something if we want to be successful with PCI in diabetic patients. And I'm glad about this effort. We will, in this symposium, we still don't have data, but we have a lot of activities going on, and all the participants will present what we are seriously doing to handle this problem. This problem is not going to be easy because diabetes is a very complicated disease, you know better than me. So let me first go ahead and do the introduction about a device, a proposal, a study, and then we go more deeper with the other speaker. I need to share my screen and just let me a moment to open my presentation. Okay, so I will go over this unique stent design to treat diabetic patients, and then tell you what we did and what we are doing to test this technology. So let me summarize briefly this technology. This is the scheme of a stent. And first of all, there is a abluminal coating. This is nothing new. We have many stents with abluminal coating. Makes sense because the drug is given to the wall. The unique feature of this device is coating on the stent as well as exposed part of the balloon. So the coating is not only on the struts, but with sirolimus, of course, but is also on the balloon. So the whole idea is to have a more homogeneous drug delivery on the vessel wall. In addition, because the balloon is coated, you have a 0.5 millimeter of coating outside the stent in the proximal and distal margin of the balloon. And this fact should address an occasional problem of the edge restenosis, which is not common, but it can occur. And we all know that in every stent delivery system, the balloon protrudes more proximally and distally. This coating is done with this unique biodegradable film, which is basically a very thin layer that covers the whole delivery system. So this is the regular stent delivery balloon, nothing strange. The tip length is standard. The crossing profile is very low. The maximum size a little bit less than 1 millimeter, 0.98. And as I said, the unique aspect is that the protruding part of the balloon, which is present in every stent delivery system, is coated with sirolimus. The stent is a modern stent, and for modern I mean hybrid cell design, which is basically open cells in the center and closed cells at the margins in order to avoid longitudinal deformation. So this is a very important aspect. The strut thickness is 73. There is a link between the struts, which is 60, and the strut width is not a lot, is 120. So these are what I call second or third generation stent, thin struts, not ultra thin, but 73 microns is the thin struts. The stent is a modern stent, which means that we have three design, one for a small vessel, one for standard vessel, and one for big vessels. So we can really go to stent de left main because the coverage is well guaranteed, and there is not a lot of metal when you go to small vessels. So this is an additional feature. The drug release is very effective, up to 45 days. The maximum delivery is at from 7 days to 48 days. So it's really a good delivery profile, optimal for mitigate smooth cell muscular proliferation. This is the in vitro release with different sizes of the balloon and of the stent. As you see, it's very similar with different sizes of devices. The data are several. I'm not going to go into details, but just go into some summary. The first study was done in India by Samir Dani. First patient is a feasibility study. Then we have a single arm multicentric registry, and then another big registry that will be presented by Luca Testa on everyday patients. You see the two first studies have been closed, the third one is still ongoing. Then there is a small but very interesting study that I will describe into more details later, which is a randomized study to evaluate tissue growth inside the stent. And then there is a real big study, Ability Diabetes Mellitus Global Study, 3,000 patients. And then there is a acute coronary syndrome. So there is a lot of meat on the table, and this device is going to be really tested at the very deep. This is the some summary data of the study on the 40 patients. This is not only for diabetics, but almost half, 42% of these patients were diabetic. It is a single center feasibility with angiographic follow-up at 6 months in 39 patients. So almost everybody went to angiographic follow-up. And this is the value of angiographic follow-up of 0.17 in segment and 0.24 in segment, in stent. And don't forget that 42% have diabetes. The standard deviations are 0.29 and 0.30. So there is a certain spread, but even at the worst, which is the worst standard deviation, we go to 45 of late loss, which is really not bad, considering that 42% were restenotic. This is a post-market registry of 2,000, 5,000 patients, I think done by Dr. Samir Dani. And these are the results at 1 year in diabetics and non-diabetics. Diabetics is in blue, non-diabetic is in pink. And you see that the columns are quite similar. The diabetics a little bit higher, but really not so bad. Cardiac death is 1.4, 0.8, TLR 1.9, 1.1. So maybe we are going into the right direction. Luca Testa will present his data, so I skip on these. And I want to devote a little bit of time on this randomized trial of Abluminus Des versus Everolimus to address intimal proliferation in diabetic patients. This study is conceived by me and Azim Latib. We started the study while we were both in San Raffaele, and the study is continuing. Is a multi-center, single-blinded, almost finished, almost, because we still need another 10, 15 patients, but nothing wrong to tell you the design. Is a 2-to-1 randomized to Ablumins versus Everolimus, and the primary endpoint is in-stent neointimal volume at 9 months follow-up measured by OCT in the two groups of patients. These are some examples. These are just anecdotal examples. Please don't take these examples as a proof that something works or something doesn't work. But it's nice, at least you see that we are telling that we are doing the follow-up. This is the patient treated with Ablumins. Maybe is a nice result, and that's the reason why I'm presenting to you. But you really see a very favorable endothelialization with a lumen area of 7.7 and the stent area of 9.2. So far, I'm pleased to see at least one good result. This is another good result with post-stenting follow-up at 8 months with very favorable endothelialization and really very contained hyperplasia. This is a more severe hyperplasia, so sometimes things don't go the way you like. I believe whatever result we will do, we will not resolve the problem, but we hope to mitigate the problem. This is an example where the hyperplasia was more pronounced. The lumen area is 3.8, so you have a more severe late loss. But we have to see what the final number will tell us. And then we go to the ability. I think Marie-Claude will go this with more details. Is 3,000 patients with very limited exclusion criteria, randomized versus science, very provocative study, a very courageous study, because it's the first study that not only wants to demonstrate non-inferiority, but wants to demonstrate also possible superiority. It's a worldwide study, Europe, Latin America, Australia. Is powered for non-inferiority and sequential superiority. So it's really a tremendous power of the company, the tremendous courage more than power of this company supporting such an important study. So to conclude, I will say that the Ability Global Diabetic may set a new standard regarding PCI in diabetic patients. And of course, there are many other approaches, drug-coated balloon alone, as we discussed in the previous study, but to have a dedicated stent which is more effective in diabetic patients will be a real step forward for all of us. Thank you for your attention. Can you hear?
Yeah, thank you, Dr. Colombo, for covering that. And they have covered some of the aspects of other talks coming up. And we'll
So thank you. First of all, good afternoon, everybody, dear colleagues and friends there in India. So it's my pleasure, of course, to be part of this program. And as you know already, I'm pretty much involved in this evolution of this technology. I'm pleased to share with you some information and some experience that I've done in the last few years. So it's always also a pleasure to speak after Dr. Antonio Colombo that actually introduced some of the concept that I would like to stress during this short presentation. But anyway, everything actually started in terms of clinical program from the Enable e-registry. And as you know, that it has been a trial, a registry aimed at evaluating the safety and efficacy of the Luminous Dust Plus in all comers population with minimal exclusion criteria. So the idea, the concept of targeting diabetes was not there since the very beginning of the program. But the point is, that after some observation, 2,500 patients have been enrolled, and among them, more than 800 were diabetic. So the thing is that according to the data, the preliminary results, and what has been already published, by the way, they observe that the rate of MACE, but as well as all the possible clinical endpoints, was actually very promising, regardless the presence or not of diabetes. So actually, that was the beginning of the idea, the beginning of all the program that we are discussing nowadays. The results of the Abluminous were actually consistent in patients with or without diabetes. And then actually, that was the idea to start a larger registry, not just in Asia or in India, but everywhere. It's a global registry, and I'm pleased to be the PI of this. And this is the dedicated registry. That is the drug-eluting stent for diabetic patients in coronary artery disease treatment. Again, this time we decided to have minimal exclusion criteria in order to have the largest availability of patients and experiences worldwide. The primary endpoint is a kind of a more modern endpoint, such as the target lesion failure, a composite of cardiac death, target vessel MI, and clinically indicated target lesion revascularization within 12 months, and a full list of secondary endpoint. I will not go through all this list. The situation is, as you can see here, up to date, we have 983 patients enrolled, but actually we are targeting 5,000 patients. And then, as Antonio Colombo already introduced, from the same idea, the ability randomized controlled trial has been actually ideated by Antonio and my friend Azim Latib, which is in the United States at the moment. This is an investigator-initiated pilot study with a completely different objective, because the objective was to compare the angiographic and clinical performance of the Abluminous Des Plus versus the Everolimus family in patients with diabetes. And the primary endpoint is an OCT endpoint, meaning that it is the instant neointimal volume and 9-month follow-up, measured with OCT, followed with PCI with Abluminous Des Plus, compare with the instant neointimal volume following PCI with Everolimus eluting stent. And again, another full list of secondary endpoints. This is the situation. And as Antonio said before, we need some more patients, but we are very close to the end of this trial. So I'm pleased to show you some of the imaging that we have taken from the follow-up of this patient. This is just case number 1. I'm talking about a gentleman with 53 years old with type 2 diabetes, hypertensive, dyslipidemic, and a family history of coronary artery disease. In 2018, he actually had F1 angina with a positive ECG stress test. The echocardiogram was actually normal with a normal ejection fraction. That's the angio. Metadistal RCA, some critical stenosis, actually. I hope that you can see clearly. I hope so. And as this is the left system, well, besides the presence of a fistula, which is honestly not important for us, there is a lesion in the middle AD, a lesion in the first diagonal, and a lesion in LCX. This is a typical aspect of diabetic patients with a diffuse disease. So what we did PCI to the LAD in 2018, and actually we put a 3.28 Abluminous Des Plus, post-dilated with a 3.0 non-compliant balloon, and then we did the plain old balloon angioplasty to the first diagonal. And that's the results. Pretty acceptable, I would say, in both lesions. And then we staged the treatment to the RCA that has been done two months after. And then we put another Abluminous 2.5 by 18 and Abluminous 3.0 by 26. But index procedure was the first one. And then, of course, the patient has been called back in the hospital for the planned follow-up, angiographic follow-up, and OCT. Patient was absolutely fine. That's the result after several months. As you can see, the angiographic aspect is pretty good. And that's the OCT. So I don't want to show you the entire run because it will take a long time. But as you can see, there is a lot of disease. The stent looks very good. There is some neo-intimal aplasia. The strat coverage looks perfect, honestly. And there is no edge dissection, and it's coming in a few seconds, at least for the distal part. But also, as you will see in a moment, there's no edge dissection, but full coverage and the proximal edge. So this is just one example at the distal edge. As you can see, there is full coverage and there's just the minimal neo-intimal aplasia. That's the MLA that we measured at the proximal part, very close to the proximal edge. And you see the MLA is 4.5 millimeters square. But these are some other numbers that are actually useful for the trial. The strat coverage is 100%. The neo-intimal area at the narrowest segment is 1.9 and max neo-intimal thickness is 0.6. Again, MLA was 4.5 millimeters square. Case number 2. A 67 years old gentleman, type 2 diabetes, hypertensive, premium smoker, and dyslipidemia. A long history of coronary artery disease. And, well, as you can see, starting in 2003 with an intralateral acute myocardial infarction, some PCI with a bare metal stent in 2003. And then again, 2009, 2014, and 2018, patients has been hospitalized with for unstable angina and then referred for new coronary angio. As you can see, there is patent RCA, very good result. And LCX was very good. And there is tight stenosis in the obtuse marginal. The LAD looks okay, but also there is a 90% stenosis into the intermediate branch. So the patient has been scheduled for PCI to the intermediate branch, and we put a 3 by 16 abluminous Des plus, actually preceded by a pre-dilatation. The final result, I hope that you can see. Oh, it's not running. Okay, that's the run. Very good result. And then, of course, we did a planned angio follow-up with the OCT. As you can see here, angiographically speaking, there's nothing relevant. It looks pretty good. But this is the run that I want to show you. And I will skip the first part. Let's see if we can do okay. So there is a lot of disease. Distal edge looks pretty good. There's a minimal neointimal hyperplasia. Again, it looks like there is 100% struct coverage. The stent looks pretty good and very widely patent. Proximal part and proximal edge looks very good as well. These are some numbers. This is something that we always took for the trial. And the MLA was 3.97 millimeters square. Again, strut coverage 100%. And the max neointimal thickness was 0.18, which is very good number. Case number 3. A lady, 60 years old, type 2 diabetes again, hypertension, dyslipidemia, and overweight. Clinical history started in 2004 with effort angina and triple CABG. In 2012, another episode of unstable angina with a PCI with a drug-eluting stent on distal RCA. 2018, again, a non-ST elevation myocardial infarction. That's the coronary angio. As you can see, the left coronary artery looks actually okay. There is a critical stenosis in the RCA. And just to mention that the graft going to the RCA was actually closed. So this is the saphenous vein graft or D1. This is the right mammary artery and the left mammary artery. They are patent. So, of course, patients has been enrolled and treated for the stenosis in the RCA. In this case, this is a randomized trial. We did an Exaion spine implantation 3 by 38. We actually post-dilated with a non-compliant balloon 3 by 25. That's the final result at the index procedure, which is pretty good. That's the planned follow-up angio and OCT for this patient, for this lady. And that's, again, the run of the OCT. The distal edge was pretty good. It's also pretty good throughout the length of this very long stent. I go directly to the distal edge. The distal edge, as you can see, looks pretty good. And again, these are some numbers I want to show you. The MLA was 5.0, this is very good, big artery. Max neointimal thickness, 0.25, and strut coverage, 100%. So, in other words, these are my take-home messages. The preliminary clinical data concerning the Abluminous technology showed promising in both the general and diabetic population. And the preliminary data from the OCT images show that at least comparable results with everolimus-eluting stents, which are honestly some of the best in class nowadays. Indeed, there is a strong rationale to further investigate the potential of this new technology in the field of diabetic coronary artery disease. And this is a very good way, I believe, to introduce what Marie-Claude Maurice is about to talk, because the future is waiting for the results of the Ability Global, which will probably, as Antonio said, set a new standard for the treatment of diabetic patients. At least we hope so. Thanks for your attention.
Thank you, Luca, for the interesting talk and very encouraging endothelialization results of the newer stent. We will have more discussion. Some of them have raised some questions that you have had endothelialization done within 30 days. Very good, but we will have more discussion on it after Professor Marie-Claude Maurice's talk. I don't know whether Madam remembers, she has trained a lot of students like from India, and we were together in the Spirit Woman trial. We had quite good experiences with Madam, and we are part of it, and we are very happy to have you here in this TCT India meeting, Madam. And we will hear more from her on this Ability Diabetes Global Program, which Antonio briefly introduced. This is the largest randomized controlled trial to treat diabetic patients as of now. So let us hear more from Dr. Marie-Claude Maurice, who is the principal investigator for this. And in the end, we'll have discussion on all the questions which have come up and some of the panelist questions. Over to you, Dr. Marie-Claude. Thank you.
Thank you, Dr. Tkukumar, for the nice introduction. Very proud to be part of this symposium concerning the Ability Diabetes Global Trial and device, and thank to Concept for organizing that. As I was saying, I'm extremely happy to be at TCT India, as part of my heart is in India due to the many fellows that I had the pleasure to train when they were young, and now I see their wonderful career, and I'm extremely proud of all of them. And so my topic today is to present you the trial Ability Diabetes Global. I am the CEO of CIRC, which is the CRO, one of the CRO conducting the trial. I think it's not necessary, especially in India, to say why there is a real rationale to evaluate the treatment of diabetic patients. You are one of the countries with the highest rate. Yes, you are in the countries that have very high rate of diabetics, and it's increasing everywhere. So the rationale, the need for the patient is really there. And as Prof. Colombo was saying, even if since years and years we work hard to improve the treatment of diabetic patients, there is a lot more to do for those patients. So the rationale is the diabetic patients have more events. They have an additional risk of acute and subacute stent thrombosis. They have delayed healing due to slower endothelialization and increased inflammatory response, and this lead also to more stenosis and, as said, more acute thrombosis. So, the objective with this dedicated stent to the diabetic is to compare the Abluminus stent to the everolimus, in other terms, the Xience, and we think that at least 40% of patients will be multivessel, because this is the anatomy of diabetic patient, and we thought that we will have at least 30% of acute coronary syndrome. I won't stay long on the device, because you have extensive presentation of it by Prof. Colombo, very well done. Prof. Tesla also addressed that. You know that we are with a very special device that has the combination of a last generation DES and a drug-eluting balloon that cover the edges also. And so it's really designed to treat a diabetic patient. We hypothesize that this device will provide more drug, greater drug delivery, and also more homogeneous drug delivery per square millimeter and at the vessel wall, and that will reduce the restenosis rate in that population. The study design, you saw it, but I will go a little bit in more detail. So we will recruit 3,000 only diabetic patients eligible for PCI. They will be followed for 2 years. It's prospective, multi-center, multinational, randomized 1-to-1, open label by blinded follow-up. I will go into that later. The primary endpoint is clinically indicated TLR at 1 year. It's powered for non-inferiority, but also sequentially superiority if non-inferiority is met. Is really what we are looking for, a superiority versus Xience. 20 countries, 100 sites, Europe, Asia, Australia, which is part of Asia, South America, and 3,000 patients, I told you, and the two device you saw them. So the diabetic patient will be screened to see if they are eligible for PCI. The doctors will check inclusion-exclusion criteria. Then the patient will go to angiography because they are angiographic criteria. If they are not validated, it's a screening failure. If they are validated, they go there to randomization and they will randomize one by one abluminous Xience. There is a blinded part. The patient, of course, at the moment of PCI, the doctors will know which stent they implanted. But immediately after, meaning at the moment, even at the moment of the report, it's not written anywhere which stent the patient, it's a study device which is written. And the study coordinator performing the follow-up are not the one who enter the procedure data. So since the end of the procedure, everyone will be blinded to the stent assigned up to the end of follow-up. There is many, let's say, inclusion criteria are very wide, and it's really an all-comer trial, but we want the patient diabetics, but they can be all newly diagnosed diabetic with those criteria, and even only with an HbA1c level over 7%, they can enter in the trial. It can be newly diagnosed, or, of course, patients with the previous documented diabetes, type 1 or 2, and that are treated or oral or by insulin. And any symptomatic coronary artery disease is allowed, except STEMI and cardiogenic shock. For inclusion angiographic criteria, you see that there is really no limitation. They need to have at least one de novo lesion in a native, so grafts are excluded, and in-stent restenosis is excluded, but that's all. And then after, there is no limitation of the number of treated lesions, number of vessels, or lesion lengths. You can treat any patient that has a good indication for treatment. As I told you, we exclude only patients in cardiogenic shock and the STEMI and the severe renal dysfunction for obvious reason of risk of contrast-induced nephropathy. The primary endpoint, as said, TLR, ID TLR at 1 year, powered for inferiority and sequential superiority, and the classical target lesion failure, that is, let's say, the principal R2 criteria. There are many secondary endpoints, but they are also very, very classical. Of course, we follow patients longer. We have several composites. And we will look also to the bark bleeding, of course. Many composites, as I told you, technical success, stent thrombosis, stroke, TVR up to 2 years. That's very classical. How the study is managed? As I told you, Concept Medical is the sponsor. They sponsor the study and they supply the study device. Only, of course, the study, the abluminous device. The Mount Sinai, and it's a collaboration. I'm very proud of this collaboration. CERC Mount Sinai in the trial organization. Mount Sinai Icahn School of Medicine being responsible of project management, CEC, data management, and stats. When CERC will do the site selection, the regulatory submission, the project management, contract also, monitoring, serious adverse event reporting, and the core lab for endpoint related events. There is a wonderful team to execute this trial. chairperson of the executive team being Roxana Meram, with 3 wonderful study PI, Prof. Colombo, Prof. Abizaid, and Prof. Saito. And the steering committee is the same doctors with Dr. Fadila Malik, Dr. David Ildismis, Darius Dudek, Dr. Tolg, and Dr. Benjamin Faury. So it's a very nice team that we count on to execute well the trial. This is the current status. In green, you see the country where the sites are approved, the regulation process is finished. In yellow, when it's ongoing, meaning submission has been done and we are waiting for answers. And in red, it's when we prepare the package. And we are extremely proud to have 2 sites in India, Dr. Mulasari and Dr. Rajendra Kumar Premchand. And let's say we are looking forward working with them. And before question, to conclude, ladies and gentlemen, extremely happy to be part of this wonderful trial. We can say that the diabetic population is increasing worldwide and continue to have a poor outcome despite all medical improvement, both in, I would say, in drugs and in devices. The Abluminous device, which represents the combination of the best-in-class DES and drug-eluting balloon, with the advantages of both systems, has the potential to address better this population. And the Abluminous Diabetes Global Trial is the largest head-to-head stent trial for diabetics conducted so far. The patient will be recruited in all continents and countries, allowing the conclusion of the trial to be applicable worldwide. Thank you.
Thank you, Dr. Marie-Claude, for covering this Abilities Diabetes Global Trial in detail. What we clinicians, what bothers us is, madam, we already have such very low events with existing good generation stents, and to compete with a platform like Xience and produce the superiority over it is quite difficult. And most of the trials which come with comparative results say that both are equal. So what are your thoughts that this new platform could be proving superior over the existing platform? Now I feel Abbott is sitting pretty. They need not spend any money for any research now. They've done enough. Now all the companies compare their stents with this benchmark stent. But what are your thoughts? You feel that this new trial could prove superiority over the existing Xience platform?
Yes, of course, as you say, it's not the first time that Xience is challenged, but it has been challenged also with thinner struts, for example, with some mixed results, but some of them were positive. But let's say there we are addressing a population where even all the DS have a worse outcome than the non-diabetic patient. So it's numbers, I agree, are low, but not as low as they could be if the patient were not diabetics. So there is a real gap. And there is no other stents that combine a DES and a DEB. So that's why, of course, with a so big trial, we are looking for non-inferiority. This trial cannot fail for being so too ambitious. But we are all convinced that there is a good, reasonable chance to get superiority on this trial. Yes.
Thank you, madam. I think we have very two experienced doctors who had a lot of experience with this stent and the drug-eluting balloons platforms which you are using. We have Dr. Rishi and Dr. Ravikant Patil with us. Harshita, can you unmute them so that they can share some experience and clear the doubts with Antonio and Marie-Claude? Dr. Rishi is from KGMC Medical College. This is one of the leading centers in the country, do very high volume work. Teaching institutes, we have their trained DM and MD students. Ravikant Patil also has a lot of experience. Both of them are part of this dedicated global registry, and they can share their experience. Can you make unmute and show the panelists? I think we have Dr. Sangat Velu, Dr. Ravikant Patil, Dr. Rishi Sethi, and Sonan Ray as panelists because of their experience. Can we have them unmute?
Yeah. Good afternoon, sir.
Yeah,
this is Dr. Ravikant.
Yeah, go ahead, Ravikant.
Yeah. Actually, I just want to share some things like last 2 years, I've been using this stent and I've used more than 3,000 implants in last 2 years. And my personal experience about this is acute stent thrombosis, though I see some in cases, but restenosis I have not seen, or maybe I've seen very few in with this implant. So I just want to know what is your real life experience about the real world registry about this stent. This is my experience that restenosis rates have come across very less. Acute stent thrombosis, yes, few cases I have come across with this implant.
Dr. Mary-Claude or Luca, can you take that?
No, yes, I think that Luca can take, Luca and Prof. Colombo can take the question because I have no personal experience in this stent, with this stent.
Well, for sure, I have to say that I started using the Abluminous more than 4 years ago. And well, in large number of patients, because as soon as I started, I targeted diabetic patients with this stent. And I have to say, I have more experience in diabetes rather than in patients without diabetes. However, the thing is that I can remember in 4 years, one event of stent thrombosis in a patient that decided to stop DAPT after a month. Stop. So we had a stent thrombosis, but I think unrelated to the stent, it's just a matter of fact. I mean, if you stop the DAPT much earlier than you should, well, that's a problem. And honestly, I'm not sure we can actually connect the stent with this event. In terms of stenosis, I've seen a few, maybe 5 or 6 in 4 years. So nothing really special. And this is something, to be honest, it is usually I've seen is inside the stent, right in the middle of the stent, where the stent maybe was not truly and properly expanded. So it was possible to recognize a technical issue since the first implant, which is pretty normal. The very good thing is that I've never seen an edge restenosis, which is something really important, particularly in diabetic patients where the disease is diffuse. I've seen some progression into the artery, but nothing involving the edges of the stent. Of course, I don't have thousands of patients to say that. However, in terms of real world experience, so far, so good.
Yeah.
Thank you, Dr. Antonio, for joining back. Can you share your comments on this? Did you hear the question?
Yes, thank you. I don't have a large experience. I started using this device only recently. So I cannot discuss the follow-up. The only thing I can say that the durability and the performance of the stent is similar to the most recent new generation DS. So good deliverability, flexibility, and performance. And I'm really happy to hear what Luca Testa said, because I think in Concept Medical, they are investing a lot of money in this study. And I'm sure that they are pretty convinced from preliminary data that there is some clear gain. Again, I'm not convinced that this device will eliminate restenosis or will drastically, but I think it will be a step forward in the right direction. So far, Limus stent, in the way they have been conceived, did not really make an impact in diabetics. And we need a solution, but I doubt any stent will be the solution, but at least a step forward is important.
Thank you, sir. Dr. Sangatvelu,
Yeah.
do you have any questions?
Thank you, and always nice to see Dr. Mary Claude. Thank you very much, and nice, interesting presentation. So, are there any concerns of increased dose of sirolimus? I know the preliminary registries have shown nice results, but do you consider that in terms of dosing?
I think that it's not only dosing. I don't think that there is more than on a regular stent. It's just that it's completely homogeneous. Usually, the sirolimus is on the strut of the stent and then diffuse. There, it's a layer. It's a thin layer. So completely and elastic, meaning that when you deploy, which is over the stent and over the balloon, meaning that when you deploy your balloon, you expose the whole surface to this layer of sirolimus, including the edges. And we know that 20% of the in-stent restenosis are edges restenosis.
Okay, I think we had a very good discussion, a lot of interesting things coming up, where Indian company is coming up with a good technology of Limus balloon and then probably newer versions of stents. We wish they could work very well in this diabetic subgroup of patients. And Colombo proposed some newer concepts of DEB usage as well as this combination of this could do well. And any final question from Dr. Rishi? Are you there?
Yeah, hi. Sorry,
Yeah.
there was an interruption. There was an interruption in my internet connection. As you already told, we have a little experience with the use of this device in our hospital, and we are also a part of the DCATE registry. I just want to ask Luca or Madam, maybe. I mean, what is it in diabetes that? What do you think is the key factor with this device in the diabetes? Are we relying too much on the earlier data of the registry, the enabled registry, to go after diabetes all along? Or are we convinced that in this device there's something, is it the drug-eluting balloon, or is it the dosage? What exactly is the key component as a pathophysiological basis that we believe will be so effective in diabetics, as we are putting all our eggs into one basket and we're not going for any complex coronary lesions and just targeting diabetes for all our clinical studies and registries in future? What do you think is your take on what? Luca, if you can answer that. Maybe
Actually, I was, thanks for the question, by the way. I mean, that's exactly the point. So I believe, and we believe, that the fact that this is a unique fusion between a DEB and a DES with abluminal coating. By the way, this coating is also bioresorbable. So it's not something staying there, well, actually fueling inflammation. So there are some technical features. The first one, at least in my mind, is the fact that we are releasing an homogeneous dose of sirolimus. And this is crucial. Plus, there is also a coating at the edges, which is absolutely new thing as compared to any other available drug-eluting stent. Number three, there is actually a burst of drug during the implantation, and that's the reason why you have to keep the balloon inflated for 40-45 seconds. And then there is also a controlled release over 1 month. Plus all these features together, I believe they will be able to, to make a step ahead. We need to remember that diabetes is a metabolic disease. So what we are looking at is a way to face the hurdles of PCIs. But clearly, if there, for example, there's no glycemic control, if there's no drug medications, if there's nothing, besides PCI, that would be useless. What we are looking at is a way to address the ischemic heart disease in diabetic patients. However, there's a conundrum. A diabetic patient is a whole world that needs to be addressed. But definitely we are starting from something that in terms of techniques is something new and very promising. We'll see.
Thank you. We had an excellent discussion. I think we need to move on. Thank you, Dr. Mary Claude, Dr. Antonio Colombo, and Dr. Luca for participating in this. My wish to have Dr. Colombo to inaugurate this ETCT has come true. Maybe thanks to COVID pandemic, we could have time and all the interesting sessions we had and will continue to have. And we thank all these session chairpersons and speakers. And we'll move on to the next session that is basically on endovascular procedures and peripheral arterial disease. We wish all of you to continue. And if you're interested, then we'll have interesting discussions on drug-eluting balloon usage also in the peripheral vascular disease. My good friend, Dr. Rajendra Kumar Jain, who is the Director of Cardiology and owner of the KIMS Krishna Institute of Medical Sciences, Hyderabad, and Dr. N.N. Khanna, Senior Consultant Cardiologist in Apollo Hospital, Delhi, and very senior cardiologist and well-wisher, Dr. Manutosh Panja, sir, from Kolkata, will chair this endovascular and peripheral interventions. As you know, Dr. Manutosh Panja is also known for his work in the Takayasu arthritis and other fields. We have other panelists joining. I think we have Dr. Samir, Manoj, Neeraj, and many others. I request all of them to come over and take over the session. Jane on the...
Dr. Now, if you want to really understand the application of Laplace's law, then it is in this, we have all done, blowing up balloons for our children, and we have all realized it, that as you are blowing the balloon, initially when the balloon is empty, there is more pressure required to inflate it. And as the balloon inflates, the pressure to inflate reduces. So the balloon starts ballooning out very fast. And if that happens very rapidly, the risk of rupture is there. So this is what determines the luminal diameter is inversely proportional, and the surface tension is directly proportional to cause the rupture. Now, based on this, so far, what is the rule of the game in management of AAA aneurysms? When we consider the mortality, the cost involved, the quality of life of a given patient, and the risk of rupture, this is what we are following as of now. If it's an asymptomatic patient and the aneurysm is about 5.5 centimeter in size, well, we would like to treat it. Or we would treat it if the size increases by 5 millimeter in 6 months' time. So these are the two main criteria to treat an asymptomatic patient. But if it's a symptomatic patient, well, pain, if this patient has, then you know that you have to treat it. Obviously, ruptured aneurysm, you would like to treat it immediately. Otherwise, what do we follow? If the size is less than 5.5, so far we are following a surveillance. We feel is better. Medical management has to continue at the same time. And we would like to assess the risk factors to decide the line of treatment in some of these patients. Now, if you look at the Cochrane review, where they looked at surgery for small abdominal aortic aneurysm without any symptoms, they considered that it is all low risk, and therefore it is better to monitor these patients and wait till the time the aneurysm grows to more than 5.5 centimeters and then contemplate surgery. What is our practice looking at all these? Well, as of now, based on the recommendation that are there, if it's a smaller aneurysm, that is anything less than 5.5 centimeters, we would like to do the surveillance. What are the size criteria? If it is less than 3 centimeters, we would do ultrasonography once in 5 years. Anything more between 4 to 4.9 centimeters is sonography, and if necessary, CT scan once a year. Anything more than 5 to 5.5 centimeters, sonography, SOS CT scan once in 6 months. So this is the standard protocol that we are recommending and practicing in our day-to-day practice. However, things are changing now. Small abdominal and aortic aneurysm, should we wait? Is what the question this paper was, which is a clinical review, which is Glalilos and his team had attended to. And looking at the data so far, they said that those patients in a subgroup that following the tight surveillance recognizes that these are patients, if they are of poor status, then surgical indication should be considered as early as possible. So there were some cases where you thought that surgery should be taken up earlier, even if the aneurysm is less than 5 centimeters. Now, these are the change in the rules to treat these small abdominal aortic aneurysm, and you would plan the early treatment if the risk factors, if you have assessed, there are certain risk factors which I'll tell you, if the medical management is not followed properly, or based on these findings, you would plan an intervention in these patients. Now, these are the risk factors that we should consider. If there is a family history of ruptured aneurysm, then you may consider treating these patients earlier. We know in women, the growth rate is much faster than men, and therefore, even a smaller aneurysm, you would like to treat that. If there is an associated large thrombus, which leads to increased stress on the wall and reduced stress wall tension, the risk of rupture increases, and therefore this would be one of the criteria. In various studies, they have identified that if there is an associated carotid artery stenosis, the chances of aortic rupture is much higher. Now, I don't know why, but this is what is the data which is showing up. Another criteria is obviously increased matrix metanoproteinase 9. We know that this particular proteinase causes weakening of the wall and the chance of rupture increases in these patients. Collagen markers like elastin peptidase, plasmin, antiplasmin, and interferon gamma are some of the other markers which you would like to evaluate. And if there is any change in that, you would like to treat. At the same time, you have to realize there are some factors which reduces the risk of rupture. And in diabetic patient, the risk of rupture is reduced. And it has been identified that even in patient with chronic limb ischemia, the risk of rupture is less. So these are some of the risk factors that we need to understand. Anyway, if you are conserving these patients, the medical management has to be tightly followed. And these medical managements are mainly related to hemodynamic circulations, blood pressures, and inhibition of inflammation, where statins would come in and some of the other immunological drugs will come in, and protease inhibitions drugs are always prescribed. And if these patients are not complying to this, then you may consider treating them much earlier than waiting up to 5.5 centimeters. Then came in a lot of these trials, and these were large trials. The ADAMS trial, which was more than 1,000 patients, and they looked at patients which were 4 to 4.5 centimeter aneurysms. They had patients who had 569 open surgical cases and 567 surveillance cases. And they realized that there was no survival improvement if these patients who had a smaller aneurysm went for surgery. So there was no improvement in the survival. When you look at the UKSAT trial, where again they looked at aneurysm which were 4 to 5.4 centimeters in size, with surgery and surveillance more or less equal numbers, the results were early survival in favor of surveillance, which is known because if in surgery the early morbidity and mortality are much higher. The mortality due to open surgery was 5.8. However, if you looked at 2, 4, and 6-year mortality, it was same whether the patient went through surveillance or whether there was an open repair. So in conclusion, early surgery did not benefit patients. However, it showed that the survival benefit was better in least fit patient, which means that if the patient was unfit, it was better to treat him early rather than wait for the size to increase to more than 5.5 centimeters. The pivotal trial, which is again a large trial, 728 patients. Here they compared the outcome of patients who had smaller aneurysms with EVAR versus surveillance. And they saw that with EVAR, the early mortality was less, just 1.101%. The aneurysm ruptured and aneurysm related death was equal in both groups. And therefore, their conclusion was that both approaches are safe, alternative with small AAA aneurysm. So you could do either surveillance or even treat them with EVAR procedure in patients who had less than 5.5 centimeter aneurysm. There is this another survey, the CAESARS trial, which was comparison of surveillance versus aortic endografting for small aneurysmal repair. 360 patients were taken up. The mortality and rupture was low with EVAR. And they also found out that 3 out of 5 small aneurysm finally grew and required interventions. And equally important to know that 1 out of 6 patients lost the feasibility of EVAR if we waited for the size to grow more than 5.5 centimeters. So what it means is that EVAR is possible to do in these patients if it is necessary to treat these patients with either of the procedure. Zarin et al. Had a retrospective study, and they evaluated the data from 2 studies that were multi-center aneurysm trial treatments endovascularly, and compared it with the UKSAT trial, which was the surgery trial. And this was their conclusion on that EVAR of a small AAA significantly reduced the risk of fatal aneurysmal rupture and aneurysmal related death. So that improved the overall survival in these patients. The rupture occurred in 1.6% of the patient who underwent EVAR versus 5.1% in a surveillance group. The fatal aneurysmal rupture is 4 times higher in the surveillance group, and all-cause mortality rate was higher in the surveillance group. So all this was prompting that, yes, we can consider doing EVAR procedure in patients with smaller aneurysms. Another prospective study by Zareen et al., 923 patients, and they concluded that small abdominal aortic less than 5 centimeters have 99% freedom from AAA death at 5 years. So you can see that the 5-year mortality rate, if these patients are taken up early with EVAR, is 99%. Comes the question is which are the patient or what kind of patient that you would take it up for small aneurysms. And this has been my practice also. If I find a patient is a smoker, I would take them up for aneurysm, which may be about 4.5 or 4.9. I would take them up for intervention. Women, you would take up in a smaller aneurysms also. Infective etiology patients, especially mycotic aneurysms, would require an antibiotic cover before, during, and after the procedure, but you would like to treat them even if it's a small aneurysm. If you see a rapid progression more than 5 millimeters in 6 months period, these are again a patient that even if they are smaller, first time they have come to you when it was 4, but in 6 months time it has become 4.5, then definitely requires an early treatment. Symptomatic patient, obviously we would treat them. Saccular aneurysm, again, there is no sizing for that. Whatever sizing we have done is mainly for a fusiform aneurysm. And if the patient is less fit at the time of presentation, even if it's a smaller aneurysm, we would like to treat them at that point rather than waiting and then he becomes unfit for any of these procedures. So these are some of the cases where a small aneurysms can be taken up for an early EVAR procedure. The surgical outcomes in these early cases is not so good, especially because of the 30-day mortality and morbidity is much higher. So this is what I would suggest is a game changer as compared to just Laplace's law that we have been following so far and the criteria of 5.5 that we have followed so far. Thank you very much. You will take the questions now or? Hello?
We'll get question in the last, sir. Let us go ahead with the next talk, I think.
Perfect, perfect.
Dr. Vimal, you'll be there, no, till the end?
Yeah, I will wait. I'll wait.
Thank you.
Surely.
That's me, the next one.
Yeah, Dr. Khanna, sir, how are you, sir? In COVID time, nice to see you online. I think let's go ahead with the interesting talk.
Let me just.
I think Dr. Khanna is the next. Can you, somebody who is there from, yeah, I think they have made, yeah.
Sir, you have to put it in a full screen mode, sir.
Good evening, everybody. So today, after a very wonderful talk by Dr. Vimal Someshwar on a very controversial topic of treating endovascular treatment for small-sized aortic aneurysm in the abdomen, let me talk about, some points about endovascular interventions in type 3 aortic dissection or type 2B aortic dissection. Whether we are ready for the paradigm shift of early intervention and better remodeling. So this has been a topic which has been controversial for a very long time, right from our student days, whether to treat acute aortic dissection which is stable with medical therapy or surgery or endovascular grafting. How do I move next? So let's see about acute aortic dissection. It's actually a part of the acute aortic syndromes, which are characterized by aortic dissection, rupture of thoracic aorta, penetrating ulcer, intramural hematoma, or traumatic injuries. And there are three types of aortic aneurysm dissections, which we know. Just to revise, we are talking here of type Stanford B, which is the distal aortic dissection, which is distal to the left subclavian artery, and it would be DeBakey type 3. Now, what is the natural history and why it is very important? What we see is that aortic dissections, I'm not talking of type B alone, but all together carries a very grave prognosis. 28 to 55% of the patients die even without reaching a definitive diagnosis. And this is especially for type A and not for type B, but this is a registry data which includes every aortic dissection. The registry data demonstrates that medical management of type A aortic dissection is associated with 24% mortality at day 1, and 29% mortality at day 2, and 44% mortality at day 7, and 50% mortality at day 15. Less than 10% of untreated patients are alive at 1 year, and almost all of them die within 10 years of presentation. Type B aortic dissection, in contrast to type A, has better prognosis with 89% survival at 1 month, and 84% at 1 year, and 80% at 5 years. So there was a dictum when we were students that, if you have an acute aortic dissection and the patient is asymptomatic, give optimal medical therapy, lower the blood pressure, try to do a conservative management if there are no acute indications for surgery or for stent grafting. And then if the patient gets into a phase of chronicity after 1 month, the natural history of treated and untreated aortic dissection by endovascular graft or surgery are same, and that is the reason this whole concept and controversy started, because a lot of people were left alone on medical therapy, and then the natural history was compared, and it was seen that probably treating early treatment of aortic dissection was more beneficial than leaving them alone, and I'll be discussing why. The most classical symptoms, I'm just going to be skipping, of type A and type B dissections. But if you look at the definite indications for treating type B aortic dissection by endovascular means, we have 3 sets of complications. If there is a patient who's having a rupture or impending rupture or a contained rupture, definitely requires an early and immediate endovascular repair if possible. If the patient is having a malperfusion associated with rupture or without rupture, then this patient definitely requires an endovascular treatment, which could be endovascular grafting, stent grafting to occlude the entry point, or could also be to enlarge the true or false lumen depending on the malperfusion, or to do a fenestration or a combination of all of them. Or if the patient is having persistent severe pain, and which is an indicator of expansion of this or extension of this dissection, again this patient requires, it's a complicated type B dissection, and it requires urgent and immediate endovascular treatment, and sometimes even a surgical repair. And for uncomplicated, high-risk, type B aortic dissections, we have to see if there is a large primary entry tear, or if there is a partial false lumen thrombosis over a period of time, or if there is a severe compression of the true lumen, or if the false lumen size is more than 22 millimeter, and if there is also uncontrollable hypertension, actually these patients also require an endovascular treatment. So these are in summary. If you have rupture, if you have malperfusion, both on clinical and angiographic finding, you will actually require to do endovascular repair. And if you also have an aneurysm which is growing and there is a persistent pain which is indicative of extension in presence of uncontrolled hypertension, you require endovascular repair. And how it is done conceptually, it is very simple. You seal the entry point where the primary tear is. You also have multiple secondary tears, and then the concept is to depressurize the false lumen and to increase the pressure and flow in the true lumen and redirect the blood flow from true lumen to true lumen. And this leads to thrombosis of the false lumen and remodeling of the aorta and the aneurysm. So this is the basic concept. What is the fate of survivors of type B aortic dissection? The acute mortality is about 10%. Late complications vary from 20 to 50%. And this, in comparison, type A is where the mortality is much more higher. Now, if you leave the aneurysm, what happens? The chronicity leads to maturing of the entry tears. The intimal flap is thickened, and the immobility affects remodeling. So, does false lumen thrombosis matter? And there have been different studies which have been published in the Journal of Vascular Surgery and International Cardiology Reviews, and also European Journal of Endovascular Surgery. It is a slow process, and the shrinkage is the key. And if the shrinkage is not happening, then this again, and if there is an expansion, again, this is an indication for endovascular repair. So there was an 89% survival, 4-year survival, when the false lumen size actually decreased. And there was only, as compared to only 39% survival, where the false lumen size did not change or increase. That was a very, very important finding, and this was published in 2012. And that led to a debate whether early treatment and early endovascular repair actually would lead to a better outcome and remodeling, positive remodeling. This is the consensus of literature, which is fairly divided, and usually the consensus up till now was favoring medical therapy over TEVAR. But then there were good trials, like an INSTATE trial, which was a 5-year trial, and the key results was, here we checked the cumulative clinical results from year 0 to year 5, and the two groups were compared: optimal medical therapy and thoracic endovascular aortic repair with optimal medical therapy. It included 68 and 72 patients in both the arms. What was seen, the blue one is the TEVAR. The all-cause mortality was reduced. The aorta-specific mortality was reduced, and the disease progression was reduced. Again, there was a clear suggestion that endovascular treatment may be better. Early endovascular treatment may be better in type B aortic dissections. Now, again, this is the concept which I have told you. You seal the entry point and try to depressurize the false lumen and increase the flow in the true lumen. And this is what you get. This is the entry point, and this is the false lumen. This is what you get after endovascular repair. Now, acute complicated type B dissection, what do we know? The reports on the results of thoracic endovascular aortic repair for acute complicated type B dissection at 30 days and 1 year. This was from the Multidisciplinary Subcommittee of Society for Vascular Surgery Outcomes Committee. And this was headed by Dr. Rodney White and Craig Miller and Frank Cryo. And what was seen is that 30-day mortality was 10.8%, and emergency TEVAR for acute and complicated dissection had acceptable morbidity and mortality rates extending up to 1 year. Then if the patient has persistent pain and refractory hypertension, this was a study which was published this was published in 2014, and it was seen that patients with recurrent pain and refractory hypertension, the mortality was 35.6% versus 1.5% if there was no pain and no hypertension in the patient of acute type B aortic dissection. Again, these were very important and seminal studies to actually tell that not only the endovascular aortic repair is safe, but there are surrogate markers or clinical criteria where you can actually predict which patient is going to be surviving longer and when endovascular treatment is actually required. And this followed by the INSTEAD trial actually led to thinking that an early endovascular treatment is the way to go in type B aortic dissection, especially if you have these conditions. Now, about the peri-procedural planning and anatomical and technical consideration, what is seen here is coverage of left subclavian artery is usually necessary in most of these patients because the dissection actually starts just distal to the left subclavian artery, and usually there is no good landing zone at the proximal landing zone, so we need to cover that. Now, once we are covering left subclavian artery, 5 to 10% incidence of stroke is there. So we must consider immediate revascularization if you have a left dominant vertebral artery, or if there is an extensive thoracic coverage, or if there has been a prior abdominal aortic endovascular repair. Now, the technical steps depends on the clinical scenario. In case of rupture, you must maximize the aortic coverage and be aggressive with sealing distal entry tear. In malperfusion, the greater coverage correlates with greater false lumen thrombosis, and the risk of paraplegia is higher. Now, this is a new concept of petticoat graft, which is there to actually enlarge the true lumen. And what is done here is a covered graft is used to actually cover the entry point, seal the primary entry point or a tear in the thoracic aorta. And then the entire false lumen is sort of enlarged with a non-covered self-expanding stent, which actually enlarges the true lumen, and it leads to a good and early thrombosis of the false lumen. And if you have malperfusion syndromes, you're not inhibited to do endovascular repair for those malperfusion syndromes as well. Another word, if you have a patient which is very sick, and the patient can, or there is a contraindication to use a lot of contrast, what you can do is take the help of intravascular ultrasound, and this is very, very helpful to actually delineate the entry points, the type of tear, the number of tears, and also their relation with the vessel. And while we are doing an endovascular graft, many a times after initial angiogram, you may not require to do a repeated contrast injection, and the entire procedure can be done with intravascular ultrasound guidance. And actually, the contrast load is very, very minimal, and the results can be analyzed with a lot of accuracy with the use of intravascular ultrasound. So I'm just going to be skipping this for the want of time. Now, again, just going on to the conclusion, as of today, it is found that endovascular aortic repair for early endovascular aortic repair for acute type B aortic dissection is much better than medical therapy, and the mortality rates are much lower as compared to open surgery or medical therapy. This is the long-term survival of TEVAR versus no TEVAR and just optimal conventional therapy. What is seen is that the long-term survival is much better in TEVAR group as compared to the conventional therapy, which could be open surgical repair plus medical therapy or medical management alone. And this is a follow-up of 7 years, and you can clearly see that TEVAR is much better in terms of long-term survival. So in conclusion, acute type B dissection should be treated by early endovascular repair, especially if there is a malperfusion, if there is an acute enlargement, persistent pain in presence of uncontrolled hypertension, or if there is a failure of medical therapy. And this has been published in the circulation as a consensus. And for asymptomatic patients on medical management, if it prevents long-term complications of late dilatations or interventions for other complications of dissection, which occur in 30 to 40% cases over 5 years. So if you treat them with endovascular repair, you may actually prevent these complications. And it also alleviates the debilitating effects of intense medical therapy that are not frequently considered, and the drug depression and limited lifestyles which these patients have to follow. Regression of aneurysmal thoracic segment occurs in most of the patients after successful endovascular repair, and the persistent flow in visceral and abdominal segments leads to unpredictable aneurysmal enlargement in the abdomen. And this can sometimes be an issue for further treatment. And TEVAR actually prevents long-term complications of left dilatations and interventions for other complications of dissection. And that is why it should be considered as the treatment of choice in today's in these acute settings. Thank you very much.
Thank you, Dr. Khanna. I think for an excellent talk on the controversial topic. I think Dr. Bashi is there in line. I think probably, David, can you just share Dr. Bashi's screen?
Good evening, chairpersons and panelists, and thank you, Dr. Srinivas and Dr. Jain, for the privilege of addressing this audience this evening. And my topic is open surgery for descending thoracic aortic aneurysms. Already, the interventional treatment has been discussed in detail by Dr. Khanna. There is no doubt about that. The present consensus on the indications. Now, what do we do these type of aortas? Like when a dissection is an aorta arteritis, then a patient with coarctation with aneurysm, extensive aneurysm of the aortic arch, retrograde dissection. These are the few things which we see in our practice. Or should it be, what is the role of open surgery today? So I will just discuss a brief thing about in the literature, and then I go through a few cases and my experience because I find there are not many reports from our country, even though we talk about a lot of results and comparisons. See, I personally feel, I am sure all of you agree, the age group of the patients coming to us, the pathology, the anatomy, and all those things are totally different. Unfortunately, we don't have any studies regarding the size of the aorta and regarding none of the statistics has been published from our country. So we have to always take the statistics from other countries. So I'll just go through in brief detail because it's such a vast topic. So as we all know, there are three procedures: open surgery, total endovascular, and hybrid for descending thoracic aneurysms. And it is a complex disease, and the incidence is about 10 in 100,000 population, and natural history, as we all know, is progression with rupture, and only 10 to 20% will survive for 20 years. This is one of the largest series published in the literature, and Dr. Joseph Casale is one of the experts in thoracic and thoracoabdominal aneurysms. He has done more than nearly 2,500 cases. And in his hands, the operative death is about 6%, and renal failure is less. And most importantly, paraplegia, which used to be a very big problem in the olden days, is much less, as less as 3.8%. This is an article published in 2007. Recently also I was listening to his talk, and almost his results are even better. So that is just to show the early results. Now see, this is from Mark Skeppens from Belgium. He has done more than 500 cases of thoracoabdominal aneurysms, and see the long-term results. You can see almost 20 years, 83% freedom from reoperation. To justify that in indicated cases, surgery gives excellent results. Now coming to the pathologies, what we see, I think at least in my practice over the last 35 years, I find the younger patients are much more, they come with advanced disease with multiple problems. This is like a patient who is about 33 years with severe aortic incompetence, who has got chronic type B plus an infrarenal aortic aneurysms. So in this patient, he had LV dysfunction, so I have done a root and descending thoracic in a frozen elephant trunk. And this distal part, he is waiting for on follow-up for surgical correction. I will not put a endostent in this patient because he's already a Marfan. Now, this is another pathology which is unique to our place. Aortoarteritis affects in females, multiple aneurysm with obstruction of the few of the visceral vessels. So in one way, it is an advantage because you don't have to reimplant all these vessels when you do an open surgery. And this is the intraoperative picture, and this was done about almost 9 months ago. I don't have any post-op CT. And again, another young patient, 25-year-old female. One of the symptoms in these cases are excruciating back pain, and the amount of improvement they get with surgery is phenomenal. And most of them will require intensive medical treatment when they come with the acute phase, either with, now there are a lot of good medical therapy for these cases. So until the active phase is controlled with the medication, you should not do surgery immediately. Now, this is another case, a tuberculous arteritis. You can see that from the subclavian artery down up to the bifurcation, there is no aorta in this area. Is only renal artery is there, and one visceral artery was patent. So we did a thoracoabdominal open surgery, and that is the right hand side. What you see is the post-operative CT aortogram. This actually was published in the American Journal of Thoracic Cardiovascular Surgery. This is another young patient from Mumbai, actually. He was referred by a cardiologist to me with an aneurysm here, severe back pain, elevated ESR, all blood cultures were negative. I was in a dilemma as to what to do. Finally, we decided, because the mouth was quite big for this, so we did an open surgery, and this is the CT aortogram after 1.5 years. He is on steroids with the follow-up. These are some special cases which we see in our country, which I don't think many people abroad will be seeing. Now see, this is another patient who is 40 years old. The aorta is occluded here, huge aneurysm here, which is eroding into the vertebrae. I was wondering how to manage. Finally, I did a double thoracotomy for him and did the whole procedure without cardiopulmonary bypass. Actually, we did the anastomosis here and then put through below the retroperitoneum and anastomosis here just with a cross clamp there for about 20 minutes. So finally it came out very well, and he is doing quite well. Blood pressure is getting controlled. Now coming to type B dissection, already Dr. Khanna has explained in detail. I don't have to go through. As we all know, at present, I don't think anybody will try to operate on a patient with acute type B dissection. The operative mortality and complications are high. Chronic, definitely there is a lot of scope for surgery in a particular situation. Depending upon the condition of the patient, the age of the patient, we can decide whether open surgery or endovascular procedure. This is a very young fellow. Young boy presented with back pain. See, the whole aorta is dissected up to the bifurcation, and it is the intraoperative picture. We did a thoracoabdominal aneurysm repair, and that is the post-operative aortogram after 2 years. This is another young patient. He was she was referred from Maldives with back pain, and then we did an open procedure. She also has got connective tissue disorder. These are the cases one should not, in my opinion, should not put a stent graft because of the age as well as the connective tissue disorder. And this is also another 24-year-old patient with Marfan syndrome with severe aortic incompetence with a type B dissection, LV dysfunction. So we did the aortic root replacement, and on follow-up, he came with the increase in size of the aneurysm, and that's the intraoperative picture of a thoracoabdominal repair. Now, the problem, another problem, but we all see, which has also been mentioned earlier talk, as is the progression of the distal aorta after type A aortic repair. The distal aorta enlarges, the true lumen becomes small, false lumen becomes, they need constant follow-up, at least in a year, and they should be caught on time. For this, we can do the frozen elephant trunk, which is a very major procedure. These are the two grafts available in India. Both are available now for the last 1 year. And before the arrival of these grafts, I used to modify, like stitch an arch graft with a descending endograft and do it. These are the two cases done before. You can see the extent of the disease, and also the false lumen is enlarged so much. He's from Maharashtra, this chap. He was operated in Mumbai with and there was for type A dissection, and there was a kink in the graft. So post-operatively, everything was corrected, and this is the arch graft. Now, another pathology which needs sometimes, of course, a lot of interventions are done in coarctation, but all depends upon the anatomy and the age of the patient and associated pathology. This is a 28-year female with a coarctation of the aorta. We did just a side-biting clamp here, just an aortic subclavian to aortic bypass. One thing I want to show is the marked regression of the collaterals, even within 1 week. I just want to check a CT to find out, she had so much of collaterals and uncontrolled hypertension. And this is the CT taken about a week later. See, the problem of coarctation is that I showed in the first slide about this CT, about the large aortic aneurysm distally. So I don't know whether to put a stent in this situation is ideal, considering the age of the patient. And that is the CT you see is the post-operative. And this is a very, very unique case. In my early days, I operated this patient when I was in CMC in 1984, the second year after I finished my MCH, when Dr. Stanley John was there. He had a slight mitral stenosis and coarctation of the aorta, maybe the only case reported in the literature. I did a CT for him after 35 years. This is the subclavian arterioplasty. The aorta looks almost like normal. I don't think you can get any better result with any other procedure for such a long term as of now for coarctation of the aorta. So now complex aneurysms of the ascending of the arch and descending, usually it doesn't come isolated. Usually these are aneurysms, not dissection. I'm talking about aneurysm cases. I do a single stage procedure. This is what is being done by a midline stenotomy and a anterolateral thoracotomy. This is a 33-year-old person presented with hoarseness of voice, low-grade fever. He had anti-tuberculosis treatment. He had aneurysm involving. It's a huge aneurysm. So we did a single-stage operation with an anterolateral thoracotomy and midline stenotomy, and that is the aortogram after 2 years. Same, another patient with a hemiplegic, and he had tuberculosis. I was hesitating to operate him when he saw the CT, and he had very severe coronary artery disease. So we did an arch and descending thoracic aortic replacement up to here in single stage and the triple vessel coronary bypass. That is his photograph taken after 10 years. He was put on almost double his weight. I couldn't recognize him. This is one of the longest patients with just to show the limelight of surgery, how it does long term. This is maybe one of the longest surviving patients in our country. I operated in 1994. It's a nun sister. This was Professor Solomon Victor, who is no more now, only referred this patient. This was aneurysm when she came. Those days we didn't have CT, only the cut film of the angiography. And she inaugurated our aortic summit last year, just to show how the graft we put stitched together, how it lasts for 24 years. Now, another indication for open surgery is complications for after endovascular procedures. He's a professor of plastic surgery, retired, working in one of the private hospitals in Chennai. He came with a hematemesis following his endovascular procedure for a intramural hematoma, and he developed a leak plus infection with gas in the periaortic tissue. He had a previous EABG with Lima to the lady. He was brought intubated. So finally, a patient was not willing for surgery, but the relatives wanted me to operate, and I did an open surgery and replace the graft. One of the things which I do in this type of cases is with an omentoplasty. You transpose the omentum into this aorta graft. It's really, really helpful. This is actually now 4 years after surgery. This actually was also published. This is another child from Bangladesh. They did a PDA closure and then patient developed an aneurysm, and they tried to put 2-3 grafts, emergency balloon stenting, and then shifted actually they came to a neighboring hospital where they tried to put a stent in India also, then referred to me for surgery. And these are the things which I removed from the aorta, and that I did a single stage midline and lateral thoracotomy. She was only 7 years old. Now, this is another very interesting case. patient with the problems of coarctation, I just want to show. Patient first underwent coarctation surgery, aortic graft. Then he developed leak in the thoracic aorta. He was then they put some coils and plugs and everything. Again, he started developing hemoptysis. So came to me. I did arch debranching and did an endograft completely. Thought that everything is all right. He went home. Came back after 6 months again with hemoptysis. Then we found a CT and found that there was a few of the plugs has eroded into the left main bronchus. So I did a left pneumonectomy. About actually just in February only it was done. So CT is not done. He is doing well. These are the materials which are removed from the left chest. So this is one of the patients where endovascular graft got infected and we did a homograft aorta and it's doing well. One of the dreaded complication which no interventionalists like to see is retrograde dissection of the ascending aorta, which carries a mortality of almost more than 50 to 75%. Whereas it occurs later, means you have got time to save. These are the few cases whom I operated. This patient came after 3 months. This was actually after a total endovascular aortic arch repair was done elsewhere. Patient came with a retrograde dissection with a renal failure. He was on dialysis. Then I did a circulatory arrest and then replaced the ascending aorta as a post-operative result. This is also another patient after 10 years. It is a very dreaded complication, especially in patients with peri-aortic hematoma, excessive dilatation of the graft. All these are and too much manipulation of the catheter, as you all know very well, better than me. And a few of the studies. Next procedure is the hybrid procedure in the abdominal aorta, where instead of doing an open thoracoabdominal, that also is a major procedure, and it should be done by experienced hands with good high volume centers. Otherwise, that also have a lot of problems. This is one of the articles published by late Dr. Roy Greenberg from Cleveland Clinic, where he has compared endovascular as well as surgical repair, and as found earlier, there is not much statistical difference in survival. This is my personal experience till 2018. Now I've done another more than 150 cases after that. Over that more than 1,500 cases, we have done close to about 200 cases of thoracic and thoracoabdominal. Just to show the results, we have overall mortality of 9.2% with the mortality in the last 10 years. Nearing 6% with a low incidence of paraplegia and renal failure. And to conclude, surgery is a gold standard. Younger patients definitely with connective tissue disorders have better long-term results, and patients with complex anatomy and pathology, open procedure is preferred. High volume centers definitely have a low morbidity and mortality, no doubt about that. And unfortunately, no prospective randomized trials to compare these treatment strategies on head-to-head basis not available. Despite minimally invasiveness of the new endovascular repair, long-term durability is still largely known, and hence surveillance is important. Most important thing, I think I will highlight it, very important is to have a very good aortic team, which is important to take the correct decision, what to do and when in a patient is the most important factor, which ultimately decides the result. That cannot be overemphasized, because I find, because I get problems which has been created by certain, I'm sorry to say that, because when you take a wrong decision to do a procedure in a patient with aortic dissection, he will develop complications after complications after complications. So it is important, if one is not able to take a decision as to what is to be done, there is no point in discussing with somebody else, and take a decision so that you are giving the best to your patient. Thank you for your attention.
Thank you very much. It was an excellent talk, and really the cases you showed are mind-boggling. Okay, thank you very much, sir. And I think we should go to next to Dr. P.C. Gupta, sir. He's ready waiting. And Dr. P.C. Gupta is a vascular surgeon in Care Group of Hospital. He has extensive experience in management ischemia, aneurysm.
And very encouraged to see what is shown by Dr. Bashi sir. excellent results and lot of experience. That's why I want operators who have maximum experience to come and speak, so that your strength is our work. That will speak for itself. Thanks for your excellent lecture, sir. We'll go on to the next by Dr. Gupta.
Thank you.
Thanks, Dr. Srinivas. Thank you, Mr. Chairman. Good evening, everyone. So what I'm going to talk about today is not really operative surgery. So we're going to talk about one of the medical aspects of managing patients. So the topic given to me was management of acute limb ischemia. Is there any role of stem cell therapy? And I was really wondering why have I been given this topic? There seems to be really no role for stem cell therapy. Now, if you look at acute limb ischemia, it's a very challenging problem with very high morbidity and mortality. And especially if we have patients with acute aortic occlusion, the mortality can be as high as 40%. And of course, the various reasons why we could have embolic is the commonest that we see. Could be cardioembolism in patients with mitral stenosis or acute MI. Quite often now we see arterial, and we recognize these more often because we are doing CT angiography for these patients. And then of course, thrombosis or underlying disease or graft thrombosis could be procedure related, for example, following a femoral puncture or a brachial puncture for an endovascular intervention. Then of course could be low flow states like cardiogenic shock and others like vasculitis, occasionally acute aortic occlusion following aortic dissection. Now the important thing to define acute limb ischemia is that patient should present within 14 days. Now once 14 days have passed and the patient presents, we call it delayed presentation of acute limb ischemia. So this is what I'll focus on, arterial plaques which cause distal embolism. Now quite often these plaques which are present either in the thoracic aorta, abdominal aorta, or at times in the iliacs, these cause chronic embolism. And over a period of few months, the tibial arteries get completely occluded. And these patients then come to us with a sudden proximal occlusion. Now, in a typical acute ischemia, if the patient is not treated, this will lead on to tissue infarction. And usually the nerves and muscles are affected. In fact, just last night we had a patient we are suspecting COVID positive who came with bilateral acute ischemia, which was irreversible. And we had to do an above-knee amputation. So this is how fast the disease can progress. And once there is anaerobic metabolism, leads to accumulation of lactic acid, leading on to severe acidosis, hypotension, hyperkalemia. And this is just to highlight what really happens in acute limb ischemia and why there may be really no role of stem cell therapy in this group of patients. So when we look at category 1, we could consider that this limb is going to be viable and there might be something we could do. But once we move on to category 2 and 3, there seems to be really no role of waiting for any sort of procedure. We need to intervene immediately. So this is the algorithm that we follow. So class 1 or 2A, there could be some delay. We anticoagulate, work up for comorbid factors, semi-elective angiography, and then take a therapeutic decision, which could be either observation, surgery, or thrombolysis. And class 2B needs immediate procedure to the extent that we say even don't wait for thrombolysis. If we can do a percutaneous thrombectomy, good enough. Otherwise, go in straight away for surgery. And class 3 is irreversible. We go in for amputation. So now if you look at this algorithm, you will see that I have not mentioned stem cell therapy anywhere. So these are the surgical procedures. Now, when would we consider stem cell therapy? So when we talk about stem cell therapy, we are talking about vasculogenesis or neovascularization. So it has two components. One is arteriogenesis, in which we have formation of collaterals, which is stimulated by fluid shear stress in relation to arterial stenosis. So a typical procedure that most of you are familiar with, a typical situation is, let's say, an SFA stenosis. And because of the SFA stenosis, when we do an angiogram, we see a lot of collaterals which supply blood beyond the stenosis. This is due to arteriogenesis related to fluid shear stress. The second is angiogenesis, which is formation of capillaries, which is stimulated by growth factors and hypoxia. So this happens when there is severe ischemia in the distal tissues. So these are the collaterals I was talking about, which you see in patients who have arterial occlusion or stenosis. So what are the angiogenic therapies available to us? These are gene and protein based, using like the VEGF or the vascular endothelial growth factor. fibroblast growth factor, hepatocyte growth factor, and hypoxia-inducible factor. I personally have no experience with any of these. The other cell-based are the ones which seem to work better. These are the endothelial progenitor cells, bone marrow-derived cells, and peripheral blood cells. And we really are more familiar with the bone marrow-derived cells. So once we aspirate cells from the bone marrow, what they contain are endothelial stem cells and progenitor cells, hemangioblasts, angioblasts, mesenchymal stem cells, and hemopoietic cells. Now, regardless of their ability to transform into endothelial cells, because that is what we really want for neovascularization, most of these cells from the bone marrow are pro-angiogenic, and they participate in angiogenesis via various methods. For example, paracrine signaling or the ability to take on endothelial cell-like characteristics. So when we look at the outcomes of trials, about 37 trials, in critical limb ischemia or chronic limb-threatening ischemia, we have no revascularization option. There is a tendency towards also healing and cessation of rest pain. Benefit is seen at about 3 months. And what we have seen in clinical practice, it takes about 2 to 3 months for the effect to start. So therefore, if you see a patient with typical acute limb ischemia category 2 or 3, people used to take. So when I got this topic, I started looking at my own data. Is there really a role for stem cell therapy? The answer is no and yes. No for acute presentation. Yes for delayed presentation with no options of poor revascularization and viable limb. So this is the patient who has been having chronic embolism. The distal arteries are occluded and we really cannot open them up. They come with a sudden onset of acute ischemia because of more proximal embolism or thrombosis. So often they have toe gangrene, ulcers, rest pain. There is fresh thrombus in the proximal arteries. So we are able to revascularize the proximal segment either with thrombolysis or with an embolectomy or a thrombectomy. So stem cell therapy with bone marrow cells is most useful in this group of patients. So when I looked at our data over 50 cases where we've done stem cell therapy, we found 10 patients where we had treated acute limb ischemia or delayed presentation of acute limb ischemia, and we were able to salvage the limb in 9 of these patients. So this seems to be really encouraging in this specific group of patients who come with delayed presentation. So to summarize, there is no role of stem cell therapy in acute limb ischemia. We are studying its efficacy in treating patients with delayed presentation of acute limb ischemia, and the results seem to be surprisingly encouraging in this group. Thank you very much.
Thank you, Dr. Gupta. Jain? Dr. Khanna?
Thank you very much, sir. Dr. P.C. Gupta, sir. Now, Dr. Rohit Nair, are you there? Dr. Rohit, can you switch on your video?
Obviously, Dr. P.C. Gupta meant it's obvious that ischemia revascularization is the first choice. He didn't cover that and showed the other aspects of acute limb ischemia. We know that even the critical
Hi, good evening all. Thanks for having me to talk. My topic is on treatment paradigms in below the knee interventions. So I think for want of time, I'm just going to quickly try and skip through the slides. So I'm going to jump straight in. I won't waste much time. Obviously, everybody knows about lifestyle modification, medical management, endovascular therapies, and surgical management. I'm going to concentrate on endovascular therapies. Collaboration. First thing I just have to put it first as one of the most important things that I always do for most of our patients is collaboration prior, during, and after with physicians, endocrinologists, surgeons, podiatry, and wound care. We have a whole team here for treating critical limb ischemia, and we have weekly meetings, and that's proven to work. Before we do anything, we have to have pre-procedural planning. What I've always said is to have an end point. I mean, I'll speak about that in a second. We need to know what we want to achieve, and then obviously understanding the lesions and the anatomy, which I think is very important. Planning the access site, as all of you know, your armamentarium, what kit you have, your backup, to have your surgeons nearby, to have your cardiologists nearby, to make sure you've got the anesthetist on standby, and the post-procedural care. These are just simple things that you do in any procedure. Now, what is the end point? I mean, I was looking at all these years of below knee interventions or the above knee interventions I do. I realized over the last 5 to 6 years, or maybe probably a little more than that, what I've done is I have actually learned to work on my endpoint. I mean, what am I doing this for? Is it for foot claudication, or is it just for ulcer wound healing, or is it just a preoperative, vascular augmentation? For example, if the vascular surgeons want to put let's say a FEMP or bypass, but there's not much good runoff, am I just opening them just for that? Those are the things that go through my mind. So what I've done is I've tailored the procedures according to what I want to do, and or prevent amputation. So end point, I think that's the most important for me and for anybody. Obviously, this is from the legendary Dr. Akihiro, who's obviously a very famous cardiologist, and he's done a lot of work on angiography and endovascular therapy. He's talked about. I haven't shown you what's the above knee anatomy, but there are a couple of branches which I think are sort of my saviors in case of problems, particularly the anterior malleolar branch of the peroneal and the calcaneal branches of the peroneal. These, as you know, are common pathways you can enter via these arteries into ATO or the PT. Now, again, just quickly going through the anatomies before I go into a few cases that I have done. You've got the anterior tibial artery, dorsal aspiratus artery. I don't know how many of you here still believe in angiosomes concept. I know it's a very surgical concept. I still think it works a lot for personally for me and my team here. To decide which artery to open up. All what you have to remember is there are arteries for give out collaterals. It's important that you also treat the neighboring artery. And here in this two, you've got the lateral plantar, medial plantar. These are two important arteries which we need to know. This is a slide I've shown many times, repeatedly, because I think sometimes, for example, if you look at type 3A, which actually, people, this patient must have come with an ulcer in the heel, and then patients had a CT or an angiography or an ultrasound which shows an sort of occluded PT, but it actually isn't. That is the normal anatomy for the patient. So understanding the anatomy is extremely important. You look at the type 3B, which is a peroneum magna, and you can see there's the PTs that looks a bit diseased. The AT is almost non-existent, and then we try and open up those two arteries unknowingly. I'm not telling that it's knowingly, but unknowingly thinking. So it's important that you understand the anatomy. However experienced we are, we just have to make sure that we're not missing this small things.
Yeah, so this is quite a good example. Again, you can see there's a big peroneal artery. You can't see the PT. The AT, if you look at the left hand of the screen, you think it's diseased. But then if you look at it, it's actually non-existent. And what you have got is the peroneal artery giving a dorsalis pedis. So these are small things. So opening up that bit might prove helpful. Okay, and among the treatment paradigms, what you have to understand is the foot circulation. I mean, 99% of the cases which I have done are to treat foot diseases. Hence, knowing that there's an anterior and a posterior circulation, and those are the arteries which you need to concentrate and open on. So, understanding anatomy and lesions is one of the best. It's one of the most important things in treatment of below the knee disease. Access sites and kit, antegrade common femoral artery. As many of you know, I won't waste too much time on it. Tibiopedal access, again, increasingly being used, and I use it quite often to puncture the anterotibial posterior artery. Sometimes the peroneal artery, if it's possible, in fluoroscopy. I've never been able to identify on ultrasound the peroneal arteries. I've tried many times, but I always miss it. But AT and PT, it's been quite straightforward. My go-to set is a Cook Medical's micro puncture pedal access kit. It comes with this 21 gauge needle, as you know, under ultrasound guidance. And then you puncture the thing past the small guide wire that comes through it, and you can put a dilator, and then over the dilator you can through that you can put a V18, for example, wire, and then put that small sheath in. Again, that's a 2.9 French inner diameter of that pedal access kit, which means you can only pass a sort of a less than 2.9 French micro catheter or a support catheter. It isn't great, but at least it is something. And sometimes I think these retrograde accesses are much easier to cross CTOs. Just a quick picture of the anterotibial artery and ultrasound guidance. The PT is slightly more difficult. That's a typical picture that you always see most of the time. You've got the posterior tibial veins which splits on either side of the posterior artery, preventing your access. I mean, sometimes it's better not to put color and just puncture the tibial artery straight away. Otherwise, you start thinking of AV fistulas and things like that. But we have to ultrasound it and find the correct focal point puncture, which sometimes may be quite high up. Okay. Then there are, again, I'll just go through this quickly. Support catheters. I know most of you use everything. You've got Rubicon, CXL, Trailblazers. You've got the Navicross support catheters. All these are pretty good. In Navicross, I think you've got short links available, even up to 25, 30, I think, or 40. Can't remember. But they're pretty good catheters. The commonly which I use are CXA and Rubicon catheters. Wires, Command from Abbott and the V18 from Boston are among the good ones which I've used. Field FCs, it's a great wire, but the only thing is the wire, it is not heavily loaded. So it's a great for navigation, but support-wise, I don't think it's the best. Then you've got the Medtronic Nitrex. I think it's already in India, and it's one of the best wires to watch for. It's a great support and navigation wire for below the knee arteries. Balloons. I was hoping to hear Dr. Girish's talk regarding drug-coated balloons or drug-eluting balloons. I have found with regards to below knee arteries, increasingly I've been very, very happy with the drug-coated balloon results. The ones which I use are Lumina from iVascular and Impact Adrenal from Medtronic. The reason being, there are lots of trials going on, and we are yet to have like a long 2 or 3 year results. But the initial first year results for primary endpoint of saving the leg is just amazing. It's about 90% with drug-coated balloons for below the knee disease. I'm talking below the knee disease. But I always explain balloons first to angioplasty and then finish up with drug-coated balloons. Post-PTA therapy, now after we have done, we don't forget the patient. Again, we have got the
critical limb ischemia clinic running, and diabetologist. We follow the patient for 3 to 6 months, take photographs of the legs. You'll see that in a short while. Now, for me, the Charisma trial in 2006, which looked at dual antiplatelets. In fact, most of these trials, if you were to go through these trials, all of them are for cardiovascular disease, stroke incidences, death, rather than actually looking at PAD in itself. How good is it PAD? How good is a particular drug for preventing recurrence of that lesion? That's what I think is probably lacking in many of these trials. So, under the two trials, which one I have highlighted as a Charisma trial in 2006, which looked at dual antiplatelets. Again, if you remember, the trial results said that there's not much difference between using a single or dual antiplatelets. But then they had an ad hoc subgroup analysis of only PAD patients, just PAD patients. So in that subgroup, they have said that the dual antiplatelets regime in a short term, you're talking 3 or 6 months, has actually proven to be beneficial. So that's one interest. So I've sort of, accustomed to that bit of the trial results which I've seen, and I tend to use dual antiplatelets for 3 months, and then put them on single antiplatelets throughout their life. The one thing that the landmark trial in 2018 by Narula, and I think it was in, I can't remember the hospital, but it was published in the Journal of American College of Cardiology, where they looked at arteries of amputated limbs, and interestingly, it showed luminal thrombi instead of atherosclerotic lesions. So the question is this a thrombi-dependent mechanism in the pathogenesis of many PAD, and hence will they benefit from something like warfarin or rivaroxaban? And so those are the questions that are still going, but I still tend to use dual antiplatelets post-PTA therapy. So I'm just going to quickly go through these cases. 51-year-old.
We have some limited time. Can you quickly go? We have.
Okay. So how much time have we got?
Yeah, I think another few minutes.
5 minutes to the max, or 2-3 minutes?
2-3 minutes.
Okay, fine. I'll just quickly go through the slides. So these are pre-operative. There's pre-procedural slides of a patient. We did a crural angioplasty. Let me just see if I can. So you can see the AT is deceased, and these are ones which I used with. Yeah, so that's just showing you the crossing. I've used a Rubicon catheter here with a triaxial system. It was a retrograde puncture. I'll remove that. So I got the access from down and then passed it all the way, and then angioplasty. It was I just used using a drug coating balloon. And you can see the recanalization, but I'll show you. I will skip through all the slides. So immediately we took them for debridement, and this is back in 2019. In September 2019, it's been like that. So that's one. I'll show you one more, couple more quickly. So you can see this foot which doesn't look good with the third foot gangrenous. This was an SFA, complete locution with no runoff at all. And she was not fit for surgery of any side, so she was doomed for amputation because she had ascending sepsis. And I think, so there's nothing, so I'll skip the SFA popliteal angioplasty. And then after establishing the popliteal angioplasty, I angioplasted the AT and finally created the arc, and then used a drug-eluting balloon to complete the picture. So quickly, so that's recanalization of the AT. And there's a bit of spasm, but that was the third toe and slough excision on 7th of November 2019, and 4th of this is her foot now. And this is the last slide I'll show you. The last case which I'll show you, a very bad foot with tendo-Achilles tendon exposed. We were planning for salvage angioplasty. She had a bit of renal dysfunction, so I decided to use CO2 angiography for most of the procedure. It's impossible to use in crural arteries, I think. So you can see SFA and popliteal are fine with the CO2 negative contrast. Let's take a look. Yeah. So this is, yeah, and then you can see this, the significant rural disease. Again, this was this I wanted to show you a bit more clearly, but let's forget about that. This was an access from the posterior tibial artery via the perforating into the peroneal. And then I angioplasty. So that's a peroneal artery. Just I don't think it's a PT. It's just been how it's been taken. So you can see this very clearly. The peroneal artery is, and then you can see the blush of the Achilles tendon. So she had excision, and this is back in 2019. So I'll stop there. I won't show you any more pictures. But thanks for the time. I'm sorry for taking this extra time.
Thank you, Rohit, for an excellent lecture. So any questions are there, Srinivas Kumar? You have the list or any chat box?
No, I did not receive that. Some questions are on drug-eluting balloon usage in periphery. We missed it. Can anybody of you comment what is your opinion on usage of drug-eluting balloon?
Nair, I think you can take this.
Yeah. I mean, see, for the below knee arterial disease, I think using drug-eluting balloons have always been very beneficial. Because I've had sets of patients where I've used plain balloon angioplasty and they have come back with recurrence. And for me, the primary endpoint is the healing of that particular ulcer or saving the leg. So I have definitely had better results with drug-eluting balloon. In fact, there was a Luminor trial which was done recently last year, which showed 92% patency in 1 year. This is for below the knee artery disease.
I think after seeing all those pictures, it looks like we should never give up. Always try to revascularize, do something, and the human body is great. It heals itself. And many times patients were told to amputate, and we did something, and we could save limbs of these many patients. All of you could have such experiences. Jain and Kanna, if you have anything to say, otherwise we'll conclude. People are waiting for the next session to join. So final comments from both of you. Mantosh Panja sir is there still, or is
Yes, sir is there. Sir is there.
Yes. Any comments, sir? Dr. Panja, can you connect? Get him live, Dr. Mantosh Panja.
He's alive.
It was probably a very good session, especially I liked the talk of Dr. Bashi, and Dr. Vimal. So it was 3 controversial topics of small aneurysms, type B aortic dissection, whether to do elective early and repair and the surgical thing. Dr. Bashi, of course, is one of the best surgeons in the world for aneurysms.
Sir, Bashi sir, a small comment. You're looking so smart. How do you maintain that?
COVID. That's a secret.
And COVID is also helping us to maintain.
Very nice, sir. Very nice.
Secret of working long hours in the
so no pollution, no need of going outside.
That's why I always say the best place. We are all lucky to be working in the most sterile environment in the world. When my assistants used to complain, I used to say, as surgeons, we are very, very lucky, I would say.
Yeah, thank you, sir, for joining. Final comments from Dr. Mantosh Panja. Sir is online, I think. You can go ahead, sir. Anything
you have to demute him. He is muted. Sir, unmute yourself, sir. Panja, sir, unmute yourself.
Doctor, as sir is getting on, Dr. Jain also did a lot of funny, wonderful things in this COVID times. We will share with you in the COVID challenge contest, which we posed to all the cardiologists. And we wish everybody should practice that and try to do something innovative, something good in there when you get some time, because of forced time, at least because of less decrease in emergencies, cardiac surgeries, as well as interventions. So we need to acquire some new skills or develop some new special interests, or at least become fitter or smarter like you, sir. Okay. Thank you. Dr. Panja, are you there? Because we are getting delayed. If it's taking more time to get Panja, we'll skip to the next session. I see him. I see sir. Why?
Sir is not able to unmute himself. I don't know why. He is not able to unmute. Can somebody unmute him from here? I don't know.
I think he has to do himself.
He has to himself do it.
Yeah.
that I'm an unabashed femoralist. And I've been a femoralist ever since I started practice. And I still stand by it in spite of the avalanche of radial interventions. And I still have a majority of my work through femoral axis. And all of us who know that the description of the Seldinger technique was, I mean, in 1953, and this is the technique used to do angiographies and to get femoral axis. And the only way to address the puncture made by it was the use of manual compression. Having said that, there has been an evolution of vascular closure devices, and we know that from there on, we have had other devices which are coming either external or internal to help and close these vascular access sites. And the basic problem has been, the basic attempt has been to reduce the time to hemostasis, enable early ambulation, and improve the patient comfort. So having said that, before we proceed to the point of vascular vessel closure, let's look at the anatomy of the femoral artery, which is what we use commonly as an axis from the groin. The point to note is the inguinal ligament, the inferior epigastric artery, which comes out just and turns around the inguinal ligament, the external iliacs, the common femoral, and the bifurcation into superficial femoral and the profunda. The landmark of the inguinal ligament and the internal epigastric artery is extremely important, because if you cross this area, the chances of complications and an inability to hold the vessel on the femoral head becomes a problem, and thereby leading to more complications. This is the anatomy in the lateral view. Once it goes over the femoral head, it dips into the pelvis, becomes retroperitoneal, and follows a course to join the aorta. Key considerations as far as femoral axis is concerned: the location of the puncture, the size of the vessel, and the disease associated in the vessel at that point. And of course, the factors with respect to prior aortofemoral bypass, presence of stents or grafts, calcification of the vessel, and if there is groin scarring from previous procedures, which may make puncture difficult, or vascular closure devices difficult to reach the vessel. When you puncture a femoral artery, fluoroscopy is extremely important to place the puncture point accurately. The groin fold may not necessarily be the right access point to access a femoral vessel. So this is the groin fold may actually be much lower than the femoral head. And what you need to do is you need to target the mid-femoral head for a puncture site. The fundamentals of anatomy there are that the common femoral, the bifurcation of the femoral artery, 56% is below the inferior head of the femur, 22% at the inferior head of the femoral head, 17% between the inferior border and the center of the femoral head, and only about 5% is above the center of the femoral head. All these points become important because when you are closing these devices, these punctures, either manually or using devices, we need to make sure the puncture is clean, the puncture site is appropriate. Otherwise, none of these devices will help you in getting a proper hemostasis. So you ideally target the medial third. You divide the femoral head into 4 quadrants, target the medial third, lower third of the femoral head, and you are unlikely to go wrong at the puncture. Normally, when you use a manual compression, you compress it across against the femoral head. So anything above that or anything below that can be a problem as far as punctures are concerned. The level of entry of the vessel is also important. You need to guide the vessel at about 30 to 45 degrees, which of course facilitates the guide wire passage, keeps the sheath properly aligned, prevents leaking around the sheath, and gives unnecessary hematoma formation while the sheath is inside the vessel. When you do a vessel closure, or you need to look for any issues there, you do a femoral angiography. Always bend the sheath away from the femoral artery and take 2 views. One is a RAO and one is a LAO. Because in the RAO, you get the bifurcation right, and in the LAO, you get the origin of the inferior epigastric artery right. The LAO view obscures the bifurcation. You may not be able to see it properly, but then a combination of these 2 views will give you a great idea as to what is the level of puncture. Like I said again, three options, there are three issues: location, size, and disease. Location should be below the inferior border of the inferior epigastric, above the bifurcation of the superficial femoral and the profunda, and the size, the CFA at the sheath incision site should be more than 5 millimeters in diameter. So that's the ideal. That's an approximate area where you can puncture the vessel. So, and these are the two views, like I showed you in the earlier one also, where in the LAO view, a bifurcation is not well seen, but you can see the origin of the inferior epigastric artery quite well. Avoiding access site complications. One is high punctures above the inferior border of the inferior epigastric artery. Second, of course, is a low puncture below the femoral head and into the superficial femoral. And the third, of course, are diseased vessels, which cause complications. You can, of course, you can use an ultrasound guided puncture to be absolutely sure as to where you're puncturing the vessel. And this is one of the techniques that can be used in obese patients or in patients where you can't feel the femoral artery very well. And this can help in reducing the complication rates. The complications of incorrect access site complications are well known to most of us. And this is one thing which the radialists harp on. The complication rates of femoral punctures are very high. Hematomas, pseudoaneurysms, AV fistulas, thrombotic occlusions, embolizations, and retroperitoneal bleed. Now, of which pseudoaneurysms and retroperitoneal bleeds are something which we see not so common, but are amongst these complications. These are the most common complications. Pseudoaneurysms happen when you have a inappropriate site of puncture, inappropriate compression, and there is a connection between the artery and the overlying hematoma, and blood flows intermittently into it during systole, and it sort of maintains the hematoma there. The risk factors, like I've shown in this: low femoral punctures, large sheath size, ineffective manual compression, patients already on anticoagulants and on fibrinolytics, older age, and arterial hypertension. Retroperitoneal hemorrhage has been the bane of all femoral interventions, and something which we are always worried about when we have a patient developing hypotension on the table, or you have a high puncture or multiple punctures to access the femoral artery. And the commonest reasons are high punctures, use of additional blood antiplatelets or glycoprotein 2B3 inhibitors. And by any chance, if you counterpuncture the posterior wall while doing a femoral puncture, the complication rates are pretty high. These are the summary of findings of retroperitoneal hematoma. The series vary from 0.2% to 0.74%. One series has a 4% mortality. Otherwise, the mortality rates were quite acceptable. AV fistulas can happen due to large bore catheters, aggressive anticoagulation, and again, poor access site location. And therefore, it's important to master the technique of proper access to the CFA before the procedure, so that you can reduce the complication rates in these patients. And coming to the methods of achieving hemostasis, manual compression on the femoral head has been what we have been doing for donkey's years. There were devices which came in with assisted compression on the femoral side. They were bulky, they were painful to the patient. And then, of course, the era of sealants, collagen-based and clot-assisted, which are both clot-assisted techniques, and the suture and nitinol-based, clip-based techniques, which have come in over the last 8 to 10 years. Manual compression has always been a problem, where you need to immobilize the patient for 8 hours. Everyone is unhappy with that. And of course, the patient moves, like the chances of bleeding are high. And you land up with an unhappy patient at that point of time. The need for closure arose because of these challenges and the fact that the patient had to be immobilized for a prolonged period of time, delaying hospital discharge. So you can close the vessel on the table and avoid post-procedural access site complications with a well-performed access site closure, which I'm sure the other speakers will be speaking about. I'm just going to touch on these. You have clot-assisted techniques, depositing material with coagulation-inducing properties. You have the benefits of mechanical closures, like I said, faster mobilization. And of course, you don't need compression, and the patient is also pretty happy with that. But the problem with mechanical closure has been the learning curve. But once you get the hang of it, you can close most of these punctures on the table with a reasonable amount of confirmation. The types of devices available today are the ones are basically AngioSeal, Perclose, StarClose used to be available. And of course, we had ExoSeal, and we also had the FemoStop once available once upon a time. But I don't think it's available anymore. Not in Mumbai at this point of time. But amongst these, in terms of the innovations, the Perclose, Proglide, and the Starclose have been the newer ones. And what we normally end up using are either the AngioSeal, which was launched in 1996, but has now got the newer version of the AngioSeal, which is a much better procedural technique. And of course, the Perclose Proglide, which was launched in the year 2004, has now become a standard in closing a lot of closure sites. Starclose launched in the year 2008 for 5 to 6 French devices also. And what I use in my practice are basically AngioSeal and Proglide. The only advantage with either of these is that the only problem with AngioSeal is that you cannot re-access till the collagen gets reabsorbed. Proglide, you can do an immediate repuncture. And it has a longer learning curve as far as the Proglide is concerned. The AngioSeal doesn't require as much of a learning curve. If I were to summarize, attention to the femoral punctures need to be given with utmost sincerity. Closure devices are useful, particularly with larger accesses. Safety profile on current data seems quite reasonable, and improper use has significant penalties. You need to have a judicious patient selection. Check out the groin first. Check out the puncture site. Check out the presence or absence of branches on the side of it. Make sure you're away from the bifurcation, and then go ahead and seal these vessels. Thank you very much.
Thank you. Thank you, Dr. Menon, for this complete nice presentation on vascular closure, the concept and the devices which are available. So, this is very good for big holes, but for routine angiographic or angioplasty situations where there is a 6 French or a 7 French. So my co-chair, Dr. George Joseph, is here. So I would like to take his input on this, whether there is enough data to show that the device usage is of any benefit in routine situations, which are 6, 7, or 8 French. Yeah, Dr. George.
I think it does make a difference in a patient who is on, say, dual antiplatelet therapy and maybe anticoagulation post-procedure, and you want to get the sheath out. And in that situation, I would strongly recommend to go for a closure device, even if it's just a 6 French, because it gives you a much more security with the groin than just manual compression. Plus all the advantages just listed out, the comfort for the patient and quicker ambulation. So it's always worth using a closure device as long as the cost is not a major issue. And if you have done a major PCI, then I think the little bit of extra cost that a closure device entails is worth it, I would say.
Can I say something here? The advantage is that you're leaving the groin. I mean, if you do a femoral technique, you're leaving the groin to someone who's an MBBS or a fresh guy, graduate, to compress the groin. And most of these guys are busy with a lot of things. They don't give an adequate compression after 6 to 8 hours, and a complex procedure turns into a nightmare because of a groin hematoma. I think like George said, where cost a major concern, adding another $10,000 to the cost of the procedure is well worth it, because at least you're getting a good hemostasis by the time the patient leaves the cath lab.
Yeah. So I think that is a very good viewpoint. But the only issue is, I totally agree with George and Ajit, but the only issue is that the studies which have been done have not shown any reduction in vascular complication sites when these devices are used for routine situations like angiography and angioplasty. I'm not talking of big holes like 16 or 18 French. I'm talking of 6, 7, and 8 French situations. So Satish wants to probably say something on this. Please go ahead.
So I tend to agree with Dr. George and Ajit vehemently, for the simple reason that I'm a hardcore femoralist as well. Unless it's an acute MI, I don't think I would ever look at the radial, or if it's a simple, clean in and out angiogram. My logic is this: we're all going to do large bore access. You don't want to try your devices first on the large bore access. There's nothing wrong with trying it on the 7 and 8 Frenches. You might as well get used to it on the 7, 8 Frenches, so you'll be great on the large bores.
So I think we have logics for all usage of but I'm just talking of absolute data which we have. So
I know. That's why I said, even if you look at the absolute data, it might not show benefit, but it doesn't show worse.
Yeah.
So then that's what I was saying.
Okay.
I think the next talk by Rajesh is dealing with it, sir. Let us allow him to talk. There's a slightly behind schedule. We have a live case coming up, sir. Please be particular about the time. Over to you. Dr. Rajesh will have the next talk.
Yeah.
Introduce.
So, hi, good evening, everyone, and thanks TCT India for the invitation. Good evening, Dr. Chandra and Dr. George. Let me talk about what our discussion was going on about the literature. So let's have a look on how the closure device do help in achieving the hemostasis. So SSI management play an important role in the outcome of the successful PCI. And then we all know about that vascular SSI bleeding can lead to increased morbidity, mortality, cost, and also the length of stay. So there are various ways to control the local bleeding access site, and then vascular closure device did show a promising result compared to the manual compression. The limitation of manual compression is that it do have a prolonged compression time, which may extend to more than say 15 minutes. And the ambulation is again more than 6 to 8 hours thereafter the patient is mobile enough, and then there is an increased risk of vascular complication, especially in those patients who are obese, have prolonged ACT, on GP2B3 inhibitor, and do have a larger seat. When vessel closure device has been introduced in 1990, and the aim is to have a rapid hemostasis, early ambulation, and increase the patient comfort and reduce the bleeding and also the vascular complication. As Dr. Menon has already mentioned about, there are 3 types of devices. It's an active approximator, which use the suture or nitinol clip, passive approximator, which use the plug or gel, and the external hemostatic device, which is just an alternative to the manual compression, where you do put certain devices to have a mechanical compression instead of the manual one. So regarding the active approximator, it's a Perclose ProGlide, which is commonly being used, and the advantage is one can have an immediate reassess at the local site after using it for the next intervention. It doesn't have any intraluminal material, and therefore there is no risk of ischemia, limb ischemia, or peripheral embolization. And the disadvantage of the ProGlide is that it do have require a technical expertise to use it, and because of lack of technical expertise, sometimes the failure rate is too high, especially when there is an initial experience of using this particular device. StarClose is another one which also act on a similar way. There are a few passive approximator like collagen plug. Angioseal is the one which is widely being used. It contains the absorber intravascular anchor with extracellular collagen plug. There is a problem with this device in case it's incidentally been deployed within the intravascular system, within the arterial lumen. There is a risk to have embolization leading into ischemia. And then there are a few other devices which Dr. Menon has already mentioned about. This is about the external hemostatic devices. It can be, say, a inflated bubble or a disc which has to be placed over the site of the puncture and have a manual compression. The commonly used devices are Angioseal and the ProGlide. These are the 2 devices which are in common use. Regarding the Angioseal, it's has a certain disadvantage, like it causes more of vessel narrowing, greater peri-adventitial inflammation, immediate reassess may be difficult, intravascular plug embolization, limb ischemia is a problem in case accidentally you have deployed it intraluminally. And of course, it's technically easier compared to the ProGlide with a failure rate of around 2.9%. Regarding the ProGlide, it's less of vessel narrowing is there, less scarring is there, immediate reassess can be done. However, it do need expertise with a failure rate of say 5.9% initially when the experience is not there, and it can also be used in the peripheral arterial disease. So one is the trial, initial trial, the CAP trial, which is the randomized trial comparing the manual compression with Parclose and the Angioseal, has shown that early embolization and local bleeding complication are far less compared to this device, compared to say manual compression. And in case you talk about say between the two Parclose versus Angioseal, it is found that the failure rate is quite high with the ProGlide compared to Angioseal. It's all because of say technical expertise which is required for using the Parclose. The complication associated with the vascular devices like bleeding complication, growing bleeding, hematoma, retroperitoneal hematoma, arteriovenous fistula, etc. There is also one complication which is associated with these devices is like the infection, especially those with the ProGlide when the distal end of the device do go intravascularly, and therefore it is very important whenever you are using this device, you have to have all aseptic precaution to be considered. And then there is a risk of the failure for this device, which of course is more with the Parclose compared to the Angioseal device. Regarding, as Dr. Chandra was talking about, there is a conflicting data about the vascular complication and effectiveness of these devices. It is very clear with various registry data and also the meta-analysis that these devices do reduce the bleeding and also the vascular complication. They do reduce the bleeding and also help in early mobilization. Regarding the vascular complication, there is a conflicting data. There is no clear evidence that it reduces the vascular complication as well. But then the pitfall of these various meta-analysis and the older data is they have not used the newer generation devices which are more effective compared to the older one. This is the largest registry data of 18 lakh patients where they have used manual compression with the mechanical compression and rest of the vascular devices, and it is found that Parclose and Angioseal is the one which reduces both bleeding and also the mechanical complication compared to manual compression. This is another study of 12,000 patients which has shown that the vascular complication is significantly less when it is used for the PCI patient to the tune of say 42% reduction in it. And in case the device is being used for say those with the intermediate and high risk for the local bleeding complication, which is found to be very effective in decreasing the complication. A systemic review of various randomized controlled trial by Cox et al. Has shown that these devices are associated with a shorter time of hemostasis, ambulation, and discharge, leading to cost reduction compared to the manual compression. And then there is no overall difference in the complication rate between the manual compression versus closure devices. Another review by Cochrane has shown that suture-based ventricular closure devices reduce the time to hemostasis when compared to external compression. There is no difference in the vascular injury or mortality with these devices compared to say external compression, and there is no difference in efficacy or safety of various devices per se. So in case when you are supposed to compare say with transradial approach versus transfemoral with the vascular closure devices, what's the comparison? It is found that after completion of the learning of the two techniques, say radial approach versus transfemoral approach with the device, leads to elimination of access site complication. However, the transradial access do have a better turnout compared to transfemoral even after using the vascular devices, whether it's access site complication or a bleeding complication. So in case you are going to compare say transradial with transfemoral and vascular closure devices, the access site complication and bleeding complication are far better in transradial approach compared to transfemoral. This is our personal experience at the PGI. By now I had done around 1300 ProGlide from 2013 onward, and
Hello. I can't hear anything.
Yeah, we
In
can't hear
my
anything.
study about
We lost him, huh? Did we lose
The
him?
slide is gone.
Hello.
Yeah.
Can you all hear me?
Yeah, yeah.
Okay, so
Yes.
We are all audible except
Rajesh, correct.
Hello. Can you hear me? Mic mute. Sir, one small request. for 2 cases, but one is recorded and one is they are doing live. I think other panelists also to join. And thanks everybody for joining, sir. Over to you all. I see Dr. Rath sir also. And good evening, sir. And over to you. And they're ready live with for the case from SIMS Hospital, Ahmedabad. Over to you, sir.
Hi, everybody.
Hi, Matthew. Good evening.
Good evening. Good evening.
From you are in Chennai or Mumbai?
I am in a enviable place. I am in Muna.
Oh, that's fine. Nice place. Best to be around.
Yeah.
They have started the video, sir. Then you can comment. Agit song.
Dugal.
How are you, sir?
Good. And everybody is here.
That was the song.
Dr. Dugal, how are you?
I'm very fine. How are you?
Fine. Nice to see you.
No, I've been seeing you for a long time, but you're busy.
Yeah, it was not
coordinating.
Muna is getting better now.
Let's go to C.
Yes, sir. We can see you. Dr. Rath, you can talk. Samuel, sir.
Yeah.
Hi, good evening. Can you hear me?
Good evening, Dr. Parikh. We can hear you very clearly. And we saw your hospitals, beautiful video. And you can start. Dr.
Yes,
Matthew
we'll
is
start.
there. Dr. Dugal is there. All are there. You can present your case and start.
So we'll start with brief introduction of the team. Dr. Urmil Shah is my partner for 20 years. He's an interventional cardiologist. Next to him is Atul Kalpesh, nurse and technician. And then we have Raj from Abbott. We have Vineet.
Hello.
And Vipul will be running the OCT. Let's put the first slide on, presenting the patient's history. Can we get the first slide on? Yes. So this
we can see
this is an elderly lady, 80-year-old, who came last night, highly unstable, new onset symptoms, echocardiography, 35%. Let's go to the next slide. The ECG on arrival was showing gross ischemia suggestive of a proximal LAD, possibly left main triple vessel. Troponin was positive. So we decided to take her for the live case today. And we did bring her to the cath lab around 6:15. Got her on the table, getting ready for you. She became very unstable on the table. So let me show you the film. Let's go live on the D camera. Are we there on the D to see the angiography films? Can you see the first run? So this is a RAO caudal. Next view.
Can we the full screen of the angiogram and all? It's very
Can
small.
we go full screen on the angiogram? Open the door. Full screen. Okay. Better now? Full screen
I
on the
don't know.
angiogram.
It's a very small screen we are seeing here.
Can you go full screen? So.
I think at the
Just full screen. Can you go full screen?
Now I think
Single screen. Is it better now or you still seeing?
Yeah, it's
small?
very clear now.
Okay. Next view. So it's a critical proximal LAD, long lesion, calcified. Next view. There's a tight ramus also, intermediate ramus. Next view.
there is a large OM with a critical lesion too, and RCA is total with collaterals from the left to right. Next view. So RCA is total. So we decided to go ahead and didn't wait for us to go live. So we went ahead and crossed the LAD. So we put EBU, and this is where we are. We are actually way ahead. So we'll go ahead. We crossed with the wire. We took a run through floppy wire. Next. And patient was very unstable on the table. So we did the preliminary balloon dilatation. Next view. And I'll tell you, we have a question for you, but we went ahead. So we pre-dilated artery, again occluded with the introduction of the balloon. Next view. Next. So the artery is opened up, patient stabilized and went with the OCT. Next. 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 And let's see what the OCT showed. Let's go live on OCT, large screen, station B. So Vipul, loudly, if you can tell what you found in the OCT. Loud. Can you hear?
No, not at
Yeah,
all.
we can hear.
So this is the OCT picture
Loud
of the
one,
patient,
Boomer
OCT
sir.
run of the patient, and this was the listal reference landing zone of the patient. And as I go proximally, you can see, yeah, so you can see that there is heavy calcium, both superficial as well as deep, throughout the vessel, and thin cap fibrous atheroma. So it's basically a fibrocalcific plaque with in between interspersed dissections caused by the balloon dilatations. And you would find as we go proximally, there is a lot of calcium, significant, very tight lesion. And also you will find some thrombus in the proximal LAD. Here you can see the fresh red thrombus, which is in the lumen, and which suggests that there has been, this is an acute thrombus and with dissections. And this is the proximal LAD, which was our reference landing zone for the proximal segment. When we look at the dimensions, we found that the proximal dimension was about 3.25 and the distal landing zone diameter was about 2.75. So we took a 3 millimeter, we advised a 3 millimeter stent, and the length was 38 millimeters.
So we'll go next. So
Just wanted to see the left main.
Yeah, okay.
Geographically,
show the
just
left.
focus on left main.
Okay, okay. So
There
this
is a distal left main disease.
right. So this is the circumflex bifurcation. This is the ramus coming from here, and now we come to the distal left main. This is the left main. Again, as you can see, there is calcium here, circumferential calcium, and this is the body of the left main.
So it's involving the proximal LAD also, isn't it?
Yeah,
Ostium
exactly.
part of the-
Yes.
Ostium.
It does involve. This is the plaque here at the ostium of the LAD. And so we thought that we can possibly, not make it very complex and possibly start from a little away from the ostium, about 4 to 6 millimeters away from the LAD ostium.
What about the origin of circumflex? Can you show us?
Yeah. This is the this is the circumflex origin.
So it's free from disease.
Yeah, it looks free from disease.
So we decided to leave the ostial LAD, put a 38 millimeter Zion's expedition. So let's go next on fluoro. Fluoro D. College karne bhai. So next. So what we did was we created a very nice bed with a 3O balloon, opened up the LAD, patient was slightly stable now. And this was right around 6:45 or 7-ish. Next. So we created a bed with a 3 millimeter balloon. Next, keep on going. Next. And this is before we put a stent, we had made a decision that if we faced too much calcification, we had IVL balloon and the shockwave system ready with us, because since we had already dilated with 2 millimeter, instead of going with rota, we decided we'll go with shockwave. But fortunately, and we have one more case with shockwave for you. So we put the stent, next, dilated the stent with post dilatation, keep on moving, keep on going front, keep on going, and then come to the last OCT where we have an issue we'll discuss with the panelist. So we did post dilatation with 3 millimeter, and this is where we are. So we did the OCT post dilatation. Next, next, next. Good. Stop there. Stop there. Okay. Now what we'll do is we'll go back to the OCT. OCT on the main screen. B.
Right.
In the OCT, what we found after the post dilatation, there was some blood and come to the proximal segment. The rest of the stent was well apposed, come proximally.
Yes. So as you can see, this is where the stent ends, and at this point, just proximal to the stent edge, there is a small dissection, possibly ending in the plaque area. So this is where the dissection is just, at the ostium of the LAD.
But the angiography view shows very mild dissection.
And as
so,
for the, yeah.
Proximal LAD.
Yes, proximal LAD.
Dr. Parikh,
yes.
little discussion about this planning. I would have planned in a different way.
Sure.
It's a long lesion involving the ostium LAD.
Yes.
And what I would have, and circumflex is free from disease. And ramus.
But there's a ramus which is diseased at ostium.
Yeah. So
I crossover.
Okay. I would have thought I would have covered the left main also. I would have used 2 stents with 38 is I would have used 2 stents and distally a smaller one and the other one proximal one covering the left main because ostium of the LAD was totally involved.
Yeah, but then my ramus would have been trapped, and ramus is a moderate vessel which we are planning to do stage plasty.
So in that case, probably I would have done the ramus first also after this ramus, and then I would have planned.
Now, as an 80-year-old lady, my debate is, what is the expectation of the progression of that 30% ostial LAD? So that was the decision we made and then went ahead. Again, if you see...
No, that is the other way of doing it. You have done it for 80 years, taking clinical scenario into consideration.
And if you see very minutely in this view, there is in the spider view. Can you enlarge the spider view?
Yeah.
So the spider view, ostial disease, and then there is another plaque. There is OM. So
and OCT confirms that the proximal ostial lesion of the LAD is insignificant. Still, you would like to stand from the left main?
It all depends because I would have. It all depends whether we are planning to do the ramus and that circumflex disease. Because if I am not doing, if I am doing it, I would have done it first. Or else it would have been very difficult to, if you put a stent, it will be always on the left ostium of the left LAD. So it will definitely injure further. So instead of that, it's better to cover the left main. That's my argument, logic for it.
Now what I'm doing is, I'm trying to see if I can do one more last run of the OCT.
See,
and reassess.
I tend to agree with the Keyur's philosophy. Now, he has got a total right. The patient has got disease of the circumflex, ramus, and LAD. He has non-critical disease, and patient is unstable. Probably his philosophy is that he will the mid-segment lesion or proximal lesion away from the ostium and stabilize the patient, and he bring the patient back for a second stage. Because with the right total, it is reasonable to think like that. If so, he would worry about the ostial LAD as well as the ramus and at the second sitting, probably would make the procedure a little safer. That's what his contention is. There is some reasoning.
Yeah, it is there, but it cover it all. If the left main circumflex ostium is stable, it showed that OCT doesn't have much disease. And if you are not planning to, if you want to open the ramus, you can do it. You could have done it before also. Now also you can do before putting stent, and then you can cover the left main. But all depends on the condition of the stable patient, because patient was unstable, and if it tolerates, then you can plan it a little elaborate.
So we are almost done here, and we did a last one run of OCT because we did post dilate with a 3.5 proximally. There was some malapposition, and I'm seeing. Did we get a good view?
Yeah, we did.
So we are processing. We'll
critically look at the proximal end of the stent. That is the area of
yes, of concern. So we'll come to the proximal. And can you show the dissection if it's still there? And it should be.
Yeah, there is.
So there is a dissection. Vipul,
yes.
Can you comment on the dissection
as
to why we are going to do anything there or leave it alone?
Yeah, I think the dissection as per the criterion, it is less than 3 millimeters and angle is less than 60 degrees. And there is no, there is no flow limitation on the angiogram. Possibly we can leave it. We can leave it here.
I can see Nick shaking his head. Nick.
No, I'm nodding in agreement. I completely agree. I think what we've learned about dissections is that dissections with OCT, if you use OCT a lot, you see them an awful lot.
Yes, that is what we were debating. Where one of our partners recommended putting a stent. However, I agree that with the OCT, we see so many dissections, but I think the criteria that this small dissection should be left alone.
Absolutely. And as you say, the European consensus document says 3 millimeters or a 60-degree quadrant. Or as you'll be aware, Abbott, we have a novel algorithm, and we would say if it didn't involve the media or wasn't extensive, we would leave it. And it certainly doesn't, it doesn't go more than a quadrant. It doesn't look like it goes to the media. And I think angiographically, if you hadn't used imaging, you'd be none the wiser and you'd carry on. So I think your strategy was fine. So and I think the OCT bears that out.
We'll go to the next case. Exactly. We have two cases, one about 20 minutes, one about 10 minutes. Do I have 30 minutes? How many minutes do I have? Srinivas?
Who is keeping the clock? We are already behind schedule.
Then I'll do the 10 minutes one.
Live case, let him finish, sir. We can have.
Interesting case with IVL shockwave.
You
so
can
let's
proceed with the case, sir. We'll adjust the time.
Yeah, so we'll do that. And then the third case, which we did also. So let me go and give me 2 minutes. Vipul, why don't you come here with the slides?
Yeah.
Any comments from other panelists? We have Shashigiri.
Slide
I am Dr. Ravi Kalra. Good evening, Dr. Matthew, Dr.
Good evening, sir.
Nice
Good evening, sir.
Any comments? All of
Can
us.
you go A and E? E come with the slides.
I was just wondering why the dissection.
Those minor dissections thought can be left alone, and that's what I think an elderly lady, when he's trying to do a very unstable patient, is trying to go ahead and do it. And let him go for the next one, sir.
If he's ready. If he's ready, yes.
Yeah, we are ready with the next case. And This is a, are we on the screen?
Yes.
Let's show the history of this patient. This is a 73-year-old male, hypertensive, unstable angina, who had an anterior wall MI. And yes, so it's a patient admitted with anterior wall MI just right before the lockdown started. This was in February. He had a failed angioplasty. Failed angioplasty. They could not open the LED properly. They could not pass the stent. Patient came back, significant angina, heart failure, and we'll go ahead with the case. Next slide. So let's see. Just jawab do na video challenge. So again, the case history is there, and we'll come to the live case. Am I audible?
Yeah. Very clear.
So this is a patient where the LED was unable to be crossed with the stent at an outside center. We brought him to the cath lab, very unstable. This was about 3 months ago, but we recorded most of the case. So this is what we had. And right coronary was dominant right with faint collaterals. And we took a BMW pilot and tried to cross the totally re-occluded LED. And you can see a lot of calcium in the left main LED. And the other side shows the fixed images. Ready? So we were able to cross like the previous operator, and we did dilate again with the tube balloon. And then we decided whether to go with the rota or IVL. And we had done few IVL cases with very successful result. So we decided to go with IVL, intravascular lithotripsy. And this is how it was set up. The shockwave catheter. And you can see on the slides the shockwave catheter opening slowly, and then we started dilating. And this is the video which I'll show. Turn on the video. Can you go video with the sound?
The shockwave intravascular
Is the
lithotripsy
sound
system
coming?
creates pulsatile sonic pressure waves to modify calcium in a safe manner. It consists of a compact rechargeable generator, a simple connector cable, and an intuitive catheter, which houses an array of lithotripsy emitters enclosed in an integrated balloon. Through the localized delivery of lithotripsy, the IVL system
Mainly
minimizes
for the
trauma,
interest of
optimizes outcomes,
lot
and
of
simplifies
younger
procedures.
cardiologists. And again, IVL is still not prevalent.
In a
By the
standard
time it got
technique,
released,
the IVL
we ended up
catheter
with
is
this
advanced
COVID.
and placed at the
So-
lesion using marker bands under angiography, with the integrated balloon expanded to subnominal pressure of 4 atmospheres by a mixed saline and contrast solution. The fluid within the fully opposed balloon acts as a coupler to facilitate efficient energy transfer of the sonic pressure waves into the vessel wall to reach the calcium. The generator produces 3 kilovolts of energy that travels through the connector cable and catheter to the lithotripsy
There is a
emitters once
dissection.
per second. While other treatments can't differentiate between calcium and soft tissue, acoustic pressure waves pass through soft tissue to impact
You can
both
see the
intimal
green
and medial
blinking
calcium.
when I do
With
the
emitters
pulse.
along the length of the balloon, a localized field effect is created. A small electrical discharge at the emitters vaporizes the fluid within the balloon.
So IVL fractures concentric and eccentric
Depending how calcium
differently.
presents, the number of IVL pulses to achieve an optimal result are different. When the IVL balloon expands in eccentric calcium, the emitter moves away from the calcium, since the soft tissue is not constrained. The farther the emitter is from the calcium, the less energy is able to reach it, so more pulses are needed. While each pulse's energy is identical, shock waves crack concentric lesions quicker due to the rigid ring of calcium that traps the energy, leaving no other paths to dissipate other than cracking. Waves also reflect off calcium and impact the calcium in the opposite wall. In eccentric lesions, most of the waves pass through the soft intima, and there is negligible benefit of reflecting waves. Regardless of how much energy is required, the efficacy of the shock waves is evident under angiography.
So you can see that we did full cycles, but there is still more to come here. So the artery did open up, and then we debated whether we should post-dilate, which is what's recommended, or we should go ahead and try the stent. So we did go ahead and try the stent, which we'll see in few seconds. So now we are going with the stent, and as you can see, I was amazed that the stent was able to cross without post-dilatation. This was with 2.5 IVL balloon. There was a question, Dr. Matthews?
Yeah. Yeah, go ahead.
Yes, we did a OCT before the stent. We did short calcified ring. It wasn't unusual. Very heavily calcified artery, and then we put this stent. So Onyx, 38 millimeter.
And diameter?
3 millimeter.
2.75.
2.75. But I need to show you something what happened mainly for a lot of Rajasthan's audience.
No, there is still a debate for a 2.75 or 3 millimeter vessel, whether 2.5 millimeter IVL that is enough, or we should have a 1-to-1 sizing.
With IVL, they do recommend one size smaller. 1:1, sorry, 1:1.
1:1, yeah.
Now, if you see here, what's happened to the large diagonal? What's happened to the large diagonal? Patient actually became unstable again. There's a large diagonal.
Which got closed, huh?
Which got closed. So was it a thrombus or a dissection? So obviously we went again, we had the OCT available with us. It was ready. So we went with the OCT, and OCT showed a dissection.
Yeah, usually it is that.
And we needed one more stent, and we should be done in 1 minute. So we did the reverse T stenting here. But again, the message I want to send to people is that you should have imaging in your labs. Imaging is amazing. Either IVUS, OCT, preferably both. And if you invest in anything, that's the first thing I would invest once your cath lab is there. So we did a reverse T stenting and ended with a kissing balloon. It's been now 5 months. I just saw him last week, and patient is doing very well.
Here, there is one anomaly, which is what I've seen is more you use all these imaging modalities, more complications you see, more dissections you see. We don't know whether we should do, whether we are right, whether we should do anything further. So it is not something very simple. Unless we are very sure about how to identify these dissections and small things what we pick up on OCT and make our judicious decision, you will end up with doing too many things which would lead to a lot of other complications.
Now, Srinivas, do you have time, or I think we should call it a day?
Yeah, you have shown 2 excellent cases. You wanted something else also?
Well, I have a third case, about 15 minutes if you want. Otherwise, I'll let you go. Either way is okay.
No, thank you, sir, for showing 2 good cases of image-based guidance, and also you showed the technology of IVL. And these tough times, you did a live case.
Can you go on camera? Can you start the camera?
He's going to for the third case?
No. I think I'll just say goodbye to you if I can come on camera.
So last few words, sir. Thank you.
Yeah, okay. Thank you very much, all of you.
Thank you.
Good effort. Thank you. Good night.
Thank you, sir.
Thank you.
Thank you.
Bye-bye.
Thank you. Sir, one small change. We were running little behind, and 2 lectures of the last session are left out. We will have those 2 sessions of lecture of Dr. Sai Satish and Dr. Sanjay Malhotra. Then go on to this session, continue with this session's lecture, sir. All of you will remain the same. They came from that room to this room. So we will just have their first 2 talks. First by Dr. Sai Satish, then Dr. Sanjay Malhotra. Anyway, the chairpersons of the previous session also joined here. Dr. George Joseph, Dr. Samuel Matthew sir was anyway there. So probably we'll go on with the lecture of Dr. Sai Satish. The current landscape, large hole access closure, structural heart perspective, Dr. Sai. I think Sai and Sanjay Malhotra are ready now. Thanks for waiting patiently, because the patient was unstable. They wanted to do the live case immediately. That's why we had to switch. Hope all of our interventional cardiologists, we do agree with this decision, because patient is most important. And we'll go to this talk, sir. Dr. Sai Satish.
Srini, I'm just going to go into the other room, is it?
No, same.
Thank you very much, Dr. Srinivas Kumar and respected chairpersons. I'm going to talk about the vascular closure devices, especially giving importance to the large holes. And the topic given to me is not just close, repair successfully with closure devices, management of femoral arterial closures. We all know that arterial access is very important, because all cases start with an arterial access and the case ends with the arterial closure. And this is the most important portal for us for a therapeutic intervention which we do. It may also be a source of unintended complication and dissatisfaction to your patient after a successful procedure. Now, we all know that if you don't do an optimal stick of a femoral artery where you're trying to use a large device or even a small device, you have a higher risk of complication. For example, if you do a lateral stick, the risk of pseudoaneurysm goes up. And if you do a higher stick, you may end up with a retroperitoneal hematoma. So it's very important that you choose your marks well. And I think some information has already been given on this aspect. So I'm going to skip that and move forward. It is very important that for a large bore access, you need to have either a contralateral access to guide your puncture. And it's very, very important that you do anterior puncture of the artery. Now, some people have started using intravascular ultrasound. I am 100% sure that it requires a reasonable learning curve. And that is why you should start working on the ultrasound, but stick with your fluoro guidance using a pigtail put into the common femoral artery before puncture. This is a very common picture, and all of you have seen this. This is the most commonly used device in cases where we do pre-closure for a larger bore or even for a smaller bore. The other device which is very commonly used but is not available is something called ProStar, and it is enough for one device is enough for 18 French. It actually requires even a larger or a longer learning curve, but it is important that we do some cases to learn our technique, especially with ProGlide, which are not large bore before we start closing the large bore. Because once you become experienced, you do have a reasonable learning curve. Because if you don't do that, you're going to fail the device and you lose interest in it. So that's very, very important that some of those cases where you think that you would be, reducing the procedure and post-procedure complication in patient, you probably should start closing in long angioplasty or complex angioplasties. The ProGlide delivers a knot, and I'm not going to spend time on it. The latch, which is open here, is very important to understand because I'm going to show you some problem with this in one of my cases. Now, in our center, we have started using ProGlide since 2013, and almost all our TEVAR and EVAR procedure we do percutaneously. And of course, nowadays, all the TAVI procedures are done percutaneously using the device. Now, the pre-closure technique, for example, there are certain important aspects of this learning. And most of our patients where we are using technology for large hole access would have a CT angiogram. And it's very important that we, especially in patients who are undergoing a TAVI or TAVR, where femoral access is probably the nemesis of a complication which happens in a patient. Vascular access is the most important complication in all transaortic valve implantation. So you should have a good assessment of the size of the femoral artery, which you can have either with an angiography, but better technique is to understand the CT, because you can also see the presence of calcium, the place where you would puncture, the origin of the inferior epigastric artery, the bifurcation. That is why it's very, very important that one should have an information about the femoral artery on CT. I always do a contralateral femoral puncture to position my pigtail catheter and go right in the middle of it, because that will give you an anterior puncture. Now, in most of the cases, initially, which are more than 20 French, which we have used many of them now, I used to use 3 devices, but now I have changed my technique and I use 2 devices, and if required, put the third one in the end. But it's very important that you don't lose the wire access. Now, most of the TAVI have started using 1 device. And suppose I need another device, I put extra device. But it's very, very important that we do not lose the wire access. Now, the technique is that if you want to put 3, you can put 2 devices on 10 o'clock and 2 o'clock position, where we have done this, and 1 device in a 12 o'clock position. But when you're putting 2 suture as a pre-closure, you should put 10 and 2. And in all large bore devices, it's very important that you don't post-close it. You should pre-close it, because if you post-close it, you may not stay the suture. That's why whenever you are likely to use more than 10 French or 12 French, better try to pre-close it rather than post-close it. So this is a case which are 3 proglides, one in 12 o'clock, one in 2 o'clock, and one at 10 o'clock, and one is 2 o'clock position. And there is a large bore access going. This is a case of a abdominal aortic aneurysm, and you are going to use the other one, which I have used too. But most of the time nowadays, I get away with the 14 French or the 12 French, which is used from the left side with a single device. This is again another case where you have put in the device, which is again abdominal aortic aneurysm, which you are closing. This is again a case which is most likely a TVAR. And this is what you are left with after the completion. But it is very, very important that before you remove the device, you should have a contralateral puncture, especially from the side, which is the smaller size, to see that your flow in the artery is good, the peripheral perfusion is good, there is no obstruction of the flow, and once you are confirmed about it, you can remove the wire. And this is what happens to the patient after 1 month. There is no scar. There is no risk of any post-procedure infection. There is no risk of any lymphocyte formation, and the patient is extremely comfortable. Now, in a recent study, ProGlide came out with ahead of ProStar in vascular closure after a transfemoral TAVR. And this was a Bravo 3 trial where they actually did it in about 800 patients, where they used the ProStar in about 47% patient and 53% patient reduced ProGlide, where the risk of major vascular and the minor complications was actually lesser with ProGlide as compared to the ProStar, and also the risk of acute kidney injury was more with ProStar as compared to ProGlide. Probably the overall mortality is not different, but then ProGlide probably I find it easier. I have no experience of using ProStar, but have been used by many operators who have used it very successfully. And of course, ProStar requires an even larger learning curve. The pre-closure, especially for a larger device, result in shorter procedure time and time to hemostasis, a positive trend towards reducing anesthesia time, blood loss. You don't know how to use in a smaller access and the technique and the experience of using the ProGlide, then you will not be successful in using a larger device. Now here is a patient which I want to show you where we have positioned the pigtail, we have punctured. Now it's very, very important that you pull that pigtail back because you otherwise may catch that pigtail in the ProGlide suture, and I've had it at least once, and after that I was very careful that you can pick up this device. I'm going to show you a quick case where there was a complication. So this is a ProGlide which we are trying to put, and sometimes the ProGlide doesn't go, and it's very important that if it is not going, you increase the dilator sheath's diameter by putting a larger French to make a larger hole and a cleaner hole. Also, it's very important that you use a stiffer wire. So I'm going to change a wire by putting a dilator and then try to put a stiffer wire. Sometimes you can use an 80 centimeter a stiffer wire where you would be able to push it better. Now, here is a patient we are going to do a TAVR, and before we've got the access from the contralateral side, and when I'm trying to put the ProGlide first, it's not going. So what I've done here is that I've actually changed that wire to a stiffer wire and also created a slightly straighter hole in going inside. I can probably run a bit faster, but it's about 30 more seconds left. So we put that sheath now, or the dilator, and use a stiffer wire. So this is the stiffer wire which you're going to advance now. And you now advance your ProGlide over the stiffer wire because then it will track easily. Now, once we put the Proglide in, so I think the video probably is not flowing. Now what happened that this Proglide, once I delivered the Proglide, it didn't deliver and the Proglide latch got stuck there. Now what do you do? And when you try to pull it, actually I have shown that in that video, it will not come out. You have to be very, very sensible, not try to yank it out. Because if you yank it, and people have done it in the past, you will tear the vessel and you can't save the patient. Such patient will have to bring the surgeon in to repair it. And it is very, very difficult for a surgeon to go in at this time to find it's a mess. But we put a contralateral balloon, and I think there is a picture of that. So this was the picture I'll show you. This latch is not coming out. There is obstruction. And so what I did, I put a balloon there. You can see this inflated balloon here so that you obstruct the flow. And this was the reason when we took it out, this Proglide broke at that point. Now I have done about 3,000 cases. This has happened for the first time with me. Of course, you fail the device, but you can always take it out. Now, there is an understanding if the latch is open, when you pull the device, you will tear the vessel. And that will cause a huge tear in the vessel, and the femoral artery will bleed like hell. You will kill the patient. So it's very, very important that you should not force your way in. With the help of the surgeon, it could be taken out, and 2 days later, we completed the procedure. So what are the concerns about using this device? So when you reach the ratio of the device which you're going to use with the femoral artery size, which is about 1:1, you're likely to have complication. Also, in obese patient, the depth of artery is a concern. So what is important is that you make a big stab inside and make sure that the tissue is separated so that you can deliver the knot close to the artery. So it's very important. You can even use an artery forceps to expand the subcutaneous tissue. Make sure that you reach the depth of the artery. Now, what are the advantages of percutaneous suture mediated closure? It parallels the surgical gold standards. It is associated with significantly less blood transfusion, infections, mortality, and shorter length of hospitalization compared to a surgical cup down. Although in a good hand, I think it will not make a difference. Secure repair with pre-tied monofilament suture is a good idea. And you can have a minimal intravascular footprint. That means the healing is much, much better with such devices, especially a pre-closure device using Proglide. It also promotes a good healing, so the re-access is easy. It causes less inflammatory response, and it gives a confidence inside the lab. You can have low access site related complication. It reduces time to hemostasis, ambulation, and discharge. Most of the patients with TAVR or even TEVAR or EVAR nowadays can go home in most of the situation next day because of this comfort. Thank you very much for your attention.
Thank you, Sanjay. It was an excellent lecture. You have covered all the very important points. And can we have the discussion at the end of Sai's lecture also?
Yes, sir. We will do that.
It will be better because both lectures are going to be very similar, addressing the closure devices. Sai, please go ahead.
Hi, sir. Lovely to see you. It's so nice to see all of you again. Hi, Srini.
Hi.
Hi, good evening, everyone. First of all, I'd like to thank the organizers of TCT and Srini for giving me this opportunity. It's always a pleasure to see Dr. Matthew's smiling face on the other side when I start my lecture. So the topic I was given is the structural heart perspective, puncture to perclose best practices. Now I have to say that I come after 4 fabulous lectures. So I'm going to actually fly past some of my slides and try and keep it to perspective as quickly as I can because we have this paucity of time. Ajit covered beautifully the best technique for puncture, and Raj covered the data, and Dr. Chadha covered all the new devices. So here goes a quick overview. Anatomy is everything. Now, we all know that there's been a huge shift in radial approach to PCI and angioplasty, and I can shamelessly tell you right now that I'm a hardcore femoralist. 95% of my cases are femoral, and I'm most comfortable with it. So quickly to go into the details of the common femoral artery, the mean luminal diameter of a common femoral artery is usually between 5 and 7 millimeters in an Indian population. Diabetics and women have smaller CFAs, about 1.5 millimeters smaller and shorter length. 25% of the population has significant common femoral artery atherosclerosis. In spite of all the data, we know a vast majority of people still depend on the skin crease for their punctures, and we do know how unreliable it is. Most of our patients are not how they look on the left, but more on how they look on the right side of the screen. We know what normal anatomy is. Dr. Mehrotra beautifully covered where he would like to hit the artery, so I'm going to fly past this. Again, use a radio-opaque object, try and go on the mid-femoral head. Bony landmark is everything. Do not go below the inguinal ligament, because then compression becomes a nuisance. Complications lead to retroperitoneal hematomas. This is exactly where you want to hit the artery. You have a nice sweet spot, which is above the femoral head, usually between the middle of the artery and the upper 1/3 is what I prefer for structural heart interventions because you're always using large bores. The puncture technique. Most of us are habituated to feel the artery and then take the puncture. There are a few small nuances that are different when it comes to puncturing with structural heart devices because you're normally using much larger devices. So how you have been doing it, that's not how to do it. Your options are traditional needle versus the micropuncture needle, fluoro versus ultrasound guidance. Always, so fluoro guidance. Always use fluoro, do not feel the artery, contralateral puncture first, locate and localize, start approximately 1 inch below on the skin, coaxial to the crossover wire. Always use a crossover wire from the contralateral side. 45-degree angle, and always remove wires and pigtails before firing the perclose like Dr. Mehrotra had mentioned. Quick visual aids to help you sum up what I just mentioned. First, locate and localize, visualize the artery, and puncture coaxial to the artery. Another visual aid, wrong way to puncture, right way to puncture, coaxial to the wire, 1 centimeter below where you want to enter, try and hit the artery on the upper margin of the femoral head. Now, ultrasound guided punctures completely changed my life. Now, you can use fluoro to verify where your sticks are until you get comfortable, trace the artery, first along the long axis, then along the short axis, puncture in short axis. So you always enter the artery anteriorly and not from the side, 1 centimeter above the bifurcation. The sweet spot is as long as you're a centimeter above the bifurcation for these large bore axes, your complication rates are the least. With ultrasound guided access, you can avoid the calcified plaques. Several studies have shown that the primary reason for perclose failure is because you hit calcium. So avoid the calcified plaques, avoid the atheromatous plaques if you can, and fire your percloses. Don't worry about posterior wall plaques. Maintain your 45-degree angle. This is important because if you're too flat, your percloses will take too much tissue and you'll narrow the artery. If you're too vertical, your big device won't cross the vessel. Here's a nice picture to show how a micropuncture needle has been used. I prefer the micropuncture needle for 2 reasons. One, it doesn't have a bevel, so your lacerative damage to the artery wall is very minimal. 2, the tip of the micropuncture needle is highly ultrasound opaque, and you can see it much better. You can see how beautifully the artery is denting to pressure. A clear line of fluid that you see out the artery is a hydrodissection I like to create to move structures away, which gives me a clear path all the way to the artery. Am I going too fast? Dr. Matthew, is it fine, sir?
Absolutely.
Okay. So knowing what to look for can make all the difference between life and death. This was a case that we did at Chennai Apollo. My fellow took the stick, And you can see right here what is happening as the video is playing is, sorry, I'm just trying to get the right pointer. Okay, there we go. So you can see right here, as this video is playing, there's a leak. They have actually punctured the inferior epigastric artery. And this is what is really important, to be able to identify these things before you start the procedure, because you have a 85-year-old man, you've got and look at the way the sheath has gone in. And this is something else that can happen when you start feeling your artery and puncturing it. You move the skin away from the coaxiality of the artery. So you enter the skin somewhere, then find your way to the artery. And when you let all the soft tissue fall, you get a bend like this, which is a disaster for closure devices. So DSA, and more DSA, we located the leak, used a pro-grade catheter, selectively engaged it. It's a beautiful catheter by Terumo, accommodates a 0.21 wire, but I kind of am familiar with the coronary wire. Took a Hilal Cook 2x2 coil, coiled it off, and went on to finish the case. And I want you to look at this image. Can you see how the ProGlide buckles and bends? Now, I've done this very slowly in a controlled manner, that especially when you enter the artery from one side and go in non-planar, this can happen between the hard and the soft part. And unless you know this can happen and you're on fluoro, it can create a whole lot of havoc. So the key here is, when you do this, either keep a wire to support the first part of the entry and turn the ProGlide to the side and slowly move it in under fluoro. And we managed to close that quite effectively. Even on the opposite side, look at the tortuosity, look at the way we turn the ProGlide, enter under fluoro, and even with that much of bend, we got a clean stick. This is just to show you, skin crease does not matter. Look at where the skin crease is, look at where the ProGlide stick is, and even if the ProGlide goes so deep in, don't worry about it. All you got to do is look at the blood, look at the jet, and then you're home free. This is how clean the procedure finished off. Stitching a vessel. This is an interesting case. So this was a structural heart case that we started, took the puncture, it was a clean puncture, finished the puncture. I deployed the first ProGlide, showed it to my associate how to do it, and gave him the second ProGlide. And when he deployed the second ProGlide, he didn't realize how much he was pushing it. And exactly what you saw happen in the first case happened in the second case. The ProGlide bent, the wire bent with it, the ProGlide slipped out of the vessel, the raw wire rented the vessel. There was torrential bleeding. Now at this stage, I could have done two things. I could have tried putting a big sheath into the hole, but I'll never know how much of rent is there, whether it will hold or no, how much is going to bleed. So being the son of an insurance man, the safe thing for me to do was to first secure this hole, gave massive compression on top, took my first ProGlide and closed it tight. The beauty of the ProGlide over the AngioSeal or any other device I've used is the fact that I always have access to the wire. And when I'm doing structural heart cases, I have access to the wire from the same side and the contralateral side. So went in, closed the first ProGlide, then on the wire, first took a dilator and very carefully, without breaking the bent wire, managed to get the dilator in and take the bent wire out, put another new clean wire in, took the dilator out, and then took a second ProGlide and went in the middle of the bleeding and applied the second ProGlide. After I finished the second ProGlide, I got the wire back in and pushed all the way to the bottom of the hole and applied the third ProGlide. My aim was to stitch it 1, 2, 3 in line. After that, the hole was secure. Went on to take a puncture exactly 1 centimeter above, and you can see this view, how you can see the first ProGlide beautifully stitched in, the second ProGlide nicely stitched off with 2. There was 5 ProGlides on this side. The patient did extremely well. That power went beautifully. We managed without a vascular surgery. It's extremely important here to know that your ProGlide is an extremely versatile device, but the key is your comfort, your familiarity, and the number of cases you've done, knowing your technology. So that's why I urge people to first start using it as often as you can. The last case for the evening, extreme obesity, a 61-year-old lady, 5 foot 2 inches, 137 kilos. All our punches are micropuncture. You can see the micropuncture going in. We checked from the contralateral side. The femorals were about 4.95, extremely tough to put the 14 French sheath in. Once the sheath went in, the TAVR went beautifully. It was a bicuspid young lady. The valve is beautiful, no gradient, no leak, but the sheath is stuck. Tug all we could, the sheath wouldn't come out. So look at how careful we are. We are in run 42. Take a normal view, make sure there's no renting, take a DSA, and you don't want to just yank the sheet out because you could avulse the entire intima of the vessel. So pull the sheet out very gingerly. Look at the second image. You can see how it's going down and recoiling up. At every stage, DSA to make sure you've not done anything wrong. And finally, when we take the sheet out, this is what happened. Now do remember, she's 137 kilos. So very quickly from the contralateral side, wired the profunda, and you can see the first wire. It's half inside the vessel and half outside. So I have to access the superficial femoral. Now, no matter what I did, the wire would not go through. Switch to a coronary wire. You can see the balloon mounted coronary wire. You must be wondering, why didn't you use a sheath? I've already dissected the proximal vessel. I've ballooned it, plastered it. I don't want to take any tube down there if I can manage with just a wire, getting a balloon and getting rid of the stenosis. But what happened is I got the wire, got the balloon, opened everything up. Unfortunately, there was a bend in the coronary wire. While yanking the coronary wire out, can you see the coronary wire is bent and broken in the internal iliac? So what do you do now? You have good flow, you have a bent wire. Most of the people in the lab said, look, it's been a long procedure, let's get out. But as usual, I like to leave the cases as pristine and perfect as possible. So went back in, checked to make sure everything was okay. As you can see, I've fired both the percloses. I still have access to the vessel. Went back in, double checked with DSA, took a snare, caught the wire, took it out, and there's TIMI3 flow, hardly any narrowing. And again, in this patient who was 137 kilos, 5 foot 4 inches, when she stood, her belly was below her knees. We managed to take everything out. This was her, that was the hole, and everything was done transcutaneously. This was her at day 1, this was her at day 2. I'm not going to go to the next case because I think I've finished 10 minutes. I'm just going to skip this patient. But this was another TAVR patient where the vessel closed, went in, crossed with the coronary wire, stented it. First, always you try the balloon. If the balloon doesn't keep the vessel open, only then you think of a stent because you try avoiding stents at junctions. The only stent that's approved is the Abbott Vascular's new Supera stent. All other stents are tend to crush. So anyway, we went, finished it. End result was great. All these devices have been covered by my predecessors in their talks, so it's redundant for me to cover these devices. Sorry, I'm flying past these. Just to go to the conclusion. Success starts with your puncture. Ultrasound-guided puncture should be the gold standard. All the complications I've shown you have been before I started ultrasound-guided puncture. Once you start using ultrasound, you can localize, you can avoid plaques, you can get clean punctures, you get clean sticks, you get clean closes. The Perclose is an extremely versatile and dependable device. Practice with transfemoral PCI. Start closing your 6, 7, and 8 French holes. I can't remember the last time I compressed a femoral. We even close veins in our unit with Perclose for our MitraClip cases, which is a 23 French steerable guide catheter. You have to be familiar with peripheral techniques and equipment. Otherwise, just have someone who is with you. You lose nothing by having a colleague with you. Meticulous attention to vascular access and closure is pivotal. Prediction and prevention of vascular complications will separate the boys from the men. With appropriate expertise, transfemoral percutaneous TAVR is possible in over 95% of the cases. Thank you all so much for the patient listening. Sorry I went a minute overboard.
No, thank you.
Thank you.
I think we had a lot of good discussion in the earlier session about the various devices. After these two experts again presenting, people are waiting for this next session talks. Thank you, Sai and Sanjay, for waiting. And any questions come here, I would again disturb you later. But we'll go on to the next session.
Thanks so much.
Thank you.
Thank you. Bye.
Thank you. Hi, Ajit.
Hi, Girish.
Sir.
Good evening. I firstly thank Dr. Srinivas for inviting me to speak on this, glittering platform with all these luminaries. Seeing Dr. Matthew, Dr. Gamir, Dr. Rath, Sai, wonderful. So I'll go straight away to my topic: improving outcomes in left main and bifurcation lesions. This has always been a domain of surgeons that we have invaded. We need to justify what we do. Why left main PCI is challenging or demanding? Because there's a large area at jeopardy when you attempt these. Varying angles of bifurcation makes it complicated. Aortocoronary ostium is difficult to assess pre or post PCI, and osteoproximal LCX is very notorious for restenosis. And suboptimal PCI procedure can be associated with significant complications and occasionally dangerous. The contemporary outcomes of left main trials with first and second generation drug-eluting stents have shown that either in a syntax score, which is low or medium, it is as good, but only the Noble showed that PCI is slightly inferior to bypass because of two reasons. One is increased myocardial infarctions and stroke rates, not really deaths. Probably one of the explanation is about 70 to 80% of the stents in there was provisional stenting, otherwise a single stent strategy, and QLOT was significantly higher. But Excel shows PCI non-inferior, so you have a gain. Why CABG has a definite role for left main by all the guidelines. Why? As I said, it is associated with less myocardial infarction, and it protects against future development of coronary obstructions proximal to the grafting, which does not happen in case of a stenting. Proximal if there's a new lesion that needs to be treated, and that leads to increased revascularization. But PCI has its own advantages. It leads to, it's very less invasive, very short morbidity and hospital stay, and early mental recovery, physical recovery, and rapid return to work. The best way to get most benefits for a patient is to have a heart team approach. I know it's very challenging. Surgeon would always say a bypass, but then we need to cultivate this working as a team and then always calculate a syntax score. If the syntax score is 0 to 22, I think, it's either ways. It's a patient's absolute choice. And PCI, if done well, is non-inferior. When it's between syntax score 23 to 32, I think CABG does come into a picture. You need to discuss with the patient, but in good hands, PCI is definitely not inferior. But once the syntax score crosses 33, I think we should honor and then ask the surgeon to take over if the patient is not suitable, or like an emergency left main PCI, acute myocardial infarction, or a cardiogenic shock, or not suitable for bypass. That's when the PCI comes into the play. The COBIS registry from Korea has shown that single stent strategy is good enough in 70 to 80% of the case, but then you need to justify that by good imaging and understanding the disease. And also COBIS 3 registry said that when you use the second generation stents for two stent strategy, any of the strategies, whether it is DK crush, QLOT, or T, none of them are inferior, but slightly there's a trend towards lowest target lesion failure with DK crush. And I begin with my first case. This is a 67 years old male, unstable angina, good LV function, TMT being positive. He's had a stent. He came from the Middle East. He had a stent from left main to LAD in the past. You can see that there was a damping in the ostium with the even 5 French guide, and there's an ostial stenosis. I will not play the videos. They would take a lot of time. You can have a look at this. The very, very important today is understanding the disease, because disease is in the wall, not in the lumen. And understanding the disease process, that is whether it is lipid rich, fibrotic, or calcium, what is the extent, how thick are the calcium, that determines the success. So here, when you look at this patient, the distal left main is good, well expanded, well endothelialized, but the osteoproximal region, there is quite a bit of fibrotic and lipid rich plaque, hardly any calcium there, and the minimal lumen area was 5.41 millimeter square. And since it was lipid rich, we just dilated once with a NC balloon 4 and then put in a stent, and post dilated with 4.5 followed by 5 millimeter and then did an OCT. You can see here the two pictures before and after. The lumen area was about 5.41 before, and post PCI it is 17.59. And you can see the struts are very well open, no tissue prolapse. So that's a great result. You're reassured that he will do very well. So imaging has a great reassuring power as well as an objectivity to your procedure. Here you can see the last. Many people think we may not be able to visualize coronary ostium from the aorta, but if done well with a short pullback of the OCT, we can visualize the stent right into the aorta even with OCT. The second case that I am showing you is a 60-year-old female presented with acute anteroval MI. And if you just have a look at the angiograms, distal left main, especially in the last plate, you can see on top, there is a lot of haziness. It could be thrombus or calcium. So unless you do an imaging, we may not be able to tell what it is. So we wired both LAD and the OM and then try to do an imaging. I will run through with a co-registration. You can see here, distal LAD has severe calcified lesions. I will slowly go down here. Severely calcified region right from 6 o'clock, more than 180, 200 degrees with a very eccentric lumens. You can see that, and very thin cap. And coming into the LMCA, LAD is pretty calcified. Now, when you come into the left main and the co-registration, you can see that, in the co-registration, it clearly shows that there is huge amount of thrombus. You can see here, there's a lot of thrombus with hardly any lumen. Now, you're dealing with huge amount of thrombus in the distal left main and severely calcified LAD lesion. How would you address it? Trying to do a rota, we may mess it up. So the plan was to survive the day and fight another day. So we just went in. Since the left main did not have much calcification, it was only lipid rich and fibrotic, just stented the left main to LAD single stent strategy and post dilated with 4 and then 5 millimeter stents. And then you can go through the OCT again, just to understand. Here the goal was to get over the acute MI situation. The purpose of OCT is to see that there is no distal left main, distal to the stent, there is no dissections or hematomas. You confirm them. Yeah, that's beautiful. There is some tissue prolapse towards the end and very lipid rich plaques you can see. At the same time, when you come into the left main, it's beautiful. I would like to show you that the ostium of the circumflex is free of thrombus even after doing this. Can you see this at 3 to 5 o'clock position? Between 6 to 9 position, the circumflex seems to be pretty free of disease and thrombus. And this is how it looked. So here, imaging really, if you look at the left main, looks very good, very well opposed stent, big left main, no issues. The imaging helped us to just survive the day, address the thrombus, stabilize the plaque, and then we went ahead after about 4 weeks, addressed the LAD with rotablation. This is the final result of this patient. Good TIMI3 flow, and she preserved her LV function. Trying to do too much could have been risky. Now coming to another patient, 64 years old, preserved LV function, unstable angina, strongly positive TMT. You can see here the distal left main is about 50% deceased. Distal LAD has about 70%, and the OM again has, early OM or ramus has about 70%. The strategy here was patient did not want a surgery. So we went ahead and stented the distal LAD first. in success depends on what we plan before you puncture the patient. So once you've done an angiogram, come back, have a strategy. Speed means the amount of complications. Faster you do, the least complication. So quickly went ahead, stented the distal LAD, came back. We wanted to do a QLOT from left main to OM. We put in a stent. There was little calcium in OM. We knew that. And then went across, did another stent to the LAD. And this is what the final result looks like. And then when you do the OCT again to understand, this is pullback from LAD to left main to know how is the LAD expansion, how is the minimal stent area, are there any unopposed or malopposed areas, and also look at the ostium of the circumflex. These are the purpose of doing the imaging. Here you can see there is bit of a plaque protrusion, very fibrotic but very well expanded stent. Very happy with the stent, the way it looks expanded. Now when we are getting into the bifurcation region, we need to look at here the expansion of the ostium of the LAD and also look at the circumflex. Look at that, between probably 12 o'clock and 4 o'clock. Beautifully open struts across the circumflex, no malopposed segments. And when you come to the LMCA, very, very well opposed stents. It's very, very reassuring. But then when you see proximal, there are some malopposed stent struts. You can see way into the left main. Another reason why I show this is you can see the aorto-ostial space. Can you see that? That is where you can visualize that with OCT. It's not so much difficult. Going to the going forward, then we did a OM to left main pullback just to see how the distal part of the circumflex looks. OM is more calcified than the LAD. There were areas of, under expansion because of what you call calcium. You can see here, right from 7 o'clock to about 12 o'clock, there is calcium. The vessel has not really expanded all that well, but beyond that, it's pretty good. Now, when we come into there is some malopposition here, and then come into there is a circumflex on one side, LAD on the other side, very well opened vessel. So we went ahead, post-dilated to address all these under-expanded left main segments, got a very 5 millimeter NC balloon, very well opposed, and then there was a little bit of calcium. And when you look at in a 3D rendered, you can really look at the ostium, malopposed, non-opposed, everything to make sure that you got the best outcome that can match a bypass surgery. So that is why it is important to understand the disease before and confirm your outcomes with good imaging to match the outcomes of a bypass to give the best to the patient. So learning here is whenever you do a left main PCI, imaging is mandatory, and measure the minimal stent area to get the best that you can, and always address the unopened struts across the ostium and avoid undersizing, malopposition, and tissue prolapse is a bigger challenge. You need to address them. So I think this is where I conclude. Summary, to have the best outcome for a left main, whether single stent or a double stent strategy, a thorough clinical assessment is very, very important, especially the patient selection with syntax and the suitability for a bypass, and clear strategy and communication with supporting staff, because you need to get in, get out the fastest possible with a fixed plan and complete it. And imaging, whether IVUS or OCT, is mandatory to get the best outcome. Physiological assessment, especially for the side branch, we use off late to avoid the second stent strategy if there is not much disease. But post-procedure, if you find pinching or a narrowing, FFR helps you to take a provisional T or not. Following every step systematically, if you don't keep a balloon in the main vessel while you're trying to get an access into the side vessel, you may not ever be able to take a stent. It becomes very messy. That's why when you do a bifurcation, following every step systematically is crucial for LMCA PCI to give you an optimal result. Thank you.
Thank you, Dr. Girish, for covering this aspect very well. You told it in detail and you highlighted the importance of imaging. And when you're competing with surgeons, you have to do the best and give the best outcomes to patients. If the immediate results are good, I think we'll have good results on follow-up. We can have some discussion at the end. We are slightly behind the schedule. We request you to continue to stay. And now there's a lot of new discussions happening on the antiplatelet therapies changing happening. So we thought we'd have one, is the trend for DAP changing? I hope Dr. Rishi Sethi is joined. Dr. Rishi? But initially, for the first few weeks, I think there's no controversy. Still, we all feel that we need to give dual antiplatelet. But actually, gradually, aspirin role is decreasing. And let us hear more about it from Dr. Rishi Sethi. Can you get Rishi? Girish, thanks for excellent lecture. Please.
Yeah. Dr. Srinivas, thank you very much for asking me to join your meeting. And my regards for all the other participants and the faculty members. Well, I was asked to show something with regard to the complex coronary interventions. Since, of course, my heart lies in left main coronary interventions, but for a while I was asked not to speak on left main coronary interventions, which I would do tomorrow. So I picked up some cases of rotablation in unusual conditions, which are unsuitable for coronary artery bypass graft surgery. Well, as we all know that the cardinal indications for rotablation during PCI are calcific stenotic lesions, where you are unable to cross the lesion with smallest size balloon, unable to expand the lesion despite using high pressure balloon inflation. And then, of course, the osteal lesions like left main, RCA, orthocoronary graft, and branch stenosis. Well, these are the accepted indications and advocated by the manufacturers of rotablation. There are labeled contraindications for rotablation, and these include saphenous vein graft, thrombus-containing lesions, visible dissection. Of course, some small dissections you can still do rotablation. Total occlusion with inability to pass the guide wire and highly calcified, very angulated lesions. Well, while these are the labeled contraindications, I will take you around to almost all these which have been treated by me over the past 3 years. The first case is a rotablation where we were unable to cross a severe stenosis in the body of the SVG2OM branch. And this is a 60 years male, non-diabetic, bypass graft surgery in 2009. Lima to LAD was patent, SVG to RCA was occluded, and SVG to OM was severely stenosis. And he presented to us with class 3 angina exertion, ejection fraction of 45%. Now we did his angiogram, and this was his SVG2OM, which is to some extent degenerated, but we thought it's not a very great issue to treat this with a balloon and a stent. So we took an Amplas guiding catheter, hooked it, and you can see that there is a sluggish flow in the saphenous vein graft to OM. And then we passed a wire. We attempted to pass a wire, but to my surprise, we were unable to cross this region. Well, having changed 4 or 5 different kind of wires from the most flexible wires to the stiffest wire, I was unable to get my wire across. And at times I was a bit afraid that I may not perforate this graft. So, but finally, after some struggle, we were able to get a wire across. But the next problem started that we were unable to advance even the smallest size balloon, 1 millimeter balloon across the stenosis. And at this point in time, we started using the guide liner, but nothing would help us in getting this balloon across the stenotic lesion. And as you can see here, the guiding would fall down. And this is the biggest problem in grafts, that you don't get an ideal support that you can get in the native coronary arteries. So at this point in time, I paused for a while since there are not much of literature of rotablation in saphenous vein grafts. So having, attempted this case, so I thought we should not leave it, and I mustered courage to do a rota in this patient. And fortunately, we were now able to pass a rota wire. And once the rota wire was across, then of course, the rest of things became easy. But at the same time, my heart was in my mouth when I pushed the rota across. Fortunately, there was not much a problem. It was a possibly calcified lesion. And the rota went across, and then we stepped up from 1.25 to 1.5, and then did a post-rota balloon, and then put 2 long drug-eluting stents. And having done that, we finally got this the TIMI grade 3 flow, and the graft looked perfectly fine. So this result was very gratifying. And when we looked at the literature, there were only 14 patients with 17 lesions of rotablation in SVG grafts. And the distribution was predominantly in the distal and the stenotic sites. Aorto-osteal were 4. And the body of the SVG there was only 1 out of these 17 lesions, with a procedural success rate of 100%.
And there's one more report of rotablation, a calcified ostial SVG lesion with a long-term follow-up. And this was from an Indian which appeared in the International Journal of Cardiology way back. And he also showed that the ostial lesion, ostial snoring lesion in SVG to LAD was successfully treated with rotablation. Well, I'll now go on to my second presentation, which is rotablation in acute MI. Well, generally it is contraindicated because of the presence of a large amount of thrombus. There is a ruptured unstable plaque with high chance of perforation, significantly higher risk of slow or no reflow. But if there is the underlying calcific stenosis, which is found in almost 8% of patients, well, nothing may help except doing possibly some debulking device in these patients, otherwise the stents would not expand properly. So here I'm going to show you a case of rotor stenting of LAD, including left main bifurcation in the acute phase of myocardial infarction. Now, mind you, this is during the acute phase when the patient came to us with 4 hours of chest pain. This is the electrocardiogram which showed that the patient has got anterior wall MI with RBB and LAHB with ectopics. His blood pressure was 80 millimeters of mercury. The right was totally gone. The left was, you can see that highly calcified left anterior descending artery, which was totally occluded at ostium. The only vessel which was flowing was circumflex and obtuse marginal. So this patient had previously received a pacemaker some 7 years ago. So we immediately wired this LAD and did some post balloon dilatation, and this was the result after balloon dilatation. Well, there was some flow which we could achieve, but it is very clear that there is a lot of calcification in this vessel. And since this patient was on the verge of a very low blood pressure, almost about 80 to 90, so we started some noradrenaline and build up the pressure in the next 10-15 minutes, so beyond 100. And further balloon dilatation was done to see that if we could optimize the results of balloon and then put in a stent, but that was not to be. So there was some improvement in the flow. So we thought we should do a rota in this patient. So we now exchanged the wire with the rota wire. And having done that, we took a 1.25 millimeter bar and ran it across the proximal to mid LAD. And this was followed by a further balloon dilatation using a 3 millimeter. We did not upsize the bar here because of the danger of causing the perforations. And then having done the balloon, now the flow was much better. And then we, of course, this is a post-balloon angiogram where it showed that if you look carefully that there is a mild disease at the ostium circumflex with haziness. Now, since LCX was a very important vessel to him, we were very careful not to leave anything at the origin of the circumflex. So we first deployed stent in the proximal LAD, and you can see here the stent being deployed in the proximal LAD. And then having done that, this was the result following deployment of stent in the LAD. And then we deployed a stent from left main to LCX because there was some pinching of the origin of the circumflex and already there was some haziness. So we did a reverse T here from left main to LCX, deployed a stent, and then did a kissing balloon dilatation. By this time, the patient was stabilizing a little bit. Blood pressure was almost 100 on norepinephrine, and then a POT was done. And this is the final result. The patient was discharged after 5 to 6 days. He had some mild kidney disease, so there was some rise in the creatinine levels, but then they settled down over a period of time. So this showed clearly that rotablation can be done successfully in patients with acute or recent MI. And this is a series of 47 patients with a median duration of follow-up, with a median duration between MI and rotablation was 4 days. This is, none of these patients was attempted during the acute phase of myocardial infarction. 7 of these patients, that means 15% at STEMI, others at non-STEMI. MACE at 30 days was pretty high, at 12 months was 40%, and death was also 21%. But mind you, these are very sick patients, and as you could see in my patient, the only vessel which was working was the LAD. Now, this is the third case, which is a very interesting case, rotablation for a very highly calcified diffuse disease RCA, including instant restenosis and distal bifurcation stenosis. So this was a case which was attempted by one of my colleagues, and I'll show you what was the angiogram. So this was a diabetic patient, obese, highly obese, not hypertensive, had earlier undergone angioplasty with stent of the RCA 10 years ago. He presented with class 4 angina, extremely symptomatic, and he would have a lot of rest pains with mild SST changes in the inferior leads. Ejection fraction was all right, and the left system was almost okay. Now this was his right coronary artery. So one of my colleagues had attempted to pass a wire. He could place the wire, but even the smallest balloon he could not. So he gave it up, and the next day I took up the patient. So you can see here this heavily calcified RCA with severe stenosis in the proximal RCA. The distal vessel is having only TIMI-1 flow. So I tried to use a rota wire, but I was unable to get a rota wire down because of a severely stenotic lesion and secondly heavily calcified vessel. So the rota wire would not take the top. So I tried to push the wire with the help of a rota ablation burr. So I took the burr down up to the proximal part of the RCA and tried to advance the wire, but it would not go. So having realized the difficulty, I thought I need a better support from the guiding catheter. So I then changed on to an Amplas guiding catheter and then could pass the wire, and you can see here on your left hand side here also the wire has gone only a little bit beyond the stenotic areas and the stent which was deployed earlier. And then I took the burr 1.25 and then with the help of burr I removed the friction between the wire and the vessel, and then I could advance the wire a little bit more. And then of course the rest of things became a little simplified. So 1.25 millimeter burr, which could be taken right up to the mid to distal part of the RCA. And this was then treated with a step burr, 1.5 millimeter burr for further debulking. And now you could see that it is a diffusely diseased artery with a lot of ectasias, and I was a little disheartened here having seen that we did so much of on this patient, but even the PDA and PLV were diffusely diseased. So, but we were not willing to leave it at this stage. So this is a post-rota result. You could see here that the distal part of the RCA is a little ectatic, and there is some flow which is now visible in the both PD and PLV, and both are diffusely diseased. So we then started deploying the stents. First we did a balloon dilatation of PD and PLV, and with 2 wires there you can see here. And then having done that, we started deploying stents. So this was a long DES in the distal part of the RCA, and then another stent was deployed in the proximal. I'm not going to show you all of these. And then another stent was taken down from the distal part of the RCA into the PLV. Initially, I thought I would do a mini crush, but the 2 stents would not go. So this was deployment of DS in the PDA. We then recrossed these stents and put a wire in the PDA, and then using a tap technique, we stented the PDA. So this shows that there is a stent in the PD and there is a wire in the PLV, and this was the final result. So after working for almost 2 hours, we were quite satisfied that the result is reasonably good, acceptable, and this has been now followed up for 2 years. The patient is almost asymptomatic. The last case is again a very interesting case of a bifurcation LMCA with a highly calcified diffusely diseased both LAD and LCX. LAD was highly tortuous with severe LV dysfunction. This was a 66 years male. He was hypertensive, hypothyroid, and a history of carcinoma of glottis, operated and had tracheostomy. And he was on chemotherapy. He presented to us with class 4 angina and acute LVF on one of the winter nights. Echo showed a EF of 30% with regional wall motion abnormalities on all sides. So patient was put on decongestive therapy with antiplatelets, antithrombotics, and statins. He stabilized in the next 72 hours. ECG showed T-wave inversion in V1 to V6, and echo showed ejection fraction of 32%, marginal improvement or maybe a slight variation in the operator's assessment. Subsequently, on day 4, we took up the patient when he was a little more stable for a coronary angiography. And this was his coronary angiogram. Now, it was a little frightening angiogram. You can see here there is a heavily calcified distal left main and very tortuous LAD, heavily calcified with diffuse the disease except for the terminal part. Then LCX, OM are all, I need not describe, all are heavily calcified and diseased. RC was a small vessel. So here we are dealing with a patient who had got LMCA with severe calcific two-vessel disease. His syntax score was 39. Well, we offered him that he should go for a bypass graft surgery, but the other, of course, possibilities were coronary intervention and long-term medical therapy. But the patient refused to undergo a bypass graft surgery because he said, I have already had tracheostomy. I don't want to live anymore after having done a bypass surgery. Even the surgical team refused bypass graft surgery because the patient was on chemotherapy. So they were very much hesitant to do a bypass graft surgery. The relatives are also not very inclined for any surgery. They wanted non-surgical treatment. So what were the options? Scoring balloon, certainly no. Cutting balloon, no. Rotational atherectomy was the only treatment which could have saved this patient's life. Orbital atherectomy, we have no experience, and intravascular lithotripsy out of question. So we took up this patient, wired first the LAD, and did a rota right from left vein down up to the distalmost part of the LAD using 1.25 mm burr. And this was followed by a stepped burr, 1.5 mm burr. And after this, we stented the distal part of the LAD with a long stent. This is 38 mm long stent. And having done that, this was a post DES result. We wired also the LCX and put a stent. We did not do a rota here in the LCX.
Gambhir is not seen your pictures.
My pictures are not being seen. Okay, yes. Pictures are not being seen. You can't see my videos?
No, we can't see.
Okay, you can't see. So can you see it now?
No. From the beginning itself, it is not seen.
For this particular last case?
This one, yeah. This case.
Okay, I think then, is it visible now? No.
No.
Okay, so I think this was the last case, but if you can see the final result, it's okay. Otherwise, we stop here. And so this was a gratifying result where we had done a bifurcation left main distal stenting using a mini.
Now we are seeing a fixed image. You can image.
I'll run it. So this is a deployment of DES in the OM. There was some distal dissection which you could see here, the stented with the OM stent. You can see this.
No, it's not seen.
Okay, I'll then show you the final result.
Yeah, finally.
This is the final result. You can see it?
No. You can show the fixed image if it is there because the video is not running.
Okay. This is a fixed image. Can you see it now?
No.
I can't help it then. So anyhow, this is the final result which shows both the vessels, including the left main, absolutely free of any stenotic lesion. So this is the final case which I want to show. So the take-home message is that highly calcified lesions, particularly in diffusely diseased coronary arteries, is always a challenge. Debulking techniques, if required, are often required in these patients, particularly if the calcium is more than 180 degree, length is more than 5 mm, and depth is more than 0.5. We have not done any imaging in all these patients because these cases were done almost about 3-4 years ago. So we didn't have OCT at that time, and I don't know why it was not done. Because most of these cases were done in emergency. Ablation using rotablation, the only available technique to achieve angiographic and clinical success in such cases. IVL, although is a new wave, but with only limited indications and low success rate. So that's out of question. With that, I thank you very much. And I'm sorry for the last few images which you could not see live. I can't hear you.
Dr. Gambhir, beautiful case, and especially the venous SBG graft. Beautiful case, Dr. Gambhir. Can you hear me?
Yeah, I can hear you.
Yeah, it's very interesting. The SBG graft calcification, the one you saw. You all know that it's very rare, very rare. Calcification of the SBG graft.
Yeah.
And could be it's a valve.
Could it be a valve?
Yeah.
No, it was not a valve, because a valve can easily be crossed with a balloon. Here, even a 1 millimeter balloon would not cross. Even the wire was going, almost I had to spend 20-25 minutes using 5-6 different kind of wires. So obviously it was a heavily calcified, where even the wire was not crossing, and the balloon, no chance of, even with the help of a guide liner. So it was I think, calcified lesion, but of course, it could be anything, because we did not have any imaging on this patient.
That's fine. And, all these cases, what you have done, are all diffusely calcified vessels, like that RCA we saw very clearly. And I do not think that IVL catheter, it will be useful in this type of cases. Here you again have to depend on rota, all these cases, because IVL catheter will not go down that much, and they are heavily calcified vessels.
Dr. Rath, that is why I had written IVL, although it's a new wave. There's a lot of enthusiasm, but I am very disheartened, and I don't think that you can use IVL in patients like the one which I have shown here.
Yeah, it's not ideal for diffuse.
It would not go, and here you would possibly need a rota, and then rota followed by IVL if you are interested in spending 2.5 lakhs per catheter, and you may need 3-4 catheters here.
Yeah, that's right. Dr. Matthew, I think next is Dr. Matthew. He has to present his case.
Thank you very much.
Thank you, Dr. Gambhir.
For large lumen vessel, large lumen, especially the left main and
it's more.
Dr. Matthews, one small comment. Yes, I'm not discarding this device, but you see, what I'm trying to say is that for diffusely diseased, heavily calcified vessels like the ones which I have shown,
probably yes,
IVL is not done, but just for focus nosis, and for it could be a replacement for Flextome or for such kind of devices. You first do a rota and at focal place which is not giving way even with rota. Well, certainly you can put IVL over there. Thank you, Matthew, for your comments.
Hello, are you able to hear me, sir? Can make it little more simpler and user friendly. Like now you need a coordination between both hands and the leg. Can we do anything? I think Rotaflex, which they made, I think is slight advancement over this, where you don't need to use your leg. What are your comments on that, sir?
Well, Srinivas, I think I was a party to developing this prototype when it was shown to us in Gurgaon, and I did suggest them a few things, and fortunately they have been able to carry out these things. Firstly, it has obviated the use of your legs in this case. The advancer would have everything over it, and number two, it is electrically operated. You just plug it in, and then the rest of things, motor, etc., moves with the help of not the compressed air, but with the help of a electrical power backup. So it certainly would be an advancement and a very useful advancement over the present device. But I would not be able to make any more comments on this because I have no personal experience of using it as such. Theoretically, it sounds very good. The only thing which I don't know whether they have done as yet it or not, because with the present device, we can't burr more than 60 millimeter of length of the coronary artery. So with that, I told them to increase the window size and in advancer and see that if we can in one go can take it down up to about 90 to 100 millimeters. So I'm not too sure whether they have been able to do it or not. But otherwise, yes, it is a much better option because they do not need a helper.
I think it needs a lot of change to make it user friendly. A futuristic thought is robotic rotameter.
Sir, meanwhile, sir, Matthew sir can share the screen.
Are you able to see my screen?
No, sir, not yet.
Can see your.
Yeah. Good evening, everybody. I was asked to present a case where there is some learning. Let us look at one single case with an isolated ostial circumflex lesion. A 53-year-old male, no major risk factors, very active, and this was the angiogram what we had. The left main appears to be normal. The LAD appears normal. Right coronary artery is non-dominant and normal. Are you able to appreciate an isolated proximal circumflex lesion, a discrete lesion? So one of my colleagues was treating this patient. He decided that one stent would take care of this lesion. This was in 2013. And he went ahead with pre-dilating the circumflex with a wire in the LAD and took one single stent straight away into the circumflex. And this was the end result. A very reasonable result. Left main is fine, LAD is fine, and he did extremely well for quite a few years. In 2016, that is 3 years later, he came back with ISR of the same circumflex. Left main, this time, if you look at the right-hand side panel, there is something which is not very simple. There is something coming up at the distal end of the stent, some disease coming up at the ostium of the LAD, and circumflex has got an instant restenosis starting from the ostium downwards into the OM. And another interesting thing is that you have got a lesion in the. So there is some narrowing seen on the first OM, some narrowing seen into the second OM, and also the posterior circumflex. This is where we are. So What we did is we did an IVUS. Look at the IVUS pictures. Are you able to see this? This is the stent is grossly underdeployed, and the instant restenosis is not just instant restenosis, actually underdeployed stent, what was the main cause of the problem. There is not much of instant restenosis inside the stent. So what is the option? The options are CABG is a very reasonable option with a dominant circumflex. Left main is large, distal vessels are good, no major risk factors. Angioplasty is very unreasonable, but it is doable. If doable, can we get an optimal result equal to that of CABG? That's what we would always look at this kind of patients, where patients' risk to surgery is very low. If we cannot produce what the surgeon can give those patients, then there is no justification in taking those patients for an angioplasty. We discussed with the patient, he was very reluctant to go for surgery. We went back and looked at, if we go for angioplasty, we are dealing with multiple bifurcation. The circumflex to posterior circumflex, circumflex to OM, LMCA to LAD, LAD and circumflex bifurcation. So you have got 3 or 4 bifurcation in a series. Whether we will be able to treat all of them, whether it is safe, whether we can achieve what we are planning. Or just treat the LMCA to circumflex alone, that bifurcation alone, and leave the others, whether that is justifiable. We thought that is not. We should consider doing all of them if we have to treat this patient. Look at it, what we managed to. We managed to get a wire into the circumflex and the distal wire, another wire into the LAD, dilated, did a kissing balloon of those lesions. From the IVUS, we got an additional information was that part of the stent was protruding into the left main across the LAD. So it was very important that we go through the stent into the LAD and pre-dilate that and do a proper kissing balloon. Otherwise, we will end up with various issues. So I came back with Flextome, 2.5 milligrams inside part of the ISR area, and LAD looks better, distal left main looks better, but posterior circumflex is not acceptable. And also the ostium of the first OM is not looking good. So what do we do? Now we have to take care of that also. Wire the posterior. Then what we did is, now that the LAD axis is open, what we did is we got a wire into the posterior circumflex. The LAD wire is there and dilated the posterior circumflex, because that is one vessel we may not be able to get across after we do multiple stenting. That is LAD and circumflex stenting. Of course, the OM has to be stented. Then we may find it very difficult to take care of the circumflex. So we said we will go ahead and dilate that, and with a 2.5 millimeter balloon in the posterior circumflex, as well as the stent was dilated with a 3.5 millimeter balloon. That's what we have done here. And posterior circumflex looks reasonable. There is some narrowing left, but it's okay. But we have a problem with the now ostium of the first OM ostium and the bifurcation of the posterior circumflex to the second OM. So how do we handle that? What we decided, we'll handle it one by one. We treated the ostium of the circumflex with an angiosculp, and another balloon in the circumflex. One wire is already in the LED. The results are reasonable. Both osteas are looking okay. Now we'll have to plan our strategy for the stenting. So what was our plan? We have a stent position into the first OM. We left the LED part for the time being and decided to do a mini crush of the first OM and place a stent across into the second large OM. I'm not neglecting the small OM. So this stent would be right across the posterior circumflex. I took out the wire from the circumflex and we will concentrate on these two vessels. So position, and we have to deploy the circumflex stent, which we did, and the OM stent is being deployed. The circumflex stent is left in position but not deployed, because we have to do that after getting a stent into the left main to LED. Otherwise, if this protrudes, then we will have hindrance from that. This is done. Then what next? Next is get a stent from left main to LED and deploy the circumflex stent. So we are dealing with the second bifurcation, which we have done. The post that we did a kissing balloon into the circumflex and LED and got a reasonable result. So we are handling the left main to LED as well as the circumflex in this section. The looks, shows that both stents are well open as well as the OM stent. Now, what we did, now it's time to worry about the posterior circumflex. We took another wire, go back through the circumflex stent into the posterior circumflex and dilated that. Then bring in a stent, another stent into the posterior with the balloon supporting in the main circumflex vessel. Do that, followed by a kissing balloon there. Then high pressure dilatation in both stents. Optimize the stent. Then the left main is optimized. And this is the final result we get. We reconstructed the circumflex, circumflex to posterior circumflex, circumflex to OM, and circumflex left main LED bifurcation has been achieved. This is the final result we got. These patients, when we deal with such complications, we generally ask them to come back for a follow-up if possible, and we regularly, very religiously follow them up medically with the stress test and other parameters. This is the 18-month follow-up of the same patient in 2017. The non-dominant right, and this is the circumflex left main, LED, and OMs. So, what is the message I have? Any complex lesion can be treated if you logically think and evolve a strategy. Break down the multiple bifurcations and the lesions into simple, independent bifurcations and treat them independently without compromising the subsequent component of the treatment. You have to have the strategies right. Reconstruct the entire sequence of the procedure in your mind and meticulously follow the sequence to attain the good result. This is what I have the message for the youngsters. When you plan any complex bifurcation, any complex case, you have to have your strategies right, think very clearly what you want to achieve, and reconstruct all that and plan your strategy and achieve it. Thank you very much.
Thank you, sir. Excellent demonstration of multiple bifurcations and how to tackle them in detail. And how long the entire procedure took, sir?
I think it was not too long, maybe an hour.
Okay, then that's
What technique you used it?
Yeah,
What is the imaging technique you used in this case? Did you use imaging?
Imaging I use in IVUS.
One thing is this, all of us need to know now, sir, because LCX, that is a big difficult animal. Unless you are forced to, you don't touch it. If you touch it and place the stent there, probably it reached nose and had the plaque extension into left main, into LAD, everywhere, and created a lot of trouble. Had we managed with, this is an interventional discussion, what you did is excellent. I'm just telling retrospectively, had the patient been left on medical management, would she have been all right, or what would have happened? That's altogether not in our scope of discussion. But this LCX, whenever we are handling, I think all of us should understand they should be extremely careful and try to do a good job. I think that we have Dr. Sheshagir Rao sir, Dr. Nick West and others. Any comments from Dr. Sheshagir Rao sir on the case?
No, I just want to comment on your comment on the circumflex ostium. I tend to agree with you and disagree with you. We all used to be commenting on very similarly on the LAD ostial lesions and proximal LADs. We always used to say initial phases of our stenting, those are the ones which gives us trouble. Avoid stenting ostial LADs. When we started tackling it correctly and optimizing with imaging, we started seeing a different result. We started seeing the ostium of the LAD behaves quite well and differently from what we believed it used to be. Circumflex, invariably, we are not using the imaging techniques and we don't optimize the circumflex ostial lesion. So we land up with more restenosis. Once we started imaging very aggressively on circumflex ostium and preparing the lesion properly, debulking the lesion, using of cutting balloon and IVL as well as angiosculpt, and optimizing the stent placement, we have started seeing a different picture. We have started seeing circumflex also starts behaving quite well. Of course, there is a higher restenosis in both osteas, LAD osteas and circumflex ostia, when compared to mid lesions. But I don't think we have time has come to just degrade the circumflex into a situation that we should leave it alone. It is reasonable, quite all right to treat it still. That's what I.
Had the patient for the first time would have done a crossover across LAD, left main to LAD. We don't. Normally LAD, now we're comfortably crossing over ostium treatment and we leave the LCX. But the same thing, it pinches us if you are doing crossover from left main to LCX, unless you're planning a bifurcation technique as such in tackling LAD also. That's what bothers us, sir. That is unlike
that's correct. I mean, each case is different. I don't know what is the Western world thing. Nick has got any comments? Or?
I have to introduce Dr. Nick to all the audience here. He's a chief medical officer for Abbott and he was working interventional cardiologist in UK before. We requested him to come and take his talk, which is important on the evidence-based drug-eluting stent. We also want to know from him whether Abbott is planning anything like this to tackle these osteal lesions or bifurcation lesions after his talk or even now. Dr. Nick, please.
Thank you very much indeed. Can you hear me?
Yeah,
Yes.
we can hear you.
Hour in my hands. I think it would have taken substantially longer to do all of that, and it was a great result. These are very, very tricky lesions. I mean, everyone has said already, when you do left main, anything up in the clockwork, anything up there, the ostium, the LAD, the ostium circumflex, the terminal portion of the left main stem, almost no matter which technique you use, unless you are absolutely meticulous, as you've said, you're going to get restenosis, usually at the ostium of one of those vessels. To answer your question, Dr. Srinivas Kumar, are we planning anything for the ostium? I mean, as you know, there have been some devices that have been dedicated to osteal lesions. I'm not sure if you've used any of them. I have to say, in my practice, this is with my interventional cardiologist from Cambridge practice hat on, I was deeply unimpressed by most of the devices, and they didn't really appear to offer much more than the standard stents we already have. If you have any ideas, perhaps you'd like to sign a non-disclosure and let me know. But at the present time, we don't have any particular plans for, certainly for osteal lesions anyway. And so, similarly, I'll just say about bifurcation lesions. Again, bifurcation lesions in general are kind of a graveyard for interventional devices. I've used many of them when I was a fellow in New Zealand. They were first in man. You may remember the Frontier stent was one of them. There were a whole bunch of these dedicated bifurcation stents, and the vast majority of them didn't really work very well. The only one I felt was of easy utility was the Triton device, but of course the Triton was a bare metal device, and I'm not sure where that's now, but I've not seen it for a while.
Easier to go. I think Dr. Sheshagiri Rao used one stent, Capella stent or something, which is particularly made for ostium. Can you comment on it, sir? It is not available now in our country, I think. Is Dr. Sheshagiri Rao there?
Yeah, he is there.
Yeah.
Unmute yourself, sir.
Unmute. Sheshagiri, your voice is muted.
Yeah, am I audible now?
Yeah. Okay, sir.
Yeah, Dr. Matthews, it's an excellent demonstration of the bifurcation. Actually, we used a Capella device long back when there is only ostium involvement of the side branch. That Capella device is a self-expanding device. But the problem with the Capella was actually it was not a drug-coated device. So it's a non-drug-coated device. The restenosis rates are a little higher. That's the reason why subsequently it has become a little obsolete. So in your case, actually, you did the stenting of the circumflex ostium. So as long as the disease is extending more than 5 millimeters in the circumflex ostium, unless you stent it, restenosis rates will be very high. So of late, what we have been doing is any bifurcation, the side branch ostium, we are optimizing the side branch ostium with a bigger balloon. Here in our technique, actually, we advance the bigger balloon through the main branch stent. The size of the balloon is almost equivalent to the main branch if the side branch is a big one. The conical part of the balloon will extend into the side branch only. So the distal marker of the balloon will be at the main branch stent and the side branch junction. So the only conical part of the balloon will be extending into the side branch so that there will be a conical orifice into the side branch. The flow dynamics would be better. This is side branch optimization technique. So once the strut is adequately disclosed in the main branch stent, so then we are putting a side branch stent joining with the strut of the main branch stent. So that becomes complete bifurcation. So the advantage of this technique is there won't be any excess metal into the main branch. You don't need any crush. Actually, it can be extended as a provisional stenting. So after stenting the main branch, after this displacement of the strut by crossing the main branch stent through the distal strut, so the portion of the main branch stent will be displaced into the side branch ostium. The upper angle of the bifurcation will be covered with that. So later we advance a bigger balloon through the side branch wire. The conical part of the balloon will be extending into the side branch. So it displaces the main branch stent strut fully into the side branch ostium. It covers the side branch upper angle. So then the result is not proper. Then you can go with a side branch stent and finally do a kissing balloon thing. That completes the complete bifurcation. So this is very simpler and very easier. We have done so far almost 56 cases and we are doing follow-up angiograms with this. So the results are very good actually. Only one case we developed some about 40-50% lesion at the side branch ostium. Otherwise all cases after 6 months follow-up they are doing very well with this technique.
This will work when there is only osteal focal disease, not the disease extending into the LCX. Then you anyway need a second stent.
Exactly.
That is why I think distal stent crossing, the youngsters should understand why it is important in provisional stenting. If you cross the strut distally, then probably the strut of the main vessel will again abut on the LCX ostium. That's how they do well. Not that ostial LCX is left without a stent, but it is opposing the main vessel in the main stent, and then the ostium of LCX is also opposed by some of the stents or struts of the main vessel stent. That's a technique why provisional stents do well. But this is optimal only if there is only ostial focal stent of disease of LCX. The disease is LCX extending into the distal portion of LCX. Anyway, you need a second stent. So that's why I think it is. I remembered you saying capella stent. You did live demonstration in one of the TCT meetings before, sir. Thank you for your comments. I think we are running slightly behind the schedule, and people are waiting to hear Dr. Nick West also now. And let us hear from him evidence-based selection of an ideal test for complex PCI. Thank you for agreeing to do this, sir. We contacted multiple cardiology colleagues here, and there were some challenges in making the people give this talk. So finally, we selected you, and we like to hear from you. And then probably in the end, I would like to ask one question to you: whether you are enjoying you enjoyed interventional cardiologist role or the present role. It should be a guideliner for a lot of youngsters here. We'll hear that after your talk. Over to you,
Fabulous.
sir.
Thank you very much indeed. I'll just share my screen.
In the meantime,
is free of disease. I mean, when you have a large roomy left main like this, it is a 5 millimeter left main and at the best 3.25 millimeter circumflex. You a part of one stent or one strut or 1.5 strut protruding into the left main, I don't think it would hinder any of the flow and it will not cause any restenosis. But I mean, these are options. It's totally individualized depending on each case and the angle of the vessel. So many things matters. Of course, your argument is well taken.
Tomorrow we'll have more discussion on the imaging session. PCA optimization, we have a few sessions coming up tomorrow. We can have more discussion on it. So we'll go to last talk of today, Dr. Nick West.
Fabulous. Thank you very much indeed. Can you see my screen?
Yes, sir.
Fabulous. So good evening or good afternoon from where I am in a very unseasonably hot England, unusually. Many thanks to the organisers of ETCT India for inviting me to give this talk. As Dr. Srinivas just mentioned to you, my name is Dr. Nick West. I am the Chief Medical Officer of Abbott Vascular, although until quite recently I was an interventional cardiologist at the Royal Papworth Hospital in Cambridge. These obviously are my disclosures, which is important to make before I give this talk. So my topic for this session is the selection of the ideal drug-eluting stents for complex PCI. So this was the title of an editorial that Dr. Davide Capodanno wrote in Eurointervention last year. Progress with DES. Are we done? Well, I think many of us feel that drug-eluting stents have changed enormously. Certainly they did within my career, and I'm sure that Dr. Matthew and colleagues who've been at this longer than myself will agree that stenting in general, and particularly drug-eluting stents, have evolved enormously since they were first introduced in the early 2000s. But they're not perhaps terminally evolved. And if we look at these 5 areas that were identified as potential focus areas, I think I will discuss some of these. First of all, the failure rate for stents is not 0. There remains, even with current generation designs, an attrition rate in terms of target lesion failure of between 3 and 5% per year. And that's not just in the first year, but year on year thereafter. Secondly, we don't necessarily have the answer to some of the high risk categories, those more prone to in-stent restenosis, like diabetics, like patients with long lesions. We've talked already in this session about calcified lesions and indeed left main stenosis, as well as bifurcations. Of course, we haven't overcome the late issues like neoatherosclerosis, stent fracture, although it's less common these days. One of the hottest topics, of course, is shortened DAPT regimes and the high bleeding risk patient. And finally, and it's odd to be talking about it finally, because it used to be actually the first development, are the technical characteristics in terms of stent delivery and the like. So I'll touch on some of these areas, and I'm going to focus really on data that is contemporary. So I'm not going back into history, but data really from the last couple of years. And so I think it's important to show this, which shows that drug-eluting stents, first of all, are very safe and they're pretty efficacious. This is a trial called the RESET trial. This was presented with 7-year follow-up at TCT 2 years back. What you can see is a comparison of cobalt chromium everolimus-eluting stents, which are Xience stents, against sirolimus-eluting stents, which are Cypher stents. And you can see that there is pretty good efficacy right the way out to 7 years, but we do get year-on-year target lesion failure occurring. So why does this occur? There are all kinds of potential reasons this may occur. It's important also to point out that long-term, we need evidence of safety. This is a registry looking at 10-year data for the Xience stent from Monzino. It's Professor Antonio Bartorelli's center in Italy. And what you can see in this nearly 7,000 patient registry of stable patients is a very low overall stent thrombosis rate. So that's reassuring. We have efficacy and we have safety to a certain degree. But one of the things that people have pointed the finger at for contemporary drug-eluting stents is the persistent presence of a polymer. Maybe it's the polymer that causes these curves to continue to show target lesion failure, and maybe we might be better off without a polymer. Now, I'm sure that most of the audience will be familiar with various polymer-free or bioresorbable polymer stent designs. Certainly the first bioresorbable polymer stents that I used were 10 or 15 years ago in the UK, the Nabori and the Biomatrix initial platforms. But of course, more recently, there are some other stents that have come to market that also have bioresorbable polymer. You can see the sense behind this. You would think that if the polymer was partly responsible for causing restenosis or inflammation in the longer term, if it were to go away, just as the drug often does, maybe that would make things safer and we'd have a more bare metal stent-like result, or even an angioplasty-like result. You can see this. This is the Bioscience trial. This is the Orsiro stent, the biodegradable polymer sirolimus-eluting stent, BPSES in blue, compared with DPEES, which is durable polymer everolimus-eluting stent. That's the Xience stent. You can see at a 5-year follow-up, and these were presented again 2 years ago at the ESC and have been published since, you can see there is no difference. So there appears to be no advantage in using a bioresorbable polymer, which is disappointing from an endothelial biology point of view, as certainly one would have expected benefits, but it does really fit with the data we already have from those other platforms I mentioned, and also large-scale meta-analyses and network analyses. So I do want to touch on the polymer very briefly. I want to give a quick nod to stent design. Stent design we know was important in the bare metal era with studies like IsoStereo and IsoStereo 2 showing the importance of thin strut stents. But really and truly in the current age, there is limited data that shows that thin strut DES are actually more efficacious than thicker strut DES. They're certainly more deliverable if they've got thin struts. There's no question about that. The Limus drugs really have taken over from other drugs, and the ones that are generally used these days are sirolimus, everolimus, and also Biolimus A9 for some platforms. And all of the stent platforms these days have optimized delivery systems. And I think that many interventionists would feel that there is not too much to choose between most stents in terms of their acute performance. But one thing I want to pay attention to, as I've said to you, Xience has a durable polymer, and we haven't changed it, which would appear to be flying in the face of fashion with the current bioresorbable polymer stent design. So why have we stuck with this durable polymer? And we've stuck with it right since the beginning of Xience V. It's one of the few things that has remained exactly the same, along with the drug coating. You can see we've changed the balloon, we've changed the catheter technology, we've changed items of the stent design, although the actual stent composition in terms of the cobalt chromium has remained the same. The drug dose and the PVDF fluoropolymer have remained the same. And I'll explain why. So here's a schematic of a Xience stent. And what happens with this fluorinated copolymer, and it's different to any other stent's durable polymer, is that it enhances binding of albumin. And you may say, well, so what? What difference does that make to me? Well, the fact that albumin binds to the fluorinated copolymer, it facilitates endothelialization and it deters thrombosis from occurring. It stops some of those procoagulant items that circulate in the blood from sticking to the coating of the stent. And you'll note this is not just an abluminal coating, it's a full 360-degree coating to prevent thrombosis. And then that facilitates a safe formation of a neo intima and then endothelialization. So you may say, well, you're just saying that and it's a nice graphic. It is a very nice graphic, but we do have some data that back this up. The albumin binding explains lower platelet adhesion, and there's lots of data that's come from CV-PATH, and you may have seen both Renny Vermani and Alok Finn present these. But albumin binding in an in vitro flow model, you can see below, this is albumin which has been tagged with a green fluorescent marker. You can see that if you run blood through these flow models, you can see the albumin binding on a bunch of different platforms here. Bare metal stent, you get very little binding to metal on its own. Onyx obviously has a durable polymer, or Ciro and Synergy have biodegradable polymers and they get some binding, but Xience gets the greatest binding of albumin. So we show that albumin binds, as I said it did, but what happens then? Well, we know also from these flow models that if you look at platelet adhesion after the albumin has bound, you can see that the Xience stent has the least in the way of platelet adhesion, significantly less. But of course, that is an in vitro flow model. Are there any physical human data that speak to this also? Well, there are. And they come from the Cardio-based study. If you're not familiar with this study, this is a study that was performed in Bern in Switzerland. This is a prospective registry looking at the practice in several hospitals, including INSEL in Bern. And what you can see is with unrestricted use of these stents, with very well matched populations, you can see that out to 1 year, there is very little difference in the final analysis in the outcomes, the primary endpoint of a device-oriented composite outcome. But if you focus on what happens in the very early phase, you can see that there appears to be a significant advantage in terms of occurrence of acute stent thrombosis for a durable polymer stent, the Xience stent, over a biodegradable polymer stent, the Synergy stent. And of course, these numbers iron out somewhat to 12 months, although there is a numerical advantage for Xience, it's no longer statistically significant. So the important takeaways from this study are that there may be some evidence of early thromboresistance, which is good for a durable polymer, and there is certainly no hazard at 12 months for having a durable polymer over a biodegradable polymer. There's another study that speaks also to this, and this was not a Xience. I should add that that previous study was not an Abbott-sponsored study, and nor was this one. This, in fact, was a Boston Scientific-sponsored study. This is the IDEAL left main study. In this study, patients with left main disease who were deemed suitable for left main PCI by the heart team and not necessary candidates for CABG were randomized to PCI to the left main stem with either a biodegradable polymer, platinum chromium everolimus eluting stent, that's the Synergy stent, or a durable or permanent polymer cobalt chromium everolimus eluting stent, that's the Xience stent. Now, the Synergy stents were allowed to have 4 months of dual antiplatelet therapy followed by aspirin monotherapy, whereas the Xience stents continued with 12 months of dual antiplatelet therapy. There was an OCT subgroup analysis, which I won't talk about today, but what I want to talk about is the final outcomes, and this is the 2-year outcome. What you can see here is that although Xience patients continued with 12 months of dual antiplatelet therapy, actually, their long-term outcomes in terms of MACE were numerically better than those with the biodegradable polymer stent with only a shortened DAPT regime. So there's no potential advantage in this very high-risk lesion subset by using a biodegradable polymer stent, because even if you do stop the DAPT early, there is still numerical excessive events. It's important to note that both of them are actually pretty safe. Considering the left main stem, a MACE rate of only approximately 10% at 2 years is actually by no means bad. So I'm going to talk a little bit about short dual antiplatelet therapy regimes, because it is one of the very hot topics. And we're interested in it because what we believe is a key advantage, which is the thromboresistant fluoropolymer. As I've said, this has been throughout the lifespan of the Xience V stent. And I've shown you some preclinical evidence already in terms of albumin absorption and platelet adhesion. I'm not going to talk to some of the older data which you'll be familiar with, like Dr. Palmerini's network meta-analysis and the pooled Xience data published by Dr. Genereux several years ago. I would like to focus on more recent studies that show, which were prospectively designed rather than retrospective analyses, to talk about the benefits of Xience with a shortened DAPT regime. So the first building block, if you like, was the STOP-DAPT trial, which was performed by Kimura Sensei in Japan. And this confirmed that it was pretty safe to terminate dual antiplatelet therapy after 3 months and continue with aspirin alone for patients receiving the Xience stent during percutaneous intervention. You can see that the cumulative incidence of the primary endpoint, which was a combination of cardiovascular death, myocardial infarction, stroke, definite stent thrombosis, and importantly, including bleeding, was only 2.8%, which was pretty reassuring. Building on this study, the STOP-DAPT-2 study, which actually has garnered a lot more attention because I think it is more relevant to today's practice. In this study, again, all patients received the Xience stent, but patients were randomized to either dual antiplatelet therapy for 1 month, followed by clopidogrel monotherapy, or dual antiplatelet therapy with clopidogrel or prasugrel out to 1 month, and then aspirin and clopidogrel out to 12 months and aspirin thereafter. And I won't go into all of the data, but essentially what you can see from this graph, this Kaplan-Meier graph, is that the patients that only were on clopidogrel monotherapy after the mandated 30 days of dual antiplatelet therapy had a lower incidence of the combined cardiovascular and bleeding composite endpoint. And in all honesty, that was driven by bleeding events. You can see that the event rates overall for both arms are low. But it is interesting to see that it is safe to stop aspirin and continue with clopidogrel monotherapy out to 12 months and save those bleeding events. There was a high bleeding risk patient sub-analysis, which shows also similar events, similar outcomes, but slightly higher event rates for both groups, but with an advantage for the clopidogrel monotherapy group. So this is interesting. We also have more data coming, and I would encourage you to join the TCT Connect meeting later this year in a few months' time, where we will be presenting data from our 2 dedicated short DAPT programs, the Xience 90, which is a US prospective single-arm multi-center open-label non-randomized study to evaluate the safety of 3 months of DAPT in high bleeding risk patients, and Xience 28, which took place in Europe, Asia, US, and Canada, with only 28 days of DAPT, again for high bleeding risk patients. I can't share any data with you for the moment, they are embargoed, but those studies are completed and they will present shortly. All the patients in those studies had to have one of those high bleeding risk factors you can see on the left-hand side of the slide. So I hope I've given you a flavor for some of the reasons why we believe that Xience really is the ideal stent for complex PCI. We have a unique polymer. No other platform has the same polymer that we have, although it is durable and it coats the stent completely. I hope I have illustrated why that is a benefit. Stent design perhaps is less important these days. Most stents have thin struts, some have ultra thin struts, but until we get any further data, that remains purely a procedural benefit in terms of acute deployment and does not necessarily impact on long-term patient outcomes, which are more important. I've talked a bit about the short DAPT evidence. I've talked to you about the acute and procedural outcomes and the long-term patient outcomes, and I would emphasize that over 15 million implants have taken place with the Xience stent since the start of the line. So, to address Professor Capodanno's 5 points, I hope that the Xience stent has answered some of these queries. Certainly it goes some way to providing at least a step in the right direction to improve these 5 areas for improvement. So we feel that this is the evidence-based choice for complex PCI. Thank you very much indeed for your attention. Very happy to take any questions or discuss further.
Thank you, sir, for the excellent talk. Obviously, you spoke more in favor of science. We all are quite happy, and we have one complaint with all of you. Is basically you yourself said the more latest versions of Sierra and other things are more trackable, and there's better performance, at least procedural deployment wise. So we wish that you could get that to our country. So we want the best stent for our patients. And though we are very happy with the Xience platform, if something better is there, you seriously consider getting it to our country. And when we were doing trials, Xience was doing trials in Spirit Women or Spirit 4, we were all part of it. Many of the centers were leading recruiters in the world. But now Abbott is sitting pretty. It looks like you have all other companies doing trials for you now. We had Ability, Diabetes trial, and multiple others. So it is other company needs to be very confident to challenge their stent against the Xience platform. Let me tell you. And that's how I think you are generating more and more data. You said 15 million patient data, plus that is very encouraging. And one question I wanted to ask you was, what do you think is there scope for improvement further in your product? You say it is the best, but do you feel there is a scope for improvement there?
I would hesitate. I don't want to be marketing. I wouldn't say it's the best. I would say I think it has very good data. And but I would agree with your comments. I mean, I think that I'm sure that the rest of the panel will agree that there is not much to choose for between most of the major stent companies in terms of acute performance. There's not much to choose. And I agree that if you're several iterations back on the stent platform, there are benefits. There's no question. But the further we go down with improving the balloon and the nose cone of the delivery system and the hydrophilic lubricity of the shaft, or the wrapping of the balloon, the compressing of the stent onto the balloon, there's only a finite amount more that any company can do to make that bit better. And I think whilst having been an interventional cardiologist, we all get obsessed with the procedural element, because clearly you need to finish the procedure, otherwise it's not going to go well. But to my mind, we have very good tools, and I think most of us would agree that all of the companies make pretty good stents. What I think it's important to decouple in our minds is the difference between completing the procedure and actually getting a good long-term outcome, because for many interventionists, the last thing they see from the patient might be them either leaving the cath lab or leaving the hospital for that intervention. And that's great. Most of us can get patients through that, even by doing a not very good intervention. But we've got to think beyond that and think, how are we going to stop the patients coming back in 1 month, 3 months, 6 months, 12 months, 2 years? And that's not all just about the stent, and I understand that, but the stent and some of the things we've heard about in this session, maybe considering use of imaging to optimize stent implantation, whatever kind of imaging you use, it's shown to be beneficial. So I think, we are very focused on the stent as the tool. It's the nail to which we apply the hammer. But of course, there are other things that might make your woodworking a bit better also. So I would say that. Now, you did ask me a question at the end, and I've told you something else first. What was the question at the end? Are we planning to do anything else?
Yeah, what I said is, where do you think there is scope for improvement in this?
I see. Yeah, well, I mean, this is very tricky, and it's something that obviously, we have meetings to try and work out what are the unmet needs, and there are unmet needs. But how many of them actually revolve around the actual stent itself? Clearly, there is a need for stents, and some of the competitors have these with larger nominal diameters. The things like left main, for example, as you know, some of the competitors have stents that you deploy. I mean, okay, you can expand the Xience stent up to whatever it is, legally up to 5.75, but I've made it bigger in my time, and I'm sure many of you have too. But so there's a need for that, because nobody likes to deploy a 3.5 or a 4.0 stent in a 6mm left main and then just sort of hope you're going to get your postal balloon back in to make sure it fits properly. So there's definitely a need for that. You talked a bit about ostial lesions and bifurcation lesions. I think we probably need to turn our attention to not only the large caliber devices to fit left main, but we've got to think about diabetics, I think. Diabetics have a very high restenosis risk. Possibly, you know, thinking slightly sideways, are there other solutions other than just optimizing your initial result for treating in-stent restenosis? There are all kinds of things that we should be focusing on. I think what we've seen with the dual antiplatelet therapy story is, again, just about every stent platform has gathered very similar evidence at this stage for safety for early termination or early attenuation. So I would ask you the same question. I would like to know from you, what is your unmet need, or what do the panel feel the unmet needs are?
Before I go on to the panel, I wanted to mention that we have some challenges in using in bigger size vessels, like what you mentioned, left main. And then probably another scope for improvement is side branch access facility could be improved. And then probably you have some slight challenges, and sometimes, especially when the side branches are challenging. And then the most for youngsters to learn, if somebody asks me, where do you prefer this stent the most? The ostial placement with exactly the stent marker being at the starting of the stent. That's a great advantage for youngsters to learn. I think if you have to precisely position the stent at the ostium, this stent has a great advantage. I think those are the plus and some of the negative things to improve, I said. I have a lot of other senior panelists. I think it's a good opportunity to interact with Dr. Nick West, sir, Dr. Sheshagiri Rao, sir, or Girish, or anybody has any thoughts, you can interact with him. I think you hope you don't mind for another 5 minutes.
That's all.
Okay.
Yeah, you want to know what type of stent, we want? I want a stent which is very flexible like a snake. It changes the shape inside the artery according to the size of the artery. That is what I wish and think.
That is becoming a
We have a lot of things to work, lot.
And let me guess, you'd like it very, very cheap as well, and in unlimited quantities. And
Dr. Rath is becoming very poetic. Corona is making us all feel different things.
No work, Corona.
Anything different? Any question, Dr. Girish or Dr. Sheshagiri Rao, sir? I see Sai Satish continuing. Anybody has any comments or questions to Dr. Nick West?
I had a question to Dr. Nick. Do you think varying amount of drug on a stent for a diabetic or a smaller vessel, would that have any different outcome?
Well, quite possibly. I mean, you may remember, and I can't remember which stent it was. There was a European stent that actually came with a big sort of water bath, that the idea was you were going to be able to customize the amount and type of drug. And I think it was it the Janus stent? I think it was that stent. I don't know what happened to it. It hasn't gone anywhere, but that was exactly the concept, that you could customize to your patient. It's certainly a thought. And whether or not you would just opt for a larger amount of drug, whether you would opt for a longer elution. If you remember the early days of the Endeavour stent, it was always referred to as rather cruelly, and it was a stent I used to use quite a lot of, as DES light, because it eluted the drug so quickly. It was efficacious for a short time, but then there was quite a lot of restenosis. So I think it's not just the amount, but it could be the duration of elution. And the other thing to think about is the concept of maybe using two different drugs that might attack the cell cycle in different places. And I know that, for example, paclitaxel gets a very bad rap these days because of the whole peripheral vascular disease story. But, maybe it wasn't all bad, although it was a cytotoxic drug as opposed to Limus being cytostatic. I think increasing the dose certainly is one thing that we could consider moving forwards for certain aspects, I think, and certainly for in-stent restenosis in diabetics.
Yeah, any other questions?
Printed stents, with the 3D printed technology coming in, is there a possibility that, you do an angiogram, send a CD and get the, right make in about 2 days or 3 days?
I think at the moment you wouldn't get it in 2 or 3 days, but this is very interesting, because this is now, you're now sort of talking to the whole endo space where they customize EVARs and that sort of thing. Now, yes and no is the short answer to that one. It's a bit like buying a suit off the peg or going and getting it made to measure. I think it'll be much more expensive made to measure, but there may be certain circumstances that would be beneficial. Of course, the question then is what we would print it in and how you would print it. But of course it would be possible. The question is whether it could be made scalable and affordable, unless your patients indeed are very, very wealthy, which, some of them may be, but, for the vast majority of patients, they will make do with the stents, I think, that we already have.
Dr.
Maybe I could just...
Ajit, anything?
I was just going to answer very quickly a couple of the questions, a couple of things you asked about the stent. You talked about side branch access and about precision of stenting, and these are very important things. And I think for the interventionists in training who are listening, it's very important to consider that different stent manufacturers place their stents at different points with regard to the marker bands. So, for example, Boston Medtronic, their stent is just inside the marker bands. The Xience stent from Abbott, all Abbott stents, are halfway over the marker bands. And I say halfway, there are tolerances in terms of R&D, but the same holds true for the Medtronic and the Boston ones. They'll be just inside to some degree. So if you're going to have any aspiration to do precision stenting, you must consider which stent platform you're using before you try and do it, because you could miss by 1 or 2 millimeters as a result. The second thing I'll just say very briefly about side branch access. Side branch access is something we get asked about a lot. Now, Xience Sierra, I don't wish to rub salt in the wounds because I know you don't have it, you just said it. It has the largest circular side branch access size that you can get when you expand it. But of course, the size of the side branch access is a very complex thing, and it depends not only on the design of the stent, but the thickness of the struts. So the thinner you make your struts, and the larger you make your cells, effectively, in the cellular design of the stent, it'll be more flexible, and you'll get much better side branch access. But it won't be as strong radially, and you won't get so much tissue coverage. So if you've got a lot of plaque that's kind of hanging around, you won't necessarily be able to avoid plaque protrusion. Of course, the opposite is true. If you've got thick struts and a very closed cell design or small cells, you're going to get great vessel scaffolding, but it won't be deliverable, and it'll be much more difficult to get to the side branches. So all of these things are a trade-off, and you can't have everything. You can't have thin struts and big gaps and great scaffolding and great radial strength. So this is a complex conundrum, and we'd be interested to hear which you think are the key things going forward.
In India, we have a saying in Hindi called "A dil mange more." We always want more for best things for patients. Okay, and I think I got to answer what I asked you. You're enjoying your chief medical officer post as an interventional cardiologist. I think
I'm not sure better. I think it's different, and I think if I can just have 2 seconds, I'll answer that one. You know, I'm finding this absolutely fascinating. It's great to interact with so many physicians around the world. I've learned a lot, and when I see techniques performed at meetings like this, I kind of think, oh, I'll try that next time. Then I think, I'm not doing intervention anymore. I can't try that, which is a bit of a shame because I'm picking up so many more hints and tips. But for me, I think in this role, I have the opportunity to treat in surrogate form many more patients than I could ever treat with my 2 hands. That's my opportunity. And I'm hoping that you and your colleagues are going to help me by giving us some direction as to how we can improve things for your patients.
Thank you, sir. I think if there are no further, sir, go ahead, sir. You can unmute your mic, Seshagir Rao, sir. You unmute your mic.
So Srini, it was lovely being here. I'm going to say bye. Lovely sessions. And more than anything else, it just feels like a breath of fresh air to see familiar faces. Damn wretched COVID.
Tower sessions are there on Sunday. We are having you back. On
I know. I look forward to being back as well.
Okay.
Take care. Bye, Dr. West.
Cheerio.
Yeah, Dr. Seshagir sir was telling something.
Am I audible?
Yes, sir.
Yeah, I can hear you.
Yeah, Dr. Nick, are you going to do anything to strengthen the struts? Of late, we are getting the problem of breakage of struts. Because in 2 cases at pressures of about 15, 18 also, we got strut breakage. So in the process of making strut thinner, this problem may crop up.
Yeah, absolutely. And I think if we think back to when struts were made thinner, if we think back to the first iteration before Synergy, of course, there was the Proma stent, and we used that a lot when I was in Cambridge. And that was the stent that had the biggest incidence of longitudinal stent compression, which is not quite the same, I know, but it's the same kind of issue. The problem is, as you thin the struts down, they lack the same strength. And, you know, the fact that longitudinal compression came in, no one ever thought longitudinal compression would be a problem until it happened because of the thinning of struts. I hear exactly what you say. As you thin the struts down, there would be a risk of breakage. Having said that, usually the risk of fracture is not so much acute. It's more kind of chronic. We saw it a lot with Cypher stents. As you remember, 40% of Cypher stents, incident restenoses, were associated with strut fracture, but they were much thicker, and that was usually because of vessel torsion effect. In terms of the alloys that we use, we can't say they will never fracture, of course, but they have very high tolerances for fracture. And it's only really going to be in certain anatomies, and it's usually going to be where you've got probably the junction between something very hard, like a big calcific rock, and something very soft, where you're going to run that risk. So I'd be interested, if you've seen this, how do you detect it? Because strut fracture can be very tricky, even with OCT, because of the number of slices of OCT you get. You may miss a fracture, even if it's a very localized one. I guess if it's gross, you can see it very easily.
That must be thinking about angiographic appearance.
Angiographic appearance only, yeah.
Wow. Well, the angiographic appearance means you must it must be a very bad. Yeah.
Yes.
Yeah. Anyway, I think discussions will go on, sir. I think we're already slightly late, and this is what encourages me to conduct many such programs. Still, about 700 plus doctors are still there on. And thank you for everybody for your patient hearing and active participation. This is what makes it more interesting. Tomorrow again we'll start at 3 p.m. in the afternoon, goes on till 9 p.m. And you have a second arena started tomorrow to cover up more of the challenging cases. In India, if you ask, there are a lot of young dynamic operators who want to show what they did. So to accommodate all that, we have additional hall, and many more interesting things are yet to be shared. Tomorrow you have India, South Asia sessions where you have interactions from other countries too, like Bangladesh, Myanmar, Sri Lanka, Nepal, and many other countries. And we have Dr. Greg Stone, Ajay Kirtane sharing their experiences on the chip and newer devices coming. And there will be discussion on ischemia trial, and a lot is talked. And Greg Stone, I requested him to analyze and tell about the trial, how it is relevant to day-to-day clinical practice. And there will be also discussion on FMR, DMR, mitral annular reduction therapies by him, and a lot of interesting things to come up. So I request all of you to log in at 2:45 and 10 to 3, and Dr. Rath will be sharing his experiences from Apollo, either if possible live or live in a box cases. There will be other 2-3 live cases coming up from DCFC Kochi, and also Eternal Hospital Jaipur, where a lot of interesting cases are being done in spite of all the COVID times. Thank you all for your patient hearing and participating, and we wish we should continue, but we'll have more discussions tomorrow. Thank you, and we'll all close the session for today. Any other point which I wanted to mention before we close is interesting scientific exhibition is created. Whenever you find time, this will be active tonight or tomorrow morning. You can log in and sail through our platform, and probably you should do some justice to our interventional sponsor colleagues, where there's VCD, the occlusion devices, and other 3D animations, and the important information on the various stent products, all that are kept in the stalls, and you go there and click there and you get all the information. With this, I think I close, and thank you very much.
Thank you.
Thank you.